Good morning. Is this on? Oh, yeah, it is on. Okay. Hi, everybody. Welcome to our first in-person hearing in, like 18 months. It's amazing. So I am Senator Rachel May. I am the chair of the Senate Aging Committee, and I am thrilled to welcome everybody here to this hearing on workforce challenges in long-term care settings, including nursing homes, assisted living sites, and in-home care settings. I am joined by my colleagues, Gustavo Rivera, chair of Senate Health Committee, and Jessica Ramos, the chair of the Senate Labor Committee. And as of now, by two additional senators, Senator Borrello and Senator Serino, who are both on the Aging Committee as well. Today's hearing will be an opportunity for us to hear from providers of long-term care, both institutions and the care workers themselves, as well as many who have dedicated their efforts to understanding and improving long-term care in New York State. Anyone with even a glancing familiarity with this issue knows there is a crisis in our state. Critical shortages of workers plagued the home care and nursing care industries well before the pandemic, and the situation only got worse under the pressures of COVID-19, from the need for infection control to the closing of child care facilities and the health toll the virus took on healthcare workers themselves. At the same time, New York also dealt this sector a blow by cutting Medicaid allocations, and just this month, by raising the minimum wage upstate for fast food workers, but not for home care workers. We know there is a crisis. We are deeply grateful to everyone coming forward today who is trying to solve it. We want to learn from you about anything you have tried that works, any unnecessary barriers you face to providing excellent care, and about any measures we can take to improve recruitment and retention of this critical workforce. Before I give my colleagues an opportunity to say a few opening words, I'd like to go over some housekeeping items and also thank those who helped to organize and coordinate this effort, including Senate events staff and my staff, Zach Zeliff, Kristen Williams, and Eric Vandervoort, and particularly my aging policy director, Ingrid Gonzalez-McCurdy, who just joined our team in March and has jumped in with both feet to make this hearing a success. Those testifying today have been grouped on small panels and are listed on the witness list, which is available at the back table. I'm not sure where, but somewhere you can find it in this room. We will call witnesses down by panel. We encourage them to keep their remarks brief with an absolute limit of 5 minutes so that we can have time for questions. We have many people expecting to testify and expect a full day. We'll hear testimony from now until noon, and then we'll take a break and return for the second part of the hearing. Written testimony that has been shared to our offices will be added to the archived hearing event on the Senate website and should be available for public viewing soon after the hearing. Today's hearing is also being live streamed on the nysenate.gov website. I will now turn it over to our health chair, Senator Gustavo Rivera. While he does that, let me ask the first panel to come down and get settled. If you know who you are, that's Megan Parker, Dora Fisher, Jim Clancy, and Lisa Newcomb.
Thank you, Senator May. I will be very brief. Thank you for being here. It is a pleasure to actually see people in person again, and I'm hoping that this means that we will be doing these going forward. I'm looking forward to hearing from everyone today. We understand the great pressure that workers in the healthcare field, particularly in these types of settings, have under normal circumstances, and the pandemic only made it worse. So I'm certainly looking forward to all the input that we will have today. And we have a long one since we have two hearings back to back. I'm here to back up my two colleagues. Very happy to be back here and looking forward to what the day will bring. Thank you, Senator May.
Good morning, everybody. Buenos dias. My name is Jessica Ramos. I am the New York State Senator representing District 13 in Queens. I also have the honor of chairing the Labor Committee in the New York State Senate. I'm very excited about today's hearing because I think by and large there is a societal indifference to a workforce that is largely Black Latino women, and who are often taken advantage of and are paid low wages and very often lack dignity on the job. So I'm eager to hear stories from both the industry, from workers, and from everyone who will be testifying today, just about the lack of investment that our state has made in long-term care, in assisted living, in our nursing homes for certain. I think we can all agree that the pandemic really peeled back the onion layer by layer, showing us just how much work there is to do in this sector, so that everyone can be taken care of in a better way. You know, as probably one of the youngest senators, I very much care about how my parents and the rest of their generation will be taken care of as more of our baby boomers age day by day, and hopefully establishing a better standard by the time we reach that stage. And that's, I think, what this is really about, making sure that New Yorkers, generation after generation, feel taken care of, and that the workforce, those who are caring for us, are paid living wages and treated with dignity and respect on the job. I want to thank my colleagues for co-chairing this hearing with me, and I want to thank all of the Senate staff and my legislative director, Nathan Berger, who's here with me today. Thank you.
Thank you, Senator Ramos, for making us baby boomers feel ourselves aging day by day.
I love you guys. I love you.
We have the ranking member of the Aging Committee here, Senator Serino, who would like to say a few words.
Thank you very much, Senator May.
Oh, we're back to the microphone's not necessarily working. Oh, memories.
This one, this one's working.
Yeah.
Okay, and we'll just leave this on. So I just want to say thank you, Senator May and senators, for having this hearing today. You know, as we all know, the workforce shortage that we're seeing across the care continuum is a public health emergency, and we know it's only getting worse as our population ages. And I've heard from too many neighbors who cannot access quality care simply because of a lack of staff, both in home care and residential healthcare settings. So I'm really looking forward to hearing from the witnesses today. I think it's going to be a great day. And I just had a question. I don't see the Department of Health on our list. Were they invited today? Do you know?
I don't remember. I don't think they were invited. We decided that this was really about hearing solutions coming from outside the department so that we could give a report to the department.
Because they just have such a huge part to play in this. I'm just kind of surprised that they're not here with us today. A little disappointing, but thank you. That's all. I look forward to hearing from everyone today.
Senator Borrello, do you want to say a few words?
Sure. First of all, I want to say thank you very much for having this hearing. I'd like to thank my colleagues for this. I think this is an incredibly important issue. You know, I represent some of the most rural areas of New York State. We already have staffing shortages, and we have an administration that has, for 9 years in a row, cut Medicaid reimbursements. So we're asking for more pay for employees, which they deserve, while we're cutting reimbursements. We have already seen the impact of that, and we are going to continue to see that if we don't address this issue and understand the cause and effect. Things don't happen in a vacuum. And I'm hopeful that this panel will shed some light on the real challenges. The people that are caring for our most vulnerable citizens need our support. We saw cuts to Medicaid reimbursements while we had massive increases in a budget that was a record-breaking $215 billion. And yet we cannot support our most vulnerable citizens and the people that care for them. So I look forward to hearing from you and what solutions we may be able to come up with to help you rather than hinder you, because right now the state's mostly in the hindering business and not in the helping business when it comes to caring for our most vulnerable citizens. Thank you.
All right, thank you. With that, we will start with our first panel, and I will let you introduce yourselves. So beginning with Megan Parker.
Is this on?
Yes.
Okay, great. Good morning. Hi, my name is Megan Parker. Thank you for the opportunity to testify here today on behalf of the New York Association on Independent Living, or NILE. And thank you for squeezing me in at the beginning of the hearing so I could testify. I appreciate it. NILE and our member independent living centers provide an array of services that help people to live as independently as possible in the community and to transition them from nursing homes. At the statewide level, NILE coordinates a couple of programs, including the Money Follows the Person-funded Open Doors program, which staffs a team of transition specialists across the state that actually go into nursing homes and help people transition back into the community. We also coordinate the Olmsted Housing Subsidy and Rapid Transition Program, two rental subsidy programs that help people leave institutions and provide them with supportive services and assistance with locating accessible housing. And what I keep hearing from people who run these programs and people across the state is more and more, increasingly they work with people, they line them up with all the necessary supports and services they need to transition. They actually find them an accessible apartment in the community, no easy feat, have a lease and everything, and then people are unable to leave because they cannot line up home care. So, independent living centers have been helping people for a long time transition from nursing homes, and there has long been a shortage in certain regions of the state in getting home care, but in recent years, it has really increased dramatically so that it's now an acute crisis from Long Island to Buffalo, with no regions in between really avoiding this crisis. There are a number of ways in which this is problematic, including the state having an obligation under the Supreme Court's 1999 Olmsted v. LC decision, which affirmed that people with disabilities and seniors have the right to live and receive services in the most integrated setting, their home communities. And of course, being able to access home care is a necessary component of that. And so this crisis has only increased. And in my written testimony, I do go through various ways in which people who provide the services outline that they used to be able to use to help get the harder to serve people out of institutions and access home care, including they used to sometimes, for harder to serve people, be able to access like an enhanced rate. So for example, if someone lived in a rural area and they had trouble getting home care workers to come out, MLTCs might approve an enhanced rate to serve that person, but that really no longer exists. The problem's too widespread. I don't have time to go into all the barriers, but we're also seeing a much heavier burden being put on family members to be backups, as there are no available home care workers to show up in the inevitable event that someone doesn't show up for their shift. And we're finding more and more that when people apply for traditional home care, they are told that they're either going to have to wait months and months to get home care or go into the Consumer Directed Personal Assistance Program, CDPA, basically shifting the responsibility to consumers to find and recruit their own aides. And this is not an appropriate option for everybody. And the longer somebody's in an institution, the more isolated they become, and so they really don't have the same community supports. And of course, CDPA really is a program that kind of relies heavily on family members who are willing to provide these services for the paltry wages provided. And so it becomes a barrier, especially the longer someone's in, to them being able to transition back out. This wasn't always the case. Back in 2006, home care workers earned about 150% of minimum wage, and this was a time when it was much easier to locate home care workers. It was much more readily available, but in recent years, as the minimum wage has gone up, as has wages in other sectors, home care workers now make minimum wage, and as Senator May rightly pointed out at the beginning, as of this month, in all the counties north and west of Westchester, home care workers make $2.50 less an hour than they would make if they were working in a fast food restaurant, which is only going to compound this crisis because, of course, providing home care is physically and emotionally demanding work. And why would somebody keep doing it if they could have a much less stressful job and make significantly more an hour doing something else, like working at a fast food restaurant?
Parker, I need to interrupt you because you're at your 5-minute limit. Can you wrap up?
Okay, let me just wrap up real quick and say that the answer to the crisis is to enact the Fair Pay for Home Care Act that Senator May introduced earlier this year, and thank you for your leadership on that. It would increase wages to 150% of minimum wage and take care of the home care crisis over the next few years. My testimony does outline a recent CUNY report that goes into the economic development benefits of passing Fair Pay for Home Care, as well as how it would address the crisis. This is a desperate situation. People with disabilities are not able to access home care, and we just really implore you to take action in the upcoming budget and pass Fair Pay for Home Care so people are able to access home care in the community. So thank you.
Thank you. And just as one more housekeeping matter, I believe the witnesses there is a clock that is visible from this table, but we can't see it. So Zach will hold up his hand when 5 minutes are up so that we can know as well. But thank you so much for your testimony.
Thank you.
And we have Dora Fisher next.
Hi, good morning, Senator. My name is Jim Clancy. We're together.
Oh, okay.
We're both representing Haney's, so that's okay. I'll start.
That's fine.
Your microphone, sir?
The mic is on?
Yes.
The mic is on. Good morning, Chairs May, Rivera, Ramos, and the committee members. Really appreciate this opportunity here this morning. I'm Jim Clancy, Senior Vice President for State Policy at the Healthcare Association of New York State, representing not-for-profit hospitals, health systems, and post-acute care providers across New York. I'm joined with my colleague, Dora Fisher here, the Director of Post-Acute and Continuing Care Services for Haney's. Again, thank you for this opportunity. Recruiting and retaining a robust long-term care workforce in New York has been a challenge for many years. Those who become long-term care providers desire to provide compassionate, quality care. However, the physical and psychological demands, coupled with financial limitations, can inhibit career growth and drive high turnover. The COVID-19 pandemic has certainly exacerbated that problem. Staff turnover in nursing homes had reached alarming heights long before the pandemic, with average turnover rates in 2017-18 nearing 94%. Earlier this year, the state enacted several measures aimed at staffing in nursing homes. These include mandated that nursing homes direct a minimum of 70% of their revenue toward direct resident care and maintain an average of at least 3.5 hours of nursing care resident per day. These new policies do not address the underlying issue of chronic Medicaid underfunding, which is the primary driver and root cause of long-term care workforce challenges, including shortages and high turnover rates. Over 70% of New York's nursing home resident care is paid for through Medicaid, which currently reimburses hospitals and their long-term care providers an average of 67 cents per dollar spent on care. According to a recent analysis conducted by Hanson Hunter and Company, the nursing home Medicaid shortfall in New York State totals $64 per resident per day. When annualized, that Medicaid shortfall for New York's nursing homes totaled an estimated $1.5 billion in 2017. Roughly 2/3 of New York's public and not-for-profit nursing homes deliver care on negative operating margins. The median operating margin of these homes is negative 2.9%. To make matters worse, the current fiscal year's enacted state budget estimated 200 million nursing home Medicaid rate reduction, on top of a 1.5% across-the-board Medicaid cut the year before. Haney's is committed to working with state government and all healthcare stakeholders as we pursue our common goal, ensuring nursing homes are able to provide the highest quality of care and support a first-rate workforce. Toward that aim, Haney's recommends the following actions to ensure nursing homes are equipped to address the state's long-term care workforce challenges and maintain a continued access to high-quality, safe nursing home care. First, enhance Medicaid reimbursement paid to nursing homes to cover full cost of staffing. Delivering quality care and maintaining adequate staffing levels starts with ensuring nursing homes have the necessary resources to cover the full cost of recruiting, training, and retaining staff. Second, support workforce training programs and career ladders. Workforce training programs are critical to increasing recruitment, ensuring staff can meet the needs of the population, increasing the number of individuals who are likely to pursue careers in healthcare, and building skills for those who have already begun work in healthcare. The career ladder is an important piece of building and retaining a quality long-term care workforce. These pathways must be reinforced and supported to enable staff to grow professionally and ensure nursing homes can retain their high-quality staff. 3, support apprenticeship programs and other innovative workforce models. Apprenticeship programs have proven successful in New York State, where workers receive a combination of classroom and on-the-job training, as well as receiving college credits centered on nursing home life. Haney's recommends state support to enable the development of additional apprenticeship opportunities across the state through the 1115 Medicaid waiver, the Department of Labor, or other programs. And 4, advanced regulatory relief. We encourage the Department of Health and the legislature to make permanent key COVID-19 executive order flexibilities and to further streamline regulatory requirements for long-term care providers, which would enable nursing home administrators, clinical staff, and other members of the care team to spend their time where it matters most, delivering resident care. In conclusion, Haney's, on behalf of all of our members, thanks you for providing the opportunity to address this urgent matter. We appreciate the support of the legislature and look forward to continuing the progress we have all made together. Thank you.
Thank you. And do you wish to testify in addition, Ms. Fisher?
Did you want to say anything, Laura?
Yes, absolutely. As the Director of Long-Term Care for Haney's, I speak to our nursing home administrators daily, and I hear how passionately they care about the work that they do, providing care to those who society has forgotten, frail, vulnerable older adults. Our members provide care in both urban and rural settings that, with high levels of poverty. Across the state, 1/3 of older adults are at or near the poverty level, which means that our members rely on Medicaid reimbursement rates. And frankly, it is getting very hard for them to maintain and retain staff. And thank you very much for this opportunity to speak.
Thank you. And finally, Lisa Newcomb.
Good morning, Senators, and thank you for this opportunity. I'm Lisa Newcomb, Executive Director of the Empire State Association of Assisted Living, and we represent more than 300 licensed adult homes, enriched housing programs, assisted living residences, and assisted living programs across the state, serving more than 30,000 frail elderly seniors. Our members include self-pay, sometimes referred to in this industry as private pay, and I'll have a note on that in a moment. Others serve residents that have little or no income by way of a moribund supplemental security income or SSI payment. And some also have served SSI and also have the assisted living program, which is a Medicaid daily rate add-on for licensed home care services. Back to that note on self-pay, when it comes to assisted living, I think that there's a perception that the residents living in some of these higher end, are extremely wealthy with, endless funds, but the overwhelming majority of people that are self-pay have limited incomes. They are paying from their pensions and from their life savings, and they are the most price sensitive. When costs have to be passed along to them. So I just want to, speak for those middle people because there's a lot of them out there. And in the last 10 years or more, both the SSI and the ALP rates have remained unchanged. I cited my testimony report from PHI titled Federal Policy Priorities for the Direct Care Workforce. Just some quick stats from 2019 to 2029. There will be 7.4 million job openings, 6.9 million of those are due to workers transferring to other occupations or exiting the workforce entirely. 87% are women, 59% are people of color, and 27% are immigrants. It's fair to say that the recruitment and retention strategies that worked in the past are nowhere near as effective now. Getting and keeping staff is by far the biggest challenge in our industry, and it's important to note that assisted livings can't close. We are a 24/7 business, so strategies to close for a day or two to give staff a break are not ones that we can employ. I polled members and got a very large response, and asked one question: what is the number one most important action that government can take to increase workforce availability? The overwhelming majority of respondents said that without additional financial resources, they cannot compete with the continued expanded unemployment benefits and other government subsidies that incentivize workers to stay at home. So some solutions to that problem: provide financial resources for wage subsidies, use tax credits based on length of employment to incentivize them to come and stay in assisted living, offer loan forgiveness for nurses based on length of employment, provide transportation incentives such as half fare cards, better patrol the person collecting unemployment and the point is to incentivize people to work and not to work. The New York State spending plan for the implementation of the American Rescue Plan of 2021 with regard to the HCBS funding, because the state's plan is directed at programs that are an MLTC benefit, no assisted livings, no ACFs, not even our Medicaid funded out, are targeted to get 1 penny of that. And that includes $623 million directed to the long-term care workforce for recruitment and retention, and even to pay for PPE. So we are completely shut out of all of that funding. And we are a huge and growing part of the long-term care industry, and it's incredulous that there is no funding proposed as part of that plan for us. So we asked during the next set of budget negotiations to support and promote an adjustment to our ALP rate as well as our SSI funding. And we implore the department to direct some of these ARP funds to our residents. Just some other quick recommendations. Immigration reform, again, 27% of direct care workforce are immigrants. Federal legislation to develop a new visa classification for non-seasonal, non-agricultural workers for jobs that don't require a college degree. Any initiatives like this could significantly expand the pool. I don't know how much you can do of that at the state level, but to the extent that you can. Training reform, this is nuanced, but allow our enhanced assisted living residences, which provide aging in place, to be able to operate home health aid training programs. There's an extreme shortage of training programs for certified home health aides and personal care aides. And those that do exist only really want to train their own employees because they have a hard time too finding assistance. So it makes it difficult for our enhanced assisted living residences to obtain training. A couple of other little things: allow use of equal for staff benefits. Right now, there's these approximately $6 million that you provide to those ACFs that serve the indigent cannot be used for staff for staffing. Employee bonuses beyond their regular pay should be an acceptable use of these funds. And then, of course, in the long term, a long-term care educational track very early on, beginning in high school. Thank you.
Okay, thank you. So the way this will work is the chairs have 10 minutes for questioning and everyone else has 5, but I want to say we have a very long list of witnesses for the day, so we should not feel that we have to use all of that time. I would like to direct a few questions to these providers because I'm wondering what you have experienced in the way of turnover rates in staffing and what that costs the providers, the actual institutions, when staff turns over. Do you have a sense of the cost of turnover?
I can just say, in the testimony, we have, based on numbers from 2017 to 2018, about 94% turnover.
94% are
turnover rate.
Every year?
In 2017. 2017, 2018. So it's a little dated right now, but I can't imagine that those numbers are going to get better. I'm sorry.
No, I mean, I think that we do have some members, that, particularly those that serve SSI, that experience that kind of turnover as well. I think right now, our bigger problem is actually recruiting and getting them hired. Retention is the responsibility of the employer, and, if you're a good employer, you can hopefully not lose them to McDonald's. But the recruitment, just because they're not there or they're not willing to do the work, that's the issue.
And we are losing them to McDonald's, right?
Is there any effort to determine what the main cause is for people to leave? Do you do exit interviews or that kind of thing?
I can speak to this. Ageism is endemic to our society, and these days you can get a job at Walmart stocking shelves for about the same price, for about the same wages that you can get in a nursing home. And nursing home work is incredibly grueling. Even if people are excited about aging, excited about older adults, it's still pretty hard to swallow toileting, grooming, all of that kind of work when you can just work at Walmart for the same amount of money, or Dunkin' Donuts. I think one of the things that Jim highlighted in his testimony is the need for apprenticeship and career ladder programs, because the key difference between a job at McDonald's and a job at a nursing home should be a career, that you are beginning a career. And so we believe that we need to build that infrastructure.
And if I could add, at the managerial level, I think lack of support from the state health department really drives some of our best administrators, executive directors out of the business.
I'm sorry, say that again. What was
The lack of support from the New York State, from the Department of Health, from their regulating agency.
Okay. So I know I've heard from many nursing home administrators that there were a lot of regulatory requirements as a result of the pandemic, of counting PPE on a daily basis and a lot of reporting requirements. Have any of those been eased, or do you still have major staffing requirements for reporting?
Well, I can't speak to nursing homes.
I would just say that there have been some incremental reduction in mandated reporting for the nursing homes and hospitals, but not enough. We need to do more working with the state every day to try and get that reduced.
Are there specific things you want to ask us to help
Sure,
with?
we'd like to have HERDS reporting. Right now, the hospitals and nursing homes have to report to HERDS on a daily basis. I'm not sure that that's needed, and maybe have that reduced to a few days a week.
Okay.
But happy to talk to you about specifics after this, Senator.
And then my last question is about staffing agencies. So I know that there are a lot of kind of temp nurses and temp healthcare staff in hospitals. Do nursing homes make use of that? And how does that, what kind of wages do they command? How does that affect your bottom line and the quality of care?
Expensive, very expensive. And depending on where you are, there's either little access in rural areas or tremendous competition in more populated areas for that same staff person. So prices fluctuate for that reason.
Okay.
Sorry, George.
I guess that's all I have right now. Senator Rivera? Senator Ramos? He's deferring to you.
Okay, well, thank you, Senator Rivera. My notes are all over the place, to be honest with you, so bear with me, because it's really unconscionable how high the turnover rate, how big the shortage is in this industry. And so I'm wondering what type of support for workforce training exists now, perhaps provided by your organizations, perhaps provided by the state health department. What's out there now, if anything?
Nothing directly for assisted living.
Nothing directly for assisted living or for nursing home care?
Well, I can't speak for nursing homes. I represent only assisted living
Right, right.
facilities.
I'm also wondering how many of your member homes or the agencies that are members of your organizations have workforces that are represented by a union. What is the union density among your member organizations or nursing homes or assisted living homes?
In assisted living, it's a small percentage, mostly in New York City, but there are some upstate as well, but most of the industry is not unionized.
I, of course, would argue that that's also a big reason why wages aren't very high. It's not only the state's duty and responsibility to raise the minimum wage, in my humble opinion, pegging it to inflation, but of course, collective bargaining agreements actually allow for workers to see incremental wages and hopefully improvements in terms of health and safety as well.
I'd say two things to that. When it comes to SSI, they're not interested because there's no funding there for them to get for their workers because it is so underfunded that there's no real opportunity there. On the higher end of assisted living, many of them do pay, very, very fair wages. And some have, there have been discussions of unions and the workers have voted no. That's not to say, there are some, that have unions and they work well, but for the indigent, there's no money in it for anyone.
Well, do any of the employers hold captive audience meetings in order to dissuade the workers from organizing into a union?
Not that I have ever heard. It's the unions are just not actively pursuing.
Mm-hmm.
Senator, just real quick, just to go back to your first question about other programs. Right now, again, it's in our full testimony. I didn't mention it in my comments, but there are apprenticeship programs now in the state, run through the district program and also through the Staten Island Performing Provider System. That I mentioned the mentoring and the college credits. So there are models out there that work.
That work.
So, yeah.
That was going to be my follow-up.
Yeah.
Well, how successful
Yeah.
actually are they?
So they work, but we need to expand on that. We need to
But they're
make sure
not
we have a
enough.
lot of resources put into those programs so that we can expand that.
Sure, yeah. I keep thinking, and I said this in my opening remarks, by and large, this workforce is comprised of women of color, more often than not single moms, like myself, and the rising cost of living in New York State is pretty astronomical, starting with just childcare alone. On average, we spend around $16,000 in childcare every year, and if you put that up against the wages that these workers are paid, they're really left with nothing. I honestly don't know how they make ends meet, and I can't wait to hear from the workers themselves. But I'm very interested in the workforce training and apprenticeship program development, and I'll probably be reaching out to all of you after to see how we can work together on that. Thank you.
Thank you, Senator.
Senator Benjamin. Oh, and before you go, I should welcome Senator Crocker, Senator Benjamin, and Senator Mayer, who've joined us.
All right, can you hear me?
Yes, sir.
I don't think it's on.
Can you hear me? One more time?
We can share. Mine's really loud.
Yours works.
Yeah, very loud.
Why did they give you the working mic?
I don't know, because I don't need one.
I actually want to pick up on my colleague, Senator Ramos's point about childcare. Being that you're a living facility, has there been some creative thoughts around possibly helping some of your staff with childcare within your space, so that becomes an attractive feature compared to a McDonald's or a Walmart, et cetera? Because I can tell you, childcare is very expensive in New York, in the country. So has there been thoughts around that?
a few of our members have piloted some creative solutions to support their workforce with childcare, elder care, and among other issues that are barriers to maintaining employment, such as, incentives to get your car fixed, things like that. And there have been a lot of creative solutions. I think getting back to Senator May's point about staffing agencies, a lot of our members believe that if they provide these kinds of supports for their staff, they're more likely to retain staff and not have to rely on agency as much. So these are some creative ideas that have been piloted, and I think some of them have been shown to work, and I'd be happy to discuss later.
Yeah, I think that would be something that can be a very obvious thing, that given the industry that you're in, that you can actually be a leader on providing and be very, very compelling to people who want to sort of work in this space, and know that their children are going to be taken care of at the same time. I think it could be very powerful. And their children would not be far from them because they would be in a location that they're near to. So that's something that I think I would love to hear more about. The second question I have is about the issue of the career advancement. To your point, this is very hard work, and I do think, to the extent that there is some obvious sort of process to which they can become a registered nurse, for example, et cetera, that is very transparent and clear. I wonder if that also, in addition to some of the personal issues, would help with the process of retaining workers. Any thoughts on that?
Yeah, I'd just like to say, would very much like to continue that conversation as we start to get into the next legislative session. I think we have, as an industry, as a provider, as providers, want to work with the state, particularly the state education department, with respect to licensure, scope of practice. We have professionals that we want to make sure, and I know the state wants to, everyone practicing at the top of their license. So if we can have conversation with that as we kind of round the end of 2021 into 22, I think we've got some creative ideas we'd like to share.
Sure. Last question. I know I missed the beginning, so I apologize. What are the learning lessons that you've seen from COVID thus far? Obviously, we're not out of COVID yet, but learning lessons that you've seen thus far. I know in every sector there have been, obviously COVID has been devastation, but there have been some things that we have learned and picked up that we will continue going forward, even out as we get past COVID. What are some of those things that you have seen in the industry that you think can help, guide the future of what assisted living looks like going forward?
Well, I have polled our members on that, and I've gotten a lot of different types of responses. Certainly one overarching theme is just the whole infection control. I mean, that was always a thing before COVID, but this, has certainly, I think, sensitized them, and that is not going away. COVID was a major shock to the assisted living network because it is such a social environment. Our residents, while they're elderly, they are not, bed bound. They're active. They come and they go, all the time. People are coming into the assisted living community all the time. And the isolation, that they experience because, they couldn't have visitors. I think that our members say that it just brought their staff closer to the residents because they were filling in for that family member that couldn't be there as best as they could. Lots of other lessons learned to just, kind of trust your instincts when you're in the middle of a major calamity and there's no answers that anybody, no solutions that people are providing, that you go with your gut. And, I think our members have done a tremendous job. Any death is too many, but the number of residents that passed away is, certainly significantly smaller than nursing homes because our residents, frankly, are just not quite as frail.
And I would just add, to state the obvious, the professional and heroic actions of first responders, providers, everyone in the healthcare community, regardless of where they were. But I would say also the flexibility, and this goes back to the point, your previous question, talking about licensure. the flexibility that the providers were given in the last 18 months to make sure that they got the job done for their communities was a lesson I hope that we can build on moving forward.
Thank you.
Time's up. Okay. Thank you. I guess Senator Serino has questions. Anybody else?
Oop, there we go. And I just want to say thank you so much. You know, you're all so passionate and caring for our most vulnerable, and I really appreciate your testimony today. You know, I'm a huge supporter of the apprenticeship programs, but they only work if students know about them. So I just wanted to ask you, like, do you think the state is doing enough to inform people about that? Like, what could we do better so that we can make sure that these opportunities happen?
I would say this. I think we now, with the spotlight after what has happened in the last 18 months, right, the spotlight is on healthcare.
Yes.
And the opportunities that will exist and do exist in healthcare is going to be a responsibility of everybody in this room and part of, you know, the government to ensure that it's trumpeted that there are opportunities.
Right. Great. We need to work on that.
Yeah.
And Lisa, I just have a question with the assisted living. You know, I've been always talking about SSI. It's so frustrating. It's unconscionable, you know, what we pay. It's really horrible. And I actually have legislation to raise that rate, and I will work with any legislator to get that passed so we do that pay rate they need so desperately. So thank you so much. Appreciate all your testimony.
Thank you. You've always been so supportive, as have many of you. And the legislature actually did pass an increase a few years back, and it was unfortunately vetoed by the governor. You know, the cost is $100 million, and I guess, you know, the 50,000, you know, seniors in assisted living, I guess it just wasn't a priority at that time, so.
Our seniors get left in the dust, right? It's not
Yes,
fair.
and many have closed since.
Yes, absolutely. So thank you.
Becoming a senior very quickly himself.
Senator Barella.
Thank you, Madam Chair. Again, I'd like to echo my thanks and you all being here to discuss this issue. You'd mentioned initially, well, first of all, you mentioned a daily loss of approximately $64 per patient per day in nursing homes. And then when it comes to assisted living, you mentioned that according to all of your members, or I believe you said all of your members, that the enhanced unemployment benefit has created a crisis in employment. I was wondering if you could speak to that. I mean, essentially what you're saying is that so far, our government hasn't really done anything to help you and has done a lot to hurt you. And that is certainly having an impact on the folks that you care for. But I'd like to speak a little bit more to those outside forces created by government that is having a negative impact on your ability to deliver services.
So are you out Buffalo way?
Yeah, Western New York, yes.
Okay, so we have members there when the minimum wage went up, and they're Medicaid providers. They have the assisted living program. They were already paying over the minimum wage at that time. So they did not get a Medicaid add-on. So they were kind of sort of punished for having done the right thing. So they do, you know, they are paying well because they have to, and they want to, and they have to. But they, you know, have gotten, you know, no support. And right now, the benefits that are coming in from government, you know, exceed what they can afford to pay in some cases. And, you know, this is an anecdotal story, but a member told me that in the North Country, like Plattsburgh Way, somebody actually told them that, you know, to leave her house, that she needs $23 an hour. And they just cannot, they just cannot afford that. Remember that, you know, for most facilities, that means that you're passing it on along to the resident who has a fixed income. You know, and so something's got to give at some point.
Well, in New York State, we took $100 million out during COVID with a 1.5% cut to reimbursements. So I would imagine that's had a negative impact. Now, if you can speak a little bit to that during COVID, when we were trying to do our best to take care of our most vulnerable citizens, the governor decided to cut $100 million out of reimbursements.
Yeah, and I did highlight that, right? That was part of the previous year's budget negotiation. So sure, that hurts, right? And understand how we are where we are, why we are where we are today with Medicaid spending. The program becomes more and more robust as far as services to be covered, which is a good thing, right? We want as many services, as many people to receive those services as possible. But those increased services have not been coming with an increased dollar attached to it. So that's the conversation that I hope we will all be having with the administration and with your colleagues in the other house to start to right that ship.
I don't know how much time I have left here. We're not seeing the clock, but we saw mandates for you to have to do testing that were not reimbursed, PPE that was not provided, and all the other mandates during the pandemic. Can you just speak to the overall damage that has done to your industry?
Damage is a good word, I guess. I would just say the stress is everyone just stepped up and did what they had to do, right? Put the checkbook aside, put the accounting ledger aside, and did what they had to do, and said, we will figure this out. And now we're at that, we have to figure this out stage, right? Nursing homes, be very clear, right? As I said also in my testimony, before the pandemic, nursing homes were working at a negative margin, right? So anything to hit that bottom line certainly exasperated that. Unfunded mandates, I mean, that's a word that you hear. You must hear that so many times in a year, right? From not just us, but everybody else in other hearings, right? They're hard. They're hard, and that's why we have hearings like this, so that we can bring that to light and ensure that we're having those conversations.
We already have loss of beds in Western New York, particularly in rural areas of New York State. So do you, I guess, foresee more closures? And I believe that there were 2 more closures recently and a 3rd bankruptcy somewhere on Long Island. So do you see more loss of beds? Because it's going to be a critical issue for us as we continue to have people aging, needing more services, but there's a lack of beds, at least in our area.
I do.
Okay. Thank you.
Thank you.
All right, and Senator Oberacke.
I think we got it. Yeah, there we go. All right. It's kind of weird when you talk and you don't hear yourself coming back. So thank you, Madam Chair. And I want to thank each and every one of you, too, for your testimony to help educate this senator on the issues that are out there. You know, as a businessman, and our business is a lot with product development and you know, the creative ideas that have come out. And one of the things that just struck me is that this business is so heavily reliant upon people, right, to do the jobs that are out there. And so just one of the ideas that I had is there any chance, or has there been any thought given to potentially automation that would help in some of the mundane type of tasks that are out there? Now, I don't want this to sound insensitive or anything, because I think the business that we're in is very personable, and that personable touch is so important. I'm just trying to think out of, you know, again, the creative side of things. You know, if you were to have some sort of, look at the box stores, look at Walmart. I mean, they're doing their self-checkouts and things of that nature. So they've kind of, you know, taken some of that automation idea to help out with this. So I just throw that out as kind of a question. Is there, or could there be some thought process given to that to kind of help with the shortage?
I mean, I was approached by a company just last month that has basically robots that can deliver meals. You know, so I, you know, don't have an opinion about that quite yet, one way or the other, but I told them I wanted to look at it. So we are, you know, scheduled to do that. We automate as much as we can, but like you said, it is a people industry. My daughter, when she was in college, worked in dining, in assisted living, and she really became very attached. And she would come home and she'd say, there's this boy and he likes this girl. And I'm thinking she's talking about the staff, boy and girl, and she's talking about the residents. So, you know, it really is it is a people thing, but we do what we can when it comes to automating.
And again, it was kind of interesting that my mother-in-law, who was in an assisted living, and I remember them coming around and having a sheet of paper for her meals. And it was more difficult for her to work off of a sheet of paper than if there was a picture of the actual meal that could be, given, if you will. So just something along that lines. And the other thing I bring up is as an EMS provider in my local emergency squad, and we are running through the same issues I think that you are, where we don't have enough members. Right now we're looking at getting literally a machine that will perform mechanical CPR. It's a whole nother individual for any of these calls that we're on. So I just throw that out again. I think it's something as we move forward, it would be really worth looking at.
Several of our members have utilized smart technology to monitor patients remotely, and it is really fantastic to see these creative innovations, and it also highlights why nursing homes need that kind of flexibility to be able to pay for things like this. But I do want to emphasize that this is still a high-touch human field, and there are limits to what technology can replace in this field.
Thank you.
Thanks.
All right, I think that's everyone. I just wanted to come back and say one. Oh, Senator Mayer. Sorry.
Thank you. And first of all, thank you to you and your staffs and your institutions for what you did during the last 18 months. And I think for all of us here, we dealt with family members of folks that were in your places, as well as family members and staff that work there. So one question I had, and I don't think you dealt with it, is for each of these sectors, the number of workers who either died from COVID or became seriously ill. Do you know that number?
I do not. I don't know that that's publicly available, to my knowledge.
But have you?
It would have been reported to the department, I think.
I
Yes,
just wonder, as organizations, whether you know the scope of death or serious illness of workers in your facilities during the last 18 months.
I have only heard of a few.
Yeah, I wouldn't have that data, Senator, but I can certainly go back, check, find out if we have that and let you know.
Well, I just think for us, as we represent both, as I say, the families of these patients and the families of these workers. And I know for me, and I think for many of my colleagues, the workers in these places are largely the women in our districts who are taking the bus and who don't have a car and may not have health insurance and also have childcare responsibilities, as my colleagues mentioned. And I think it would be helpful to know the burden that was placed on them, either by death or serious illness as a result of COVID, because they made extraordinary sacrifices. So I think that'd be helpful. Second is, for those that work in your facilities, I know it depends on whether the union, how many facilities provide health insurance to the employees, either in assisted living or in nursing homes?
I don't know that. I'm sorry, I don't have an answer for assisted living.
Senator, again, I don't have that information with me, but again, we will get it.
Well, again, I think at least from my point of view, for these workers, the ability to have health insurance, particularly given what we've been through, this is a moment to reevaluate the failure to provide health insurance. I understand the finances of it, but we're asking people to make extraordinary personal sacrifice. And I think that ought to be part of the conversation. I would urge you to make sure as we go forward next year that both the pain that they suffered as well as their health insurance needs going forward are part of the conversation as well in your advocacy, because I think they deserve that. So I just would urge that you do that.
Thank you, Senator.
Thank you.
All right, I'm going to take my privilege as chair and just to ask a couple follow-up questions because, especially after what Senator Mayer asked, I know we've heard a lot about enhanced unemployment benefits as a reason people aren't going back to work, but the evidence seems to be that it's lack of childcare, lack of other kinds of supports, and fear of infection. And so the question about vaccination, I know vaccination rates are low among staff at a lot of your facilities, and we're hearing around the country there are efforts to require vaccination or regular testing of employees. What are you thinking on that score?
So for assisted living, 74% of our staff currently, and it is inching up. I want it to be 100. Some of our companies very early on did mandate it. And I think more are considering it at this point, especially because, when you have unvaccinated staff, the community can't open up the way that it could if everyone were vaccinated. But of course, there's also that fear that if you mandate it, that you're losing people when you really can't, afford to lose one other worker. I certainly, support any of our members that mandate it, but there's that risk.
And almost identical, I would say. We do spend a lot of time working with our members to help combat the hesitancy within their workforce, to ensure that they really feel that it's safe and the right thing to do. But those that will mandate it, we will support those membership and help them to do that. But those that don't, for the obvious reasons outlined, flexibility needs to be part of that conversation as well.
Thank you. Megan, I don't know if you wanted to say anything about this too, with vaccination with home care workers. I apologize that you've sort of been left out of the conversation here, but the morning is mostly devoted to nursing care, so that was why.
Yeah, I know, I understand, and I'm sure my colleagues will get to answer questions on the topic I spoke on earlier. So we advocate for consumers, and I know that there are many people with, serious conditions, people who have suppressed immune systems who, don't feel safe having home care workers come into their homes if they're not vaccinated. And so I think that on the consumer side, which is where, I fall, that mandating vaccines would make people feel much more comfortable and make people much safer. So.
Okay, thanks. And then my last comment, I want to come back to this 94% turnover rate. That only 6% of your employees actually stay more than a year? Is that what you're saying? Because that is
that was, again, I want to
shocking
make
number.
based on 2017, 2018 numbers, that was the turnover rate.
But the retention was more than a year?
You know what, that's a good question, and let me find that out. I'm not sure I highlight that in my testimony, but I will let you know over what that time period is, okay?
That would be helpful, because that is a shocking number and
Yeah.
an indication of a totally failed business model, employment model that absolutely needs to be rethought from the bottom up. So.
And to clarify on the statistic, it includes, it's an average, right? So it includes turnover rates that exceed 100%, when you have, and it includes staff people that turn over 3-4 times in a year. So it's not to say that 6% of the staff stays on every year. It's about, especially at the lower level, the people who come in and out every 3 or 4 months.
Okay. Well, it would be nice to get a little more granular
Yeah.
detail about where
Absolutely.
that number comes from. Thank you. Thank you all.
Thank you.
Thank you.
Thank you.
I really appreciate your work and your testimony today. And we'll move on to the next panel, which is Stephen Hance, Tara Quinlan, and Lisa Volk. All right, Mr. Hance.
Good morning. My name is Stephen Hance, and I have the privilege of serving as President and CEO of the New York State Health Facilities Association and the New York State Center for Assisted Living, a statewide organization representing over 450 skilled nursing and assisted living facilities throughout the state, who are both proprietary, not-for-profit, and government-sponsored facilities. Prior to the onset of the COVID pandemic, New York was experiencing a significant long-term care workforce crisis. We were meeting with the Commissioner of Health folks on the second floor to address this issue. Then we had the onset of the COVID-19 pandemic, which only exacerbated this workforce shortage. We saw our workers become ill. We saw our workers, for the first time ever, have to leave work to stay home and care for their children as a consequence of schools closing. Now, we continue to fight through this pandemic, and we are sitting here discussing the workforce issue. And as we heard during the first panel, I think it's clear that the issues of workforce and reimbursement, particularly Medicaid reimbursement, are inextricably linked. You heard that New York's has a $56 per patient per day shortfall, and what that is the statewide data. It costs $265 per patient per day to provide care for a Medicaid patient. About 77% of all nursing home residents in the state of New York are Medicaid patients. So when you back out that $64, you're left with $8.37 per hour paid by the state of New York for Medicaid care for our most vulnerable men and women in nursing homes. So as we look at the issue of staffing, and we have staffing mandates, we all would love to hire as much staff as we could. I was recently speaking to an administrator of one of our buildings who said if a bus full of nurses showed up to tomorrow, I would hire them sight unseen. We would hire them all. So we need to address the workforce crisis. We need to address the reimbursement and make them work together. We can't deal with these issues in silos. It's been over 12 years since Medicaid has been increased for the cost of living in the state of New York. So we need to address that. In this past budget, it looks like $64 million was allocated for workforce, and my understanding that $64 million was for the fourth quarter of this fiscal year, and just want to get some clarity on that, because if that's the state share and that becomes $128 million, then there seems to be a level of commitment to addressing workforce. And we would stand here today to say any increase in the Medicaid rate for long-term care in New York, you can allocate 100% of that increase to staff. We would fully support that. We would work with our partners in organized labor to bring that to you. And when management and labor support something, it makes your life easier. So we would fully support that. So with those issues, there are issues that we need to do to recruit and retain workers and stop losing our workers, the limited workers we do, to hospital systems and other providers on the healthcare continuum who can continue to pay more. So with that, we'd like to present to you, in addition to the real need to increase the Medicaid rate, real concrete proposals that can be implemented now with the legislature and working with the state agencies in regulatory capacity to recruit and retain workers. And with that, I'd like to introduce my colleague, Lisa Bohl.
Good morning, everyone. So my name is Lisa Vogt. I am the Director of Clinical and Quality Services for NYSHVA. My background, I'm an RN and a licensed nursing home administrator. So I've been many years in operations of facilities. There's a couple of key areas that we are looking at when we talk about workforce. Number one being the TNA program, the Temporary Nurse Aid Training Program, that was utilized throughout the state to help supplement the nursing home staff. Currently, the Department of Health just did a survey that indicated 1,322 temporary nurse aides are being utilized in the facility. This is a big program that they're using. What we'd like to do is extend the waiver on that program. We also are currently working with the Department of Health to develop a bridge program that will accept some of the hours worked by the temporary nurse aid employees as their clinical hours for the 100-hour course. We also would like to align with the federal guidelines as far as the hours of 75 versus 100 in New York State. So those are some really big key issues that we believe, I mean, these are your frontline staff. This is very, very much so needed. Before I turn it over to Tara, my colleague, I had one other thing I wanted to talk to you about is the nursing home administrators. And Dora said earlier she's on the phone a lot with the nursing home administrators, as am I, and certainly can empathize with where they're at. But there's a lot of these nursing home administrators leaving the industry by way of retirement, by way of leaving the industry completely, by leaving the state, and that's very concerning to me. And I think there's a way that we could work with the Board of Nursing Home Examiners to see if we can open up more of the qualifying field experience. Stephen and I had worked with a nursing home administrator some years ago that actually had some awesome experience and was very qualified, but because they were not an administrator on record, their experience was not taken into account. They were more of a regional. And this is an administrator that had control kind of over a special focus facility. So I think there's things that we can do. So those are two of the key areas, but I'll turn it over to Tara, and she's going to talk more about the med tech and the nurses. Tara?
Thank you, Lisa. Can you hear me okay? Or? Okay. My name is Tara Quinlan.
Actually, I'm not sure that's on.
My name is Tara Quinlan. I'm the Director of Education Program Development and Member Operations for NYSHVA NYSCAL. I've been working in long-term care since I was 16 years old. I'm a registered nurse. I started working in a nursing home in dietary. I've since was a nursing home surveyor, and my last position was with the New York State Department of Health as the Director of the Quality Assurance Bureau of Surveillance of Nursing Homes. So I have been working in long-term care a long time. I understand the shortages of staff and what needs to be done to assist that. So my first proposal I'm going to talk about is creating the medication technician position within a nursing home. Allowing the ability to train medication techs and test their competencies within skilled nursing facilities to assist with lower level medication administration. They would be under the supervision of the registered nurse. This would allow the nurses more time to provide hands-on care to the residents, and it would also, with further changes to regulation, allow these medication technicians to be a part of that direct care staff in the nursing home. Another proposal is changes with the New York State education licensing requirements. So during the pandemic, we had an executive order to allow nurses across the United States and in Canada, if their license was in good standing, to work within New York. And I know a lot of nursing homes that I spoke to were utilizing that, especially around the states that are around us. That was a big supplementation of staff. To be part of the Nurse Licensure Compact would allow nurses to have one multi-state license and the ability to practice in their home state or neighboring states or other states. That would also supplement the workforce. And I just wanted to quickly talk about, as it was mentioned in the previous testimony, the Daily Herd Survey. Just some thoughts on that. Those are your direct care staff doing that, directors of nursing, infection preventionists. They are taken away from the direct care of those residents every single day. I understand the need for data collection, of course. However, for that to continue every single day, 7 days a week, with no relief is not necessary. That's in addition to a weekly testing survey that they have to do every Wednesday, and also in addition to several supplemental surveys that the Department of Health just sends out randomly throughout the year. So to not have to do that on a daily basis, even to not do it at all of this information is now reported to the federal government and NHSN, so it's really not needed. So those are just some other points that I think would help.
So when you take together the issues of reimbursement and real practical initiatives to recruit and retain workers, there is a pathway to address the concerns in long-term care. There are real focused initiatives that can be implemented in partnership with the legislature and with the governor, and we thank you for your time and for your focus on this critical issue. Thank you.
Okay. Thank you so much. Let me ask a couple follow-up questions. So about the HERD survey, actually, I've forgotten what my question was on that, so let me ask a different one. One of the things I've worked on a lot in the last year is visitation in nursing homes and trying to facilitate opening the doors to more family members or loved ones to be able to visit. And I often hear that the big issue is staffing in that. So can you explain what the staffing requirements are for something like that, for bringing visitors, allowing visitors into a residence room, say?
So under the current guidelines, they talk about core infection control principles. And within those core infection control principles, you have to maintain the PPE, the social distancing, et cetera. So there needs to be enough staff to kind of supervise that, because they're held accountable for maintaining that as a part of the guidelines for, through the New York State Health Department. So that's a piece of that. They have to take that into consideration of what do they have as far as, that staff to do those visitations. Okay. It's not just kind of opening the door and letting everybody in. They really have to look at what they have available to look at, maintaining those core principles.
Okay, so just in the interest of time, if we were not in a pandemic situation, if you can strip away all of those kinds of requirements, is there a significant staffing requirement to allowing visitation in nursing homes just in ordinary times?
Well, in general, there's always some level of supervision when it comes to visitation. You want to make sure things are going okay and your residents are safe, because there are, times that you do have to intervene, but they certainly are less stringent, not in the middle of a pandemic, so.
Okay, thank you. I wanted to follow up on one of your very first statements, Mr. Hance, where you said, for the first time ever, we're finding our staff having to leave work and take care of their children. Now, I get it. If schools are closed, it's sort of a mass event, but I imagine that happens all the time and has happened for years and years and years. And I just want to follow up on the discussion from the previous panel about the need for things like childcare on site as a way to really support these workers who are giving everything to your residents, and then their own families are losing out. So I wonder if you had thoughts, or any of you had thoughts on that discussion that we had before. Sure,
and Senator Ramos and Senator Benjamin, it's a real issue. It's a significant issue, and what we saw prior to the onset of the pandemic are the regulatory paradigm to establish a child care center in your workforce. There's significant hurdles, especially in healthcare. So those regulatory issues and what we're dealing with are various agencies, and this is also with the workforce in terms of the education department, that don't really work in partnership, and they say this is the reg and you can't do this. What we did see in the pandemic to encourage our workers to come to work in this very trying time, we did have, given the context of the state of emergency, various regulations were waived. So we were able to establish certain child care facilities, temporary, based under the auspices of the pandemic and the emergency, the declaration of the state of emergency. Those, now that that's over, all the applicable regulations are back in place right now. But we had several of our members do that, try to do that, and it worked. You had to find location, but you also had to find appropriate and qualified staff for childcare. which has its separate employment issues, because you need qualified individuals who those parents can trust with their children as they go to work. And the location of the child care needs to be very close, if not within the building, and then we have very significant restrictions in terms of the utilization of the building. So again, after you've heard it said anecdotally, but it really is the truth, after nuclear power, there is no more heavily regulated industry than nursing homes. It's the truth. And when you really peel back the onion and you see what we have to do, okay, we want to dedicate this wing of our nursing home to childcare. It's not that easy. Okay, we could hire someone to do it, have them come in. No, it doesn't work that way with the Department of Health, with the Office of Children and Families. It doesn't. There's all these hurdles. So I think if there was a legislative initiative to address some of these, that could help.
Okay, thank you. Do you want to follow? Anyone else follow?
I'll be brief.
Okay.
O'Brien, go.
I definitely, I heard Senator Ramos mention this. I definitely want to follow up on some of the regulatory issues around childcare, because it just seems logical that you're in the living business, children, having spaces for children to be there, because I think of career pipeline, childcare, making sure people are safe from any diseases, like obviously COVID, and working conditions. I mean, if those things coming together, I think will definitely help with this workforce retention issue. To that point, can you talk a little bit about sort of the typical length of a work shift for someone working in one of your members' facilities?
I think that varies on there's a lot of variables in that, in answering that question.
I'm sorry, not to cut you off. Let me ask the question. Being that there are shortages, you have staffing issues, I have to imagine there are people working very long shifts in some cases. Help us think through the implications of that. How long could one person be working on a shift, for example, et cetera?
Yeah, I mean, a double shift would be considered 16 hours, and you wouldn't go anything over that 16 hours. A lot of facilities will staff on 12-hour basis and do so many days on and so many days off. It all depends on what the facility's needs are. I also think that you have to take into consideration when people are working overtime, making sure they have some time off after working some overtime, and then that is also a challenge. So it's not like just a kind of cut and dry answer. Some facilities, their work hours are 7.5, some are 8, but a double shift is 16, and normally, it's 12 hours in between, so.
And I would just add, just myself being an RN and working in these facilities, even, this crisis and staffing is nothing new. And when I was working, it wasn't during a pandemic, and I often found myself as a 3 to 11 supervisor covering also that 11 to 7 shift. That was an often, probably a few times a month occurrence.
And when you go back to the SUNY Center for Workforce Studies and the School of Public Health, and you look at their data reported on a regional basis throughout the state of New York, the shortages throughout the various classifications in healthcare are there pre-COVID, they're going to be there post-COVID. Again, it goes back to the issue that the state has never really dealt with the issue. And then we heard on the earlier testimony in terms of the reimbursement. And unfortunately, the state of New York was the only state to cut Medicaid during a pandemic. So you had that. And then on top of that, the federal government provided additional funding for states' temporary relief to deal with the various mandates, the PPE, to pay higher pay, hero pay it was called, to encourage workers to come to work. So the states were allocated that money from the federal government. New York is one of only 5 states that refused to allocate any of those money to health care. So I think when we look at the issues, we really need to, again, look at them in the context of the workforce and the reimbursement. They are inextricably linked.
Sure. One last question. Do any of your members have sort of a predictable career trajectory for nursing assistants? I guess when I went to business school when I graduated. I knew if I went to go work at X place, you know, for these 3 years, if I do my job, I'll be an associate, and then I could be a vice president, et cetera, et cetera. And so, you know, when you're working around the clock, killing yourself, you know, you might say, oh, I can quit. Oh, wait a minute. You know, there's something that I'm a part of. There's a trajectory. There's a career path. I guess, you know, is that happening anywhere within your members?
It does.
Okay.
It does, and I can speak to it because at the facilities that I was a part of, from an operations standpoint, even myself, I started as an LPN. I really had to do like the background work as to what I had to do to become an RN and what would be accepted, but I did take advantage of the tuition reimbursement offered through the facility, and then went back to become the nursing home administrator. So there were some mechanisms in place that I could take advantage of. However, in particular, in the facilities that I covered, we had something called the ACNA program, which meant it was additional training for the CNAs who maybe didn't want to go and be an LPN, but really wanted a little bump up in some way. So additional training, some duties. Tara spoke about the med tech. One of the things that we feel is allow the nurses to get back to being nurses. Let the CNAs who want a little extra level up, train them to be the med techs. And you know, studies have shown that they've had really good success with this. So I think these are some of the things that we need to look at, like overall. But to your point, you know, always tuition reimbursement taken. I mean, I was the recipient of a scholarship through our association that helped me buy books. And I mean, so those things are really important, and just really pushing the nursing homes to kind of do those things. We offer that training program on a train-the-trainer basis, and there's a lot of facilities that have taken advantage of that. So there are things available. There are things available.
I need to break in here because the
I'm finished up.
Senator Rivera, did you want to say anything?
Hey, folks, I'll be brief. I'm looking through your testimony, and there are a couple of recommendations that you folks make. And I just wanted to understand, as you know, there's so many acronyms that always are thrown around. I just want to make sure that I understand some of them here, and particularly related to the medication tech program. Obviously, CNAs, you know, certified nurse assistants, and but SNF.
Skilled nursing.
Skilled nursing.
Skilled nursing. Skilled
And
nursing.
on the
facility.
med techs, New York
Yeah.
State presently permits those in assisted living facilities. For
But-
some
because-
reason, they don't in skilled nursing facilities.
Right, so I wanted to understand that particular proposal a little bit better. So could you break down what that particular proposal would be? As in, what are the changes that you propose as a recommendation to us?
Right. So we would propose that the ability to train, there is already a training program for med techs established. So allowing them to take that program and then utilize it in skilled nursing. It would require state legislative and New York State Education Department change in education law and public health law.
And this would be, the change would be, what would be the change exactly that you would be proposing? So you're saying that it exists in another setting?
They exist, they're not allowed, so currently in a nursing home, just nurses are allowed to give medications, so it would have to be written to allow medication technicians who are properly trained and certified to then also administer within the nursing home.
Gotcha.
And you'll see attached to the testimony, we have a chart with the recommendations.
Yep.
And that actually, yep, you got it, Senator.
And you got it,
That
too?
speaks to the regs, that speaks to, that bill was a bill introduced several years ago. That's not a 2021.
And did you get this to us electronically as well?
I'm sorry?
Did you get this to us electronically as well?
No, but I'm happy to do so.
And you could share with us electronically? So
Sure.
I'd appreciate it.
Absolutely.
Thank you, Madam Chair.
Is that it? Anybody else? Senator Burrow?
Thank you, and thank you all for being here today. I want to talk a little bit more about the HERDS reporting. I mean, obviously, we're talking about workforce. We're talking about hours spent with, with your residents. And I know this is something that's been around for a while, but it's my understanding this was switched to a daily reporting during the pandemic, and it's still a daily reporting burden. So can you just, I guess, being that you are in the industry and you know what it was like before, what would be best to do so it doesn't burden you so much if the data is still there?
Tara talked a little bit about this. Some of the data that's reported already in the daily herd survey is being reported at a federal level, so it's about kind of sharing that data. That'd be number one. Number two, they don't need to do it for 7 days a week. I mean, no one has a weekend off anymore. I mean, we have discussions with administrators and directors of nurses saying, now I can't do anything after, until 1 o'clock, because I have to have this submitted. I mean, their families are on hold. I mean, it's at this point, we could reduce it. The rates have come down, and we certainly could reduce that to even something during the week and not involving the weekends. They've been through a lot, and to continue to do this, I mean, it's not warranted at this point.
What was it prior to the pandemic? I mean, how frequently did they have to report this information? And is it more detailed now? I mean, I think people need to understand what a burden this really is.
Yeah, so, prior to the pandemic, and they still have to do this now. So again, we're talking about multiple places you're reporting the same information. So prior to the pandemic, if there was an infectious disease, you completed what is called a NORA report, and you reported that to the Bureau of Communicable Diseases. That makes epidemiology, everyone aware of the issue. That gets then told to the regulatory people. So really, the herd survey previous to this, you more saw it with coastal storms, that sort of thing, and how they are getting ready to prepare, that sort of thing. I have not seen, at least in my time working with the department, the herds utilized in this way for such a long time. And I just want to say it's been since March of 2020. So over pretty much a year and a half that every single day of their lives they're being taken away. And this is not a short survey either. This is not a survey that you're answering yes, no, yes in 5 minutes. It's a very long survey. And to add on top of that, if you have any technical difficulties, then engaging the department and getting that fixed. So it is quite time consuming, and it does take, like I said, this is your DON doing this report, your infection control nurses, the people who should really be with the residents. I think it gives the impression that paperwork is more important than resident care.
Well, it is government, so I'm sure that's the case.
And I'd just like to add what we're seeing, and Tara makes a really critical point. These are our clinical staff compiling and filling out these surveys, and time again, and I have a file full of them, they have to be reported by 1 o'clock on a daily basis, 7 days a week. There's case after case, 101, 102, where the nurse hit the button, and it's officially late. And the letter that comes from the Department of Health to that facility is extremely threatening. It basically says, we're going to charge you $2,000, we're going to consider taking away your license, and it's that. And we respond back. There was a case where a resident, the nurse was, in almost every case, is providing care to a resident, and we explain that, we can document that, and it's disregarded. You were a minute late, it's $2,000, and we're going to take a look at your license. It's that type of atmosphere that only exacerbates people and wanting to leave. Why do I want to work in this? Here I am providing all this care in a pandemic. I was providing care to a resident, and this is the thanks I get. So, I mean, it just adds to the myriad of issues our workers are dealing with.
Thank you.
Senator Serino.
Okay, thank you, Senator. And Lisa, this question is for you. During the pandemic, as you said, the state allowed the workers to come in from out of state during the emergency just to work temporarily. And I love your idea about the compact licensure. I think that's awesome. But the last I knew, the nursing homes still had not gotten any guidance with regard to those out-of-state employees. Have you heard anything on that?
I know at this point they were told they did not have to let them go at this point, that they were working that out, so they still have those nurses present, but it is true there is not anything formally written that I'm aware of.
They did provide to us some mechanisms to check their application status, and we advised those particular individuals to make sure they're sharing that with the facilities, to make sure they can see where they're at in the application process for New York State. But, you know, there was a variety of nurses from different states that came over to help us, and we sure would like to keep them.
Oh, absolutely. That's why I love that idea. I know I sent a letter to the governor and the Department of Health asking that question and many others, and I haven't gotten a response, so I'm glad that you got a little bit of a response. But also when we talk about the staffing shortage, building off of what Senator May's question, you know, we'll spend a lot of time today talking about that, healthcare staff in particular. But are there additional staff that could be brought in to take some things off of the healthcare team's shoulders? You know, like we saw a lot of displaced workers, people that worked in hospitality. Are there people that could answer the phones? You know, that was a big thing, right? Families were calling constantly. Things like that, or even to facilitate some visitation. And, you know, I don't know if there's a way to incentivize them, maybe to do that. And also, we talked about the childcare issues, and one thing I've heard from staff is the transportation issues and an inability to get to and back from work. Do you experience that in your network, and do you have any suggestions that what we can do on that issue? That's for, I guess, all of you.
So there are a variety of things that facilities are doing. We have the paid feeding assistance program, and so we have people coming in to help feed, which is a critical need during the hours of meals. And yes, a lot of them employ, under a different name, ambassadors or helping hands to help from an ancillary standpoint with answering phones or potentially calling families back, etc. Extra pair of hands out there, maybe to help deliver linen to the rooms, something that does not take a skilled level. So there are programs, and facilities are really taking advantage of everything they possibly could take advantage of right now. So.
Okay, so that's already in the works. That was
Yeah.
happening during the pandemic?
Yep,
Okay.
yep,
Is that,
yes,
okay.
yes, yep.
Okay.
As far as the transportation goes, in our rural areas, it is very difficult. We have administrators who I know and I've spoken to who will drive to pick up staff themselves. And they'll make the rounds in rural counties and communities to pick up staff who have no access to public transportation or a car for that matter.
Yeah, that's a big issue in my area. We have a lot of rural areas too, throughout the state, so thank you.
All right, well, thank you very much for your testimony, and we'll be following up on some of the issues that you raised.
Thank you very much.
Thank you.
Next on our list, we have Jean Hickey and a late-minute addition of Francine Stretch.
Good morning.
Good morning.
My name is Eugene Hickey. I'm the Secretary Treasurer for Local 2013 out of Brooklyn, New York. We currently represent about 13,000 members in the 5 boroughs. 44% of our members do come from the healthcare industry, so we're very engaged in that. We wanted to share some problems that we're having with a particular employer, Link Home Care. Link Home Care has been a bad actor over the last few years. We not coming to contract agreements, not recognizing the hard work of our home health aides. Currently, they have about 600 hardworking home health aides who work there at Link. The healthcare professionals, they've worked through the pandemic, they've worked hard, they went with little or no support from Link. Under their management, Hayel Edelman, We believe he needs to have a closer look from the DOH and the Department of Labor. Typically, they don't provide people with full-time work schedules. They're always recruiting people. And what this causes is that the aides constantly move on because they need to find supplemental work, because 20, 30 hours a week is not going to pay their bills, and they are minimum wage workers. This causes a bad experience for their patients because the provider is constantly a different person, so there's no continuity with the patient. Our members even report to us that there's such a bad communication with Link. They call a case manager, they want to find out what's the condition of the employee, excuse me, the condition of the patient. They are not giving any medical information from them. They're not given health care plans, which we believe are required by the state and by regulation. Members are having difficulty getting into the homes of our patients. Patients refuse to come in. Typically, our aides try to call the office. They get no answers from the case manager, no leadership gives them any guidance, and they often have to call 911 to gain access into the patient's home. Typically, our members, they work from a location that is a member's home, which is the patient's home, and the training that they're given is very inadequate. They're given very little training. It's all done online, even before the pandemic. There's no hands-on training done at the facility for Link. Our understanding is that if it's necessary or if someone complains, they try to send them out somewhere to get that training. We believe it should be done in-house with a setting that's appropriate for the home health aides. Link management, one of our aides reported to us that they have not had a care plan handed to them by Link in 5 years of employment. This is truly a concern of ours. Without that health care plan, it's hard for the aide to care for the person. They go there, they have no answers. If there's a medical emergency, they're told to contact Link. Link does not answer them. They get nothing but voicemails and often don't get their questions answered until 2 to 3 weeks later, which is way too late, is unacceptable in our eyes. The aides, we have had aides that work overnight. There's a requirement that they get a 5-hour uninterrupted sleep. Very often, we hear from the aides, they didn't get the 5 hours sleep. There's no compensation, and there has been no resolution to that as of this date. On a note that we're trying to resolve a lot of these issues through our bargaining table. We've been in negotiations with Link Home Care for over 2 years. For 2 years, we've tried to get FMCS involved to get some resolution there. That has not happened. Currently now, we have unfair labor practices filed with the NLRB. We're trying to put all our toolboxes and all our tools out there to get it, but we have not had any success at the table for 2 years. The company also, in negotiations, has not agreed to sign an extension, which resulted in the contract being expired. By the contract being expired, it cheats our employees out of the grievance process. So we can't even grieve that they're not getting the proper pay, the proper sleep, or the proper equipment.
Okay.
The other thing
Your
that-
time is up, but we have a bunch of questions. Did you want to say anything?
I was just going to add on something about PPE, because during the height of COVID, our members were put in very dangerous situations. The only PPE that they were able to pick up was masks. They weren't given gloves, they weren't given gowns, they had to pay for that out of their own money. To go pick up those masks, they had to travel to the Link office, which is far from their homes. They wouldn't get compensated for the travel time or for the time they took on their own to go pick up their PPE, and then they weren't given any instruction on how to use the PPE. So one of our members was working with a patient who was positive for TB, was never told, and was in there without gloves or a gown. So, our workers were deemed essential workers, but the way they were treated by this bad home care agency certainly didn't make it seem that they were essential workers. And like Jean said, we tried to negotiate pandemic pay for people, and we couldn't get it. So not only is PPP not reimbursed, but they're owed money. They're owed time on vacation, they're owed time on time off. We don't even think that the wage parity is working the right way. And we can't tell because people are now getting electronic pay stubs, which they can't read. So when they try and get information from Link, they're not getting any help because they can't reach anyone in the office. So, there's a lot of problems that these 600 home health aides are facing.
Thank you. I'm going to turn it over to Senator Ramos for the first questions.
Well, thank you so much for coming all the way up to Albany to share all of this information with us. I'm very troubled by everything that you are sharing with us in your testimony, and I'm wondering if you can start by describing a little bit more about what your 600 members employed by Link look like and do, and sort of what the nature of their work is, perhaps what a day in the life of looks like for them?
Yeah, basically our home health aides, their day starts off, they leave from their home, they have to travel to the patient. Their main workload is that they would go and take people's vitals, make sure they're taking medicines, instruct them on how to care for themselves. Most of our home health aides, not even, there's no area provided for lunch for them. They have to bring their own lunch. A lot of times what they do is they have to order out their lunch, which is expensive. Yes. And remember, we're talking about minimum wage workers. They're very diligent people because they do this work because they love that. They look like me, they look like Francine, they look like you guys. These are everyday people that have a genuine concern for people's health, safety, and well-being. It's God's work, we all know that.
Now, at some point, you did have a collective bargaining agreement?
Yes.
And that's been expired for now 2 years?
For 2 years, we've been trying to negotiate.
And what has that campaign looked like in order to obtain a new CBA?
Well, when we first started negotiating, we worked off of getting an extension in place so we can keep all the processes in place, such as grievances, and we also have an issue with them not submitting dues, forwarding dues to us, actually trying to cause an economic hardship on the union. And also, it's denying people access to health and welfare that really do need it. We typically notify the company 6 months prior to expiration, which we did, that we were willing to bargain. We sent a list of proposals that were put together from the HHAs, from surveys we did with them. We've had bargaining committee people there. We presented all these things. We are also represented by an attorney. And we've tried to work through this for almost 2 years. And in midstream of the first year, they fired their attorney and restarted the whole negotiations by hiring a new attorney. So that kind of staggered it a little bit longer than needed to be.
Did the original CBA provide for health benefits for this workforce, and have those services been interrupted because of the expiration of the agreement?
Yes, it always did have health and welfare in there. People have not gotten health and welfare because the contract is expired. Actually, we just had to send Link to collections on some money that they owed for health and welfare. They weren't paying the premiums, and we just had to send it to our collections lawyer.
And in fact, at an orientation that I just went to this week, where they bring in new members, that's the one place that we're able to talk to the aides, because it's before they're actually assigned. They were all being encouraged to sign up for Medicaid, which they shouldn't even be telling them to do that. And I had to tell the person, you're not supposed to do that. So, they don't follow the guidelines. And, You know, the majority of our workers are women, immigrant women, women of color, and I think Link takes advantage of our members.
Have there been any conversations about oversight with the Department of Health and Mental Hygiene? And what have those been like? What type of oversight have they been able to provide, particularly throughout the pandemic when none of these workers have had access to health insurance?
Yeah, and we have been going through a lobbyist group to try to find what's the right organization to go to complain. We've had a lot of conversation.
I'm sorry, you've hired a lobbyist to tell you where to go to complain?
Where to find the complaints.
Emphasize that.
Right, because, you know, we wanted to go to the right organization. We've made calls to different organizations and it wasn't helpful to us. We were told they were overseen by the Department of Health.
And how many of your members passed away during the pandemic, employed by Link?
Well, total, we had 50 that passed away, but we had close to 1,000 came down with COVID, and that's just what we were able to find out. You know, Link wouldn't report it to us, so that's counting some of our other, you know, our other workers as well. Many of our other places would tell us, you know, how many people came down with COVID. One of the aides told me this morning that they weren't even given any information about how they were supposed to report COVID cases. So I don't even know if Link was getting that information.
And so when the pandemic started and, you know, we reached the peak quite quickly here in New York, the State Department did not provide any sort of guidance to any of the Link employees on how to do their job in a safer way?
Not that we're aware of. I mean, we provided information. I mean, we put things on our website. You know, we had difficulty accessing the members because for years Link was hiding the list from us. So even though there were 600 workers, we were only collecting dues for 100 or 180,
180 folks.
You know, people that we knew of. So they were hiding for years, all of these workers. So we finally, in this last bargaining, got the list, and then it was trying to reach out to people, give them information about COVID safety. You know, on our website, we have a lot of information, but for years, we weren't able to even contact them because they were being hidden from us. They don't go to a central place for training, so we couldn't even go find them there.
It's lonely
It's all
work.
online. So we did have people doing 311 calls during, you know, the height of COVID to complain about PPE. And, you know, we can't file as a group with the Department of Labor, but we are helping people get together their pay stubs and their proof because a lot of them are owed money.
Well, I'm probably out of time by now, but I'm very interested in helping you. So,
3 more minutes.
oh, I have 3 more minutes. Oh, that's the clock. Thank you, Zach. Well, I don't know. I mean, perhaps, is there any other information that would be helpful to me as the labor chair in order to help you and for everyone here, particularly the press, to understand what's going on at this facility, with this employer?
Yeah, we definitely need help to get these folks to the table and to agree. We get to an agreement that everybody was happy with at the table. Their attorney goes back to Mr. Edelman, and then we hear radio silence for a month or so until we start calling, filing board charges. Then they finally come to the table.
And then forget everything they said.
And then renege on everything they say. They constantly change their position. Once we thought we had a deal where we had everybody laid out, where there would be health care or retirement program, a little bit of raises, we signed off on the MOA. We sent it to the company approximately 60 days ago. We still have not gotten an answer from Link.
Can you very quickly tell me about your retirement plan for your members?
The retirement plan they currently have is none. We implemented what we would like to implement is a 401k plan. The company is willing to do that, so they say at negotiations, but with no match, which we believe needs to be matched.
And they were saying 5 years, no raises. I mean, this was their position until we got them down to 3 years. I mean, they're a really bad actor, and we don't know what they're doing with all of the money. They even got some money.
They got
And we
PPE.
don't know what they did with it. You know, our members are not getting reimbursed for like if they are taking a patient to a doctor. We've even heard family members complain that they haven't gotten reimbursed for that. So there's something with the money going on.
Do you know the name of their attorney?
Yeah, I can get you the name of her.
Okay, please do. Thank you.
All right, thanks. I'm going to follow up just quickly because I hear stories like this all the time about home care workers, but you represent thousands of other home care workers, is that true?
And other workers.
Yeah, who don't have these problems, who do get 5 hours of sleep a night, who do
Yeah,
get
we
travel
actually
reimbursed?
represent 3 other home health aid organizations that we have a working relationship with and had not had any of these problems with
Okay,
them.
well,
They all come to the table, we bargain, we got collective bargaining agreements in place in the others.
well, I just want to say that's a testament to how valuable collective bargaining is because so many home care workers who aren't represented report exactly these kinds of problems all the time. So I want to thank you for the work you do to help the workers who are under your umbrella to get those kinds of protections because they're so important.
And just to emphasize what Jean said, the fact that they won't process grievances now almost makes it as if they don't have a union. So we have all of, I talked to people this morning, they're owed pay, they're owed, they're having problems, and because they won't process grievances,
Right. That's our mechanism to resolve issues, and apparently they don't want to resolve the issues, or else they would come to the table, come to an agreement. Not even come to an agreement, but at least sign an extension, keep the existing contract in place while we work through the issues. They refuse to do that. So it's very important that, as Francine said, these folks, they feel that they don't have anybody. For years, we've chased after Link. They've hidden somewhere between 400 members, which we finally did get in contact, that never knew that they were part of a union. They were never told.
Okay, thank you. Senator Senator Serena?
Oops. Thank you, Senator. I receive so many phone calls from healthcare workers regarding gloves, right? That is mind-blowing because that should be a basic priority. And during last year's hearing on nursing homes and the residential healthcare facilities, that was a huge part of our discussion was the lack of PPE training. And I was just wondering, have you noticed any change on that since then? Since last year?
Not with Link.
No. The
Not
only
with Link.
changes that occur is when the field director has gone to the facility and actually embarrassed them. We've actually brought gloves to facilities to hand them out. But you're right, it's a basic need of protection.
Yeah.
It's your first line of protection, and these folks are out there with no protection.
Yeah, even in our assisted living facilities where we represent workers, I mean, it's better, but it's still like controlled. They have to go through a manager if they need it, and oftentimes they're afraid to ask the manager. So, it's not easy to get the PPE that they need. Masks, yes, gloves and gowns, no.
That's absolutely horrifying.
Yeah. Or they're the wrong gloves, let me
Yeah.
say that. We have
Oh.
places where they're wearing gloves that they've gotten, and they're open around the wrist, and, they're coming in contact with body fluids.
And I know that this is obviously a hearing about staffing shortage, and not procedure, but procedure is so important, right? Because if you feel like your own health is at risk, that's going to have quite an impact on you. So what suggestions do you have to improve that training?
Well, I mean, what our aides would say is that the online training doesn't work. Watching a video, and it's not even like a group Zoom. I mean, it's like they log on themselves to watch this video, and half the time they'll say the link's link doesn't work. So, there needs to be more in-person, more hands-on training. That when they're sent out to do the required training that they're supposed to get, they have to pay for it, which is ridiculous. Link should be providing that. So I think that's one thing, is that, the training really needs to be tightened down. But the other thing is that on an ongoing basis, Link doesn't have a system to answer calls. So we just heard the other day they're thinking of outsourcing it to a call center. because they have a case manager who has 100 calls that come in. Well, yeah, we know they have 100 calls come in because our members tell us they can't reach anyone. So they're not able to get help every day in their jobs. You know, Link has no system to provide support to people. And I've tried myself. I've called, I've been put, you can call the number. I've been put on hold, I've been cut off. They transfer you to another number, it's a voicemail. They can't reach their case managers. And we have families, like a parent, you know, a parent of a client, a resident, who she can't reach them either. She can't reach her case manager. So I think they have to, you know, something has to be done not only for training, but ongoing support and communication. And then the whole PPE issue has to be resolved, you know. And they shouldn't have to go on their own time to pick up PPE, and it's not even the full PPE.
No, absolutely. They need to be protected, you know,
Yeah.
because they're protected and then the vulnerable residents are protected
They're
as well.
terrified that they're going to bring something home to their families
Yes.
because they're in homes where the only thing that was required of the patient by Link was that the patient be wearing a mask and our you know, provider be wearing a mask. But then there's people walking around the home who knows what their status is, and they're not required to wear masks. So, you know, this is a big concern when you're going into people's houses. How safe are you? You know, how would we all feel walking into a home?
Yeah, and we hear the stories from the folks from the HHAs that they fear that they go into either the garage or a back porch to take all their clothes and put them in a plastic bag before they even go home to their loved ones. A lot of these facilities they go to, it's a person's home, so they can't really change their clothes there like if you were in a factory or something. So they're in a pretty awkward position. And as I think Francine had said, is that a lot of these folks, you go into their homes, you don't know what they have because they don't have a care program. They don't know what's in this plan. Does this person have dementia? Does this person have TB? They have no idea what they're walking into.
I got a copy of a text the other day from one of our providers who's new. They told her, can you take this case? You know, she said yes. They sent her the patient's name and the address, and that was it. And then she got there, and I said to her, well, is there a care plan there? You know, the nurse should leave a care plan. She said, no.
Oh, my God.
So it's like they're just
Terrible.
sending them out.
Terrible.
Okay.
Well, I hope that gets resolved because that's
Yeah.
awful. Thank you.
All right, Senator Mayer?
That's really bad.
Just quickly, isn't Link licensed by the State Department of Health as a Medicaid home care provider?
Yeah.
And are they not paid Medicaid reimbursement for each of these patients that your members visit?
Not all of them, but yes, most of them.
The vast majority, I
Yeah.
would assume, are Medicaid. Have you filed a formal complaint at any time with the Department of Health regarding the conduct of Link?
Well, this was our first step here today, and then yes, that will be the next step.
But you haven't gone to them yet, the Department of Health? We're not the Department of Health.
Not as a union, no. Individuals, yes.
Individuals have gone to the Department of Health, and has there been any response?
Not yet. Not that we know of.
And have they gone to the Department of Labor as well?
Not yet.
Okay, thank you.
All right, thank you very much for your testimony and for bringing this to our attention.
Okay, thank you.
And we'll follow up.
Yes, I'll get you their attorney's information.
Next, we have Grace Bogdanov, William Rowe, and Tonya Blackshear.
Well, hopefully, it should be pretty soon, right? 11 or 12. Yeah, that's what you said. Thank you.
All right, can we start with
morning.
Grace?
All right. Well, first, I'd just like to thank Senator May, Senator Rivera, and Senator Ramos, everyone here for having us. My name is Grace Bogdanov. I'm the Western New York Nursing Home Division Vice President for 1199 SEIU, United Healthcare Workers East, out of Buffalo, New York. I'm joined here by Tanya and Bill, two of our members. 1199 represents over 65,000 nursing home workers across our state. and I appreciate the opportunity to share our union's perspective on the workforce shortages and the challenges in the nursing home industry. Our union played a pivotal role in New York's new requirements for minimum spending on quality care and staffing, as well as the new requirement for minimum hours of care. Adequate nursing home staffing has been the #1 priority for 1199 members for years, and we are hopeful these changes will make a real difference for residents and healthcare workers. From our experience, the workforce challenge in New York is not a result of there being too few caregivers available. The CMS COVID-19 data for the week ending June 20th shows that 89% of facilities responding said that there was no shortage of aides. 97% said that there was no shortage of clinical staff. Over and over again, workers tell us that facilities are hiring. Though instead of a worker shortage, the reality is that inadequate pay and benefits, poor working conditions, and the inability to have a seat at the table on matters concerning resident care are driving caregivers from the bedside. The real challenge that we're facing is turnover. In 2019, Leading Age reported that the turnover rate for CNAs in New York State was 25%. However, regional medians vary from a very low of 9% in New York City to a high of 52% in the Buffalo region. So what drives caregivers away from nursing homes? Typically, the pay is inadequate and the workload is overwhelming. Caregivers do not feel valued or have a say in how care is delivered. And finally, research indicates that working in a for-profit facility is associated with higher turnover, likely because these issues are more acute for workers in the for-profit setting. We know that higher turnover is associated with lower quality care. Continuity of care is crucial for nursing home residents. Caregivers get to know residents that they see daily. They understand resident needs and can identify changes in conditions, ensuring a greater quality of care provided to the residents. A 2021 study showed that facilities with the highest median turnover rates had the lowest CMS overall star ratings, and the highest rated facilities had the lowest turnover. If we're going to improve nursing home care in New York and providers are going to meet the new standards for staffing, we must reduce turnover. Living wages, quality and affordable health care, and a secure retirement are the fundamental features that can keep workers at the bedside, even when other conditions, such as short staffing, are present. In addition to quality wages and benefits, workers must have a voice in how care is delivered. In the 2018 cost reports, we found the statewide retention rate for CNAs to be 75%. But the statewide average retention rate for CNAs not represented by a union was lower, 68%. I already mentioned the 9% turnover rate for CNAs in New York City. This makes sense. These are largely union jobs with union-negotiated, affordable, and quality health care and retirement benefits. And a unionized workplace is the vehicle for workers to have a voice in how care is delivered. As simple as our solutions sound, our experience is that some employers are still doing the opposite. We still bargain contracts with employers who fight tooth and nail to limit increases in wages and benefits. They then turn around and pay premium prices for per diem and contracted staff because they can't recruit workers at the wages that they pay directly employed staff. For example, just last year, 1199 members at a nursing home in Buffalo had to fight for an improved CNA start rate, a start rate that remained below $15. This is a facility whose CEO has an estimated net worth of over $500 million. And recently, 1199 members at 2 other facilities in Western New York negotiated for months, fighting to raise hiring rates with an employer that offers new hires the choice between being in-house employees and working for the agency. We know that many of these agencies are connected to and often owned by the very same network of people who own and operate these facilities. And it should come as no surprise that some of the workers in these facilities are no longer directly employed, but instead choose to work through these agencies in order to earn a higher wage. So to reiterate, our recommendations to keep and grow the workforce are to strongly enforce the new minimum staffing and spending requirements to improve quality jobs and care, to provide adequate wages, quality and affordable health care and retirement security to caregivers directly employed by the nursing home, to improve worker engagement and investment in the workplace by including caregivers in recruitment, quality improvement, problem solving, scheduling, and mentoring new staff, to improve onboarding, training, and worker supports. I'd like to mention that our training fund focuses on providing these supports, and we provided a written testimony on this for you to review. And finally, to support funding increases for nursing home care that are targeted at improving wages, benefits, training, and supports for caregivers directly employed by providers. I'd also like to mention that in a previous panel, med techs were mentioned as a possible solution. However, this de-skills LPN labor, and it destroys the CNA to LPN career ladder. This is key to retention in nursing home industry. So during the pandemic, some of our facilities engaged their workforces in meeting the challenge of COVID-19. In many cases, these facilities did a better job at protecting both residents and staff. We're confident that we can do the very same to meet the workforce challenge of turnover and retention. Thank you.
Thank you. Mr. Rohr?
Good morning. I appreciate the opportunity to speak before this committee. My name is William Rowe. I'm the son of a Marine who served in Vietnam, and my grandfather served in World War II. I myself, I'm a nurse. I work in Manhattan. I work in 2 nursing homes, one in Manhattan, of course, one in the Bronx. Before my nursing career, I was a stockbroker on Wall Street for 8 years. Due to 9/11, I worked in World Trade Center 1, and I was on my way to work, and I escaped the tragedy. Due to that event, I could no longer continue working in downtown Manhattan, so I changed my career. My career was changed. I was interested in nursing because it was more fundamentally moral, and I could help and benefit people who were suffering illnesses and different things like that. I have a personality basically that, you know, I can basically overlook certain things and help people feel better and overcome their illnesses and their diseases and their downtrodden spirit. My goal is to improve our residents' health, but very often residents have terminal illnesses, and I'm the last person that they see. So I try to make their last days brighter days. I try to make their families feel more encouraged that there's a better day coming. Prior to the COVID pandemic, staffing was very good in hospitals and in the nursing homes. We had no issue with that. Sometimes we had to send people home because of the staffing situation. The staffing situation was so great. When COVID came, it was a different type of enemy because it was in the air. It was in the air, and basically, not only could you get sick, you could bring it home to your family and then further progress the situation. I'm an 1199 union delegate, and I have to admit, the COVID pandemic has disturbed the staffing. Can you imagine having 40 residents, 1 nurse, 2 CNAs? Can you imagine having a floor that doesn't even have a nurse, and you have to cover your floor, which is 40 residents, and then another floor, which is another 40 residents? This is what this COVID pandemic has brought us. It's a reality we live with every day, and I'm asking this panel to look into it and help us out, because times are hard. Unfortunately, some of the workers in the healthcare industry, they are not encouraged to come back. That's one of the reasons of the shortage. Due to the fact that you're putting yourself on the front line and your needs are not being met and your dignity is not being met. Dignity can't be paid, can't pay for my dignity. But you can meet it with a proper wage, you can meet it with proper PPE equipment, you can meet it with respect and dignity. Can you imagine during this time when they celebrated the heroes, they gave us t-shirts and they gave us pins, and we were putting ourselves on the front line, risking our lives. And to be honest with you, we didn't do it for money. We did it out of our own self-will. But don't disrespect our dignity by not meeting our needs and not respecting us and what we're putting ourselves through and the sacrifices that we're making. That's why we're here today. This is the workforce challenge we have to overcome. Workers need to feel they can walk into a facility without risking their health or the health of their family. We need to make sure we have enough PPE and infection control plans in place, and workers know the plans are fully effective. Finally, we need to pay workers wages that reflect both the risks that we will face in a nursing home setting when there is a deadly virus, And more importantly, we have to pay workers a wage that recognizes the dignity and importance of the work we do every day. If we can keep them safe and pay them the wages that reflects the importance of the work, they will come into the facility. People will be more encouraged to come back into healthcare facilities, understanding that they are facing a COVID-19 risk to their very lives. Thank you very much for your time and understanding.
Thank you.
Hi, good morning. My name is Tanya Blackshear, and I work as a CNA in a nursing home in Utica. I've been a CNA for over 26 years. 26 years may sound like a long time to a very difficult job, and it is. But I like taking care of the residents, and I'm committed to making sure they get the best care they can. Over the years, I've gone to school for other healthcare positions, but from the bottom of my heart, my place was in the nursing home with those residents. The challenge is, how do we make sure there are lots of women, young women, and it is women for the most part starting out today, who will be there 26 from now. My facility has always struggled keeping new staff, and the pandemic has made this worse. It was scary during the pandemic. I remember when I had to go into a room where I knew the resident was COVID positive. I cried at first, but I put on my PPE and did what I had to do because the resident needed that care. I was fortunate not to get sick, but some did. And some quit, and they never returned. Before the pandemic, we had a lot of vacancies, and now it's worse. The current staff work double shifts, come back to the work after catching some sleep, and can be faced with having to do another double. It's brutal on the body, and people are getting hurt, like I did. From my experience, for every 10 new workers that came into the building, 5 don't make it past the probation period, and 2 make it past the first year. We do orientation every week for new staff, and we average about 9 or 10 new staff per month. That means we are seeing over 100 new staff a year, but we can only maybe keep 20. The work is simply too hard for what we are paid. Our employer thinks that because we work in a poor area, they can pay us poverty wages, but people can go to fast food and make more than our starting rates. What's happening now is our facility is mostly hiring agency staff who get paid a lot more than we do. CNAs start as $13.50 here, and agency is making over $16. LPNs at my facility are making $18.75, and agencies are coming in making over $28. Also, a lot of long-term staff are switching to per diem because they can make more. They lost their health benefits, but for them, the extra pay is worth it. We have 2 agency LPNs who have working with us on the floor since the pandemic started. They both always said that if they were offered their agency rate of pay, they would be in the house for union employees. The last time we negotiated a contract, our employer refused to raise the start rate. Now they are paying for this by having to hire agency instead. I know it takes a special person to work in a nursing home, but it shouldn't just be that way. Employers need to value the work we do. Employers have to start paying wages that are well above fast food if they want to keep people who are coming in the door. it's not that there are no workers applying for nursing home jobs. Remember, we are getting about 100 new hires a year. Employers need to pay them enough so we don't lose 80 of these 100. Thank you.
Thank you, and thank all of you for your testimony and the work you do and your stories, which are so compelling. Tanya, I wanted to follow up on a couple of things you said. You talked about working double shifts. One of the things that we've heard, that we certainly heard during the pandemic, was that people, I shouldn't say in the past tense, it's still going on, but people were working a shift at one facility and then working a second shift, but not at the same facility because they couldn't get overtime pay. So they were going to a separate facility in order to make ends meet because they needed the additional work. Is that your experience, or are people working double shifts and getting overtime pay?
There's some employees that might have did that, but the employees, that most of them, they liked the job, so they stayed there and did doubles to make sure the care is getting done.
And do they get overtime pay for that?
Yeah, they got overtime.
And then when you talk about the per diem, this is the same as the agencies that you were talking about, Grace, is that right?
So not quite. For Tanya's case, in her facility, the per diem employees are part of the union, so they remain union employees, but they just forego some of the other negotiated benefits within the contract, like health insurance and pension. And unfortunately, these members have to make that choice because their paycheck at the end of the day doesn't cut it, and they have bills to pay. But no one should have to sacrifice between a quality and affordable health insurance plan and their pension plan and making a couple extra bucks on the job.
But that's negotiated by the union as an option for the workers?
Yeah, absolutely. I mean, some of our workers would go agency and have no union job security and not have, set hours that they could potentially pick up at a facility. So in this contract, the per diems are part of the union. That's not the case in every facility.
And then the agencies that you were talking about are these essentially temp agencies that provide workers.
Separate contracted agencies that send workers to facilities to fill open holes. But more and more, because there's such high turnover, agency workers have their pick of shifts. They can come in and pick up as many hours as they want, and really they could work full-time hours if they wanted to and earn that higher wage. But when they feel that burnout, or when they're tired, they can take a step back. And regular full-time and part-time employees have a commitment to the facility and to their residents, so they continue that work.
And then you said that the agencies were often owned by the same people who own the facilities? Is that's nursing homes and assisted living facilities? Both?
Yes, my experience is with nursing homes, and that is something that we see frequently, whether it's a relative or somebody who's somewhat within that network of owners. There is usually a connection to several of these agencies, where owners of facilities have a familial or work relationship that connects them to the agencies that they contract with.
Okay, that's really helpful to know. I wanted to just end by asking you about something that I have read about in Washington State. At SEIU in Washington State has a labor management partnership with the state of Washington, with private healthcare industries, and created a healthcare Northwest training partnership that, I'll just read how they describe it. The nation's first large-scale career pathway program for home care aides. This is about home care, but I think it also applies to the aides who work in nursing homes as well. So that they work together to create an apprenticeship and have brought in 3,000 new apprentices over the last 5 years. So I was wondering if there is anything like that SEIU is thinking about in terms of collaborations with the state, with the facilities, in order to create jobs. I guess I don't know to what extent the union is involved in actually recruiting new people into the field, or do you just represent people once they have decided to enter this work? And would you be interested if this were a model that we could try to import here to New York State?
Sure, absolutely. I can actually cite two examples for you, one in Syracuse and one in Buffalo where we have LPN apprenticeship programs. We have partnered with management at 2 of our nursing homes in the upstate region to actually create a way for CNAs to go to LPN school, remain employed as CNAs while going back to school, right, keeping their jobs and their benefits so that we can help them move upwards on that career ladder. That's a joint effort between union management and with the help of our training fund. So that's where I mentioned our training fund is ahead of the game on this, and we're very involved and very excited to continue this work. We need employers to work with us.
Great. Thank you very much. Who else?
I didn't have a problem before. I actually want to begin by acknowledging your ability to come here and testify today, perhaps taking a day off from work. You know, up until this moment, we've really only heard from healthcare executives, but not the actual rank and file, not the actual people doing the work of caring for others. So I just want to thank you for taking the time and acknowledge the fact that you're able to do this because you have a union to take care of you. I'm wondering if the union has had any conversations with the second floor, with the governor's office throughout this pandemic about hazard pay for your members and for other healthcare professionals throughout this endeavor.
Yeah, absolutely. We've had conversations from the basic level with our employers to all of our elected representatives, and you know, many of our employers failed the members over the past year and did not provide hazard pay, did not provide proper PPE, but we have been exhausting every avenue to make sure that our folks get paid for what they deserve.
You know, I used to work for SEIU, Local 32BJ specifically, for many years, and I'm very proud to say I'm probably one of the few people of my generation who have a pension to look forward to. And so I'm wondering if you can describe for others what your wages and benefits are, because we've heard a little bit about what it's like to be a non-union worker in this industry. What's it like to actually have a collective bargaining agreement? What does that provide for you?
Basically, in regards to nursing, a nursing benefit package would include full-time. You get 4 weeks vacation, you get 12 sick days, you basically get 2 personal, and you get your birthday. Nice. You also receive, like, for paternity or maternity. In my case, I can't get pregnant, but I had to assist, in the birth of my child.
That's right.
So it's called paternity.
That's right.
Not maternity.
Parental
So they
leave.
provide 2 days, 2 or 3 days for that paid.
Yes.
And basically, we're looking into that to improve that in the next contract.
I would just add the National Benefit Fund, our health insurance plans, our pension plans are, key pieces of what we negotiate into our collective bargaining agreements and are crucial for retention and for recruitment into nursing home industry.
Yeah. Tanya, you work in Utica, not in the 5 boroughs, and therefore your minimum wage is very different from ours downstate. Would you argue that perhaps the upstate minimum wage was erroneously made less than New York City and should actually be the same and leveled throughout the state?
Yes, we argue so much that it should be across the board for everyone. When we come to the tables, we hear the other side, and the lawyers say, we better be glad that we got a job. I think that's insulting to say that to the members when we work hard in there, and we fighting at the table to negotiate to get what we have to get for everyone, not just certain people. So our contract is ending right now. So May, we go to negotiate again, hoping that they boost the pay rate up. We just gotta fight harder and harder so we can get the members into the building. We can't have them keep going out because you keep don't pay the right pay rates to these employees. They can go everywhere else to get more money. But sometimes when people at a nursing home and they feel like these residents are their family, we don't just come there just for a paycheck. But we still got to survive too.
Yeah, no, absolutely, and thrive, not just
Yes,
survive, thrive,
thrive,
right?
yes.
So what would those extra dollars mean for a family like yours? What would you be able to provide for your family, or, how would that change your life?
Well, it actually pay my bills. I won't have to live for paycheck to paycheck. And the extra that, the bills that I have past due, I can actually pay on them if I get a decent rate. Or I wouldn't have to borrow from my uncle, my mother, just to strive and pay what I have to pay at home.
Are you a mom too?
Yes.
Yes. Is childcare something that you currently have to deal with, or have had to deal with in your career?
Well, back then, because my daughter is 31, so she strives, and she worked in a nursing home too. So she had her struggles into a nursing home too, where she had to make ends meet too. But now she works for the state. She says she couldn't work until the facility because they wasn't paying enough. I mean, I could have went to school for anything. I went for phlebotomist. I didn't want that. I went for forensic. I couldn't do that. I don't know, from in the bottom of my heart, something told me to stay at that nursing home because these residents depend on me.
That's very beautiful. That sounds like you found your vocation, and it sounds like it might be your daughter's too. So she says she's happy working for the state?
Yes.
Can you tell us a little bit about her condition?
She was working as a regular employee, but she also went to agency because she said they weren't paying enough because she has 3 children. So she said that wasn't enough for her. So she applied for the job in Utica, and they moved her to Syracuse. Now she's going for a supervisor position, and she just bought a house because she says she makes more.
Okay, well, that's nice. I guess in what remains of my time, thank you, Zach, because I can't see that. I'm wondering if we can learn more about perhaps what the union is doing to organize new workplaces, and what that looks like, what the hindrances of organizing might be, given how remote home attendants might be if they're servicing patients in their home. I imagine that it's very difficult because there is no central workplace necessarily. What's the organizing look like?
I don't want to steal the spotlight from the home care panel, but I think it is difficult from my understanding. That's not my division. I've got the nursing home division. I can speak to our organizing efforts. For nursing homes, it's totally different than home care, right? Because people are in one place. So it's traditional union organizing. What I will say is that, just like what we see at the bargaining table with employers really, really nickel and diming us and really fighting our members on any raise in benefits or wages, it's just as difficult to organize a new workplace where our members want to bring a union into their workplace. Employers fight tooth and nail to keep us out, and that certainly has not changed. I think it's maybe gotten worse.
How do they do that? What types of methods do they use to keep the union out of the workplace? Do they use captive audience meetings?
Absolutely. Absolutely. Captive audience meetings, right? Bring in consultants. They pay, a ridiculous amount of monies to bring in union busting consultants and all of these firms, when really the workers just want a seat at the table. They want a voice in how care is delivered and in their wages and benefits at work.
Okay, thank you.
Hey, folks, thank you for being here. Just have a couple of questions. Kind of the centerpiece of your testimony actually was very much, I guess, in line with what we've heard from some of the industry earlier as far as turnover being the big issue. Obviously, the reimbursement, we've gone over this many times, right, as far as reimbursement, and we've had the conversation about cuts that happened during the pandemic. I hate to do it. Certainly, many of us fought to make sure that wouldn't be the case, but our good governor thought that it was the best way to go. Anyway, as far as reducing turnover, though, obviously the better pay and better working conditions are a key thing. Also, making sure there's a career path is also part of what you suggested. I wanted to just dig a little bit into the stats, because you seem to agree certainly the turnover is an issue, but the turnover is not as high as was said earlier, because there were certainly a lot of concerning numbers that we heard earlier as far as 90 some odd percent. Do you agree with those numbers? Were those, because obviously turnover is at the core of it, but it seems that the stats are a little bit different.
No, certainly. I think turnover is a huge issue right now. So, whether our numbers don't line up exactly, it is an incredibly pressing issue. To me, it's one of the most pressing issues right now in the industry. People come in through the door, and so it looks like your staffing numbers are okay because they're there. It's their first week on the job, but you've got numbers on the floor. What we're not seeing there, though, is these people have to be oriented to the floor. Do the staff have the time, the in-house staff, do they have time to orient the new employee properly so that they can really get a sense of the residents, of the layout of the floor, how things work? It's all extra work to have to orient a new person, and then to see them walk out the door a few days later, a week later, a month later, like Tanya was saying. Turnover is an incredible challenge right now, and people come in through the door thinking it might be a rewarding, career, and it certainly is. But right now, with the way that working conditions are, and with the low pay and poor benefits, it just really isn't worth it for a lot of folks.
So as far as the top line here, if we can assure better pay, we can assure better working conditions, and make sure that there's a career path for folks that enter the industry. Those are kind of the top, you would say those are the top line things. Obviously, each one of those is a very big bucket, but at least those are the top lines, you would say?
Absolutely, and I will say there are employers who have recognized that and who have worked with 1199, right, to do LPN apprenticeship programs, to come to the table and say, what is a competitive market rate that we can offer for CNAs? Let's actually put our heads together here and let's do what's right by these residents. At the same breath, we have employers who do the exact opposite, who don't want to work with 1199 members, who cut them out of conversations when it comes down to how resident care is delivered or issues on the floor, and who fight us at the bargaining table.
And certainly having that collective bargaining power actually assures that the folks who work in unionized workplaces have an ability to do those fights.
Absolutely. It's a tough fight, but it's one that our members take on every day.
And last but not least, if there was such a thing, I don't know, to guarantee health care for everybody, something, I don't know, legislatively, like something called the New York Health Act, as an example, do you think that you, in your negotiations, would be able to do more for your members, since them as residents and full-time employees in the state of New York would have health care guaranteed to them? Do you think that you would be able to get better benefits for your members?
Sure, yeah. Whether that's, focusing on improving that pension, or improving the wage rates, or working on a shift differential, or whether that's looking at other health insurance plans, right? Whatever that is, absolutely. If our members are able to get quality health insurance through the state,
not quality health insurance, but guaranteed health care.
Guaranteed health insurance,
here.
right?
Yes.
Then absolutely, it raises the bar. Anything that raises the bar for our workers allows us to get better for them.
Gotcha. All right. Thank you, Madam Chair.
Thank you. Anyone else? Oh, Senator Serino.
William, your story really touched my heart. We need more people like you and Tanya. During last year's testimony from SEIU, we heard from a lot of the employees that they said they had to actually wear garbage bags to work, which is so unacceptable. We have to make sure that, you have the proper provisions and you're adequately addressing them. And then Grace, you spoke about the apprenticeships. How do you let people know about them? Do they have to already be in the healthcare field, or do you offer some other outreach? Because I love the apprenticeship programs. I think they're awesome.
Yeah, for those specific LPN apprenticeship programs, they were for in-house CNAs to move forward to get their LPNs. So it was all about the union members who are already in-house working as CNAs going through this program to become LPNs. But there was plenty of outreach we did within the community. We wanted people to know that this program existed so that people would consider coming on as CNAs entry level in that way, and then moving up in the future.
Do you go into the schools too to talk to the students?
Yeah, training fund, I believe all of that would probably be in their written testimony, so I'll leave that to them, and if there's any follow-up, I'll make sure we get that information to you.
Great, thank you. Thank you all for what you do. We really appreciate it, and I can tell you guys have your heart and soul in this, so thank you.
Thank you. Senator Benjamin and then Senator Burrow.
Sure. I also want to commend you on being here, and your comments and William, your testimony was very powerful for me. I used to work on Wall Street too and left, so I completely understand your sentiment. Well, I have a question for you, actually. In your testimony, you mentioned that, you know, things were fine before COVID. And you mentioned, you know, it sounded like when I heard from you, I want to make sure I'm clear on this, that the biggest issue for us to address is sort of the safety around COVID, the PPE, et cetera, infection control plans, et cetera, more so than, say, childcare issues and some other factors. So I just wanted to get your comment on that to make sure I'm clear on what I heard from your testimony and how you feel on the ground. Because, I mean, sometimes, you know, we might sit here and have our ideas about what people need, but you're on the ground, so I want to make sure I'm clear on what I'm hearing from you.
Everyone's situation is different, but there is a priority in terms of safety. Safety is first. That's the priority. So basically, in the beginning of COVID, institutions and nursing homes, hospitals, they did not meet the level of the concern of COVID. You had workers, CNAs, nurses, buying their own masks because the masks and the gowns that the facilities were given were not worth it and didn't provide yourself enough courage to feel safe in that type of an environment. So PPE is a high priority in the nursing home or in the workplace setting. Okay, childcare. Now, life changed during COVID because schools closed. If the school is closed, then you have to think twice about what is going to happen to your kids. They're going to be home. Your schools really played a part in people's lives because they didn't have to have a babysitter because the kids were in school. By the time the parent would come home from work, pick your kid up from school, you didn't need a babysitter. But being that the schools closed, child care became a high priority and still is because parents are still reluctant to send their kids to school because of the COVID pandemic. So in terms of our priority, to answer your question, I feel they both PPEs and child care, they both hold probably the similar weights in terms of what people need in their lives, you know, in terms of your family and in terms of the workplace environment.
Well, let me just say, I just only had the question. Thank you for the work you do. I'm honored to be here and hear you speak. Gives me real sort of hope for humanity that you're out here doing this hard work. You put yourselves on the line, and we owe you a debt of gratitude. And I know myself and our colleagues can do everything we can to treat you appropriately because you did and will continue to do God's work on behalf of all of us. Thank you.
More than a T-shirt and a pen, for sure. Senator Burrell.
Well, I want to echo everyone's sentiments and thank you so much. And, you know, William, particularly listening to you, you know, staring 9/11 situation in the face, making that amazing change in your life, and then facing a pandemic, which in the end took more lives of New Yorkers than 9/11. Thank you. Thank you all for what you do, for being frontline workers. Grace, I'm very familiar with 1199. I've been to your office a few times. Worked hard with your folks, including Peter DeJesus, to fight back on the closure of a hospital in my district. So thank you for all that you've done. I just want to address the issue of which was brought up, that roughly 8 in 10 of the patients in nursing homes are on Medicaid, and we've seen 9 consecutive years of rate cuts. The most recent, the only state out of the 50 that actually cut Medicaid reimbursements during the pandemic. So we can talk about how amazing you folks were, but at the end, you know, that was continuing to burden all of you and to put more pressure and stress on all of you on top of the folks that operate the facilities. So my question is has the union stepped forward to speak out against these cuts? And I'm assuming the answer is yes, but I'm just the advocacy and the understanding that this is not just impacting the ownership, it's impacting every single one of you folks that work hard every day, risk your lives to care for our most vulnerable citizens.
Absolutely, there should be no cuts to funding for our nursing homes at all. And in fact, we'd appreciate a little more funding.
Well, and I agree with you. I mean, we're seeing, last year we passed some reforms to Medicaid non-emergency transportation, which have yet to be implemented. That's millions and millions of wasted dollars in waste, fraud, and abuse that's occurring in that Medicaid non-emergency transportation. That's money that could be directed back to supporting you folks as opposed to, paying for what is essentially fraud that's occurring on a rampant basis. We see it in my district every day. So I would strongly suggest that we continue to work towards that. We have certainly the ability, since we're already, it's a misdirection of where those funds are going. It's going to these type of fraudulent situations. I mean, even our state comptroller has said there's billions with a B every year in waste, fraud, and abuse in our Medicaid system, yet we are cutting reimbursements.
Well, yeah, I want to thank you all. I have one more follow-up, which is when we talk about misdirection. Grace, you mentioned the salaries of some of the CEOs and the money spent on consultants and everything. Here you've got somebody with amazing financial experience in addition to the nursing experience. Have you thought about worker co-ops? Are there efforts to create actual worker-owned facilities? Has that ever been thought of or tried here?
Yeah, it's interesting you should mention that. I know I've read a little bit about some kind of worker agency co-ops that have succeeded elsewhere, not in New York State. So it's certainly something to look into.
You've got all the skills there, all the knowledge. Okay, well, again, thank you all for the amazing work that you do and for your testimony. It's been really enlightening. I appreciate it.
Thank you for having us.
And I echo Senator Ramos for taking a whole day to come up here from your work, too. So just a little update. We had in the schedule to take a break at 12 o'clock, but I would like us to do one more panel because we haven't gotten that far through the program. So we're going to do panel 5, and then we'll take probably a little shorter break than we had planned. But so that's Sarah Daly, Michelle O'Connor, and Doug Wisman. Yeah, we'll start asking fewer questions. Don't be insulted if there aren't as many questions moving forward.
I've done this shit one of these for 17 hours, so you know what? I got no compassion.
Thank you.
Thank you.
All right, we have Sarah Daly to start with.
Hello. There we go. Good morning, and thank you again to Senators May, Rivera, and Ramos for convening this hearing. My name is Sarah Daly, Government Relations Analyst at Leading Age New York. Many of you know that Leading Age New York represents over 400 not-for-profit and public long-term care and acute care providers. The providers we represent embody the full continuum of services an individual may need as they age. On behalf of our membership, I thank you for convening this hearing and for the opportunity to provide testimony. As has been discussed all morning, providers across the long-term care continuum are facing extraordinary and unprecedented workforce challenges that predate the COVID-19 pandemic. A combination of the state's changing demographics, inadequate reimbursement, competitive labor markets, and regulatory requirements have hindered recruitment and retention of quality workers for many years. Of course, COVID-19 has now exacerbated existing staffing shortages and depleted provider financial resources. Our members report more severe workforce shortages statewide than ever before. They are trying every possible creative strategy to recruit and retain staff, from signing bonuses to career ladder programs of their own. Still, they report dozens of open positions and few, if any, applicants at this point. Of course, An important component of any workforce conversation is wages. New York's long-term care providers cannot raise wages to compete for workers because they are vastly underpaid by their predominant payer, Medicaid. They have not received a Medicaid rate increase since 2007, despite rising costs, and have experienced steeper cuts than any other healthcare sector year after year. The $64 million included in the 2021-22 state budget for nursing home staffing is barely a third of the $168 million in annual Medicaid cuts imposed on nursing homes in 2020. As Senator Barrio touched on earlier, New York was one of the only states in the entire country that actually enacted Medicaid cuts during the pandemic. Most other states did provide increases of some kind. The financial stress on long-term care providers has been further aggravated during the COVID-19 pandemic by falling census figures, extraordinary pandemic-related costs, and the additional Medicaid cuts enacted in 2020. Unfortunately, the state has not pursued comprehensive and proactive investments for regulatory reforms to address our aging population and their needs. Like many individuals who avoid planning for their future long-term care needs, New York has no plan and has made no investment to address this crisis. Notwithstanding the demographic wave that is already driving up demand for services and limiting the supply of workers for the past several years, the state has focused its healthcare investments on the acute care and primary care sectors and its budget cuts on the long-term post-acute care sector. We need resources to bring new workers into the field and to enhance their compensation. As many of our not-for-profit providers do pay higher than minimum wage as it is, or would like to pay even more, but they simply do not have the resources to do so. Ultimately, our not-for-profit members will not continue to operate if they cannot safely staff their facilities, and they will be forced to close their doors to sell to for-profits. We've seen this already. Since March of 2020, the start of the pandemic, we have lost one not-for-profit nursing home in Westchester, 2 upstate homes have announced fall closures, at least 2 are for sale in New York City, as I believe was also mentioned earlier, and several on Long Island have been sold or are in sale negotiations. An assisted living facility that served Medicaid beneficiaries closed in Western New York that is a member of ours, and another is in the process. A number of other nursing homes and assisted living providers are evaluating long-term viability at this point, given the continuing financial impacts of COVID-19 and the deficiencies that were existing beforehand. If New York is to ensure access to high-quality care for a growing number of older adults in our communities, we need to infuse resources into the system, identify ways to attract new workers, and implement reforms that enable optimal use of a limited workforce. As outlined in detail in our written testimony, Leading Age New York proposes a multifaceted workforce plan that would include both substantial investments and no-cost regulatory and statutory reforms to reduce barriers to the recruitment, retention, and efficient deployment of nursing home, assisted living, and home care staff. On the medication, I know I'm running a little low on time, but on the medication technicians issue, Leading Age New York does have a bill that we've drafted for that, and we believe it would be a great step in the right direction to, again, enhance the career ladder for CNAs and help them see kind of an easier step between CNA and LPN, a bit more tangible for them to maybe wrap their minds around, and also, of course, taking the stressors off of the RNs and the LPNs themselves. Unfortunately, right now, there are many LPN vacancies, so if we can perhaps just train our CNAs a bit more, again, kind of showing them the way, we believe that would be a big help. If there's one point we wish to leave you with from this testimony, it is that the legislature must make long-term care its top priority in the state budget for state fiscal year 2022-23. A substantial and meaningful investment of Medicaid and non-Medicaid dollars must be made in long-term care that will enable material increase in wages and associated benefits. Thank you very much for your time.
Thank you.
Oh, is that on? Okay, great. Good morning, Senators May, Rivera, and Ramos, and distinguished members of the Senate Aging, Health, and Labor Committees. My name is Michelle O'Connor, and I'm the Legislative and Policy Director for Argentum, New York. Thank you for the opportunity to speak with you today to discuss workforce issues in assisted living residences and adult care facilities. Argentum, New York is the New York chapter of Argentum, the largest national association representing professionally managed senior living communities. Argentum, New York represents 75 communities across the state, serving over 7,500 residents. The population is aging nationwide, and New York is no exception. The U.S. Census Bureau projects that by 2060, 1 in 5 Americans will be over the age of 65, and the over 85 population will have tripled. The National Investment Center for Seniors Housing and Care estimates that to take care of this aging population, our country will need to have at least 1.4 million senior caregivers by 2025, which is right around the corner. Currently, 3.2 million New Yorkers are over 65, and this population is growing faster than any other age group in the state. As more and more seniors are choosing options that allow them to age in place with appropriate supports and services, including residing in assisted living residences, supporting and expanding the frontline health care and senior caregiver workforce has never been more critical. Over the last 18 months, the pandemic has presented providers with innumerable challenges as they worked and continue to work around the clock to provide high-quality care, supports, and services to their residents while protecting them from COVID-19, which exemplifies how crucial these workers are in caring for our seniors. One of the greatest challenges providers face is adequate staffing. Repeated and numerous staff furloughs due to COVID-positive tests and/or exposure, childcare issues has made it even more difficult to meet the staffing needs of communities. Additional staff has been required of every assisted living community in the state to meet the infection control protocols required by the Department of Health, ensure safe visitation, and conduct health screenings for all individuals entering these communities. Even as our providers offer additional hero pay, child care support, and transportation assistance, they still struggle to ensure appropriate staffing levels in their communities to care for their residents. Yet they meet these challenges every day with no financial assistance from the state and very little from the federal government. We have requested an allocation from funds from the funds New York received from the American Rescue Plan Act to help offset the tremendous financial losses our providers have incurred as a result of responding to the pandemic. To date, we have not heard that allocation will be forthcoming despite the letter of support sent to the Commissioner from many of you, which we really appreciate. We will be requesting the legislature provide fiscal relief to assisted living and adult care facility providers in the upcoming budget. Through our consultation with Argentum National, we know advocacy is ongoing on the federal level to support senior caregiving workforce strategies, including expanding and supporting workforce development programs, identifying and modifying existing federal programs within the Department of Health and the Department of Labor that use evidence-based approaches to increase earnings and create apprenticeships that will keep local senior living communities competitive so that they will attract jobs. Expand education training tracks. Senior caregiving can be a long-term career with job security. Building and implementing competency-based education pathways from high school to and through community and technical colleges to four-year colleges and universities as appropriate, and offer loan forgiveness for individuals entering the senior caregiving profession. New York created a new category of home health aides known as advanced home health aides in 2016, which would have created such a pathway for advancement. However, there are a number of barriers, including funding and regulatory requirements, that have made the program extremely difficult to implement. Immigration reform is also important. While training and education programs can create a pipeline of competent caregivers, they should be supplemented by a skills-based immigration system that responds to the demand from growth sectors for qualified individuals to help address the workforce shortages in critical occupations, including senior living. I'm just going to touch on a couple other state models. Other states have developed programs that encourage and build upon senior caregiving workforce that New York may want to replicate or modify. For example, California has a senior care workforce development program that includes partnering with schools, career centers, and vocational schools with programs just relevant to senior living. The program also includes creative recruitment strategies that provide additional training and opportunities to advance in the senior caregiving arena. Also under development is a community college trade school senior care certificate and a partnership with a nursing program that includes a rotation in assisted living residences. Caring for our seniors is of the utmost importance as our population continues to age, and it is imperative that we focus on investing in, expanding, and supporting the senior caregiving workforce. Thank you.
Thank you, Senator May, Rivera, and Ramos. My name is Doug Wisman. I am a board member of Greater New York Healthcare Facilities Association and a CFO of a large facility in Queens, New York. And I also am a trustee for the 1199 Welfare and Benefit Funds. So I've been in this business for 27 years, and over the last 2 decades, there's been numerous funding initiatives to help the facilities maintain their staffing levels, from healthcare retention and recruitment add-ons, to grant opportunities, to funds that we work directly with 1199 to provide training and development of staff. Due to these strategies, we've been able to maintain our staffing levels and provide care for the patients in New York. Unfortunately, that all changed during COVID. Overnight, we went from being fully staffed to having a situation where almost all of society shut down and was locked up in their homes, except for our workers and other essential workers. Many of our staff had comorbidities themselves and elected not to come back to work. Our staff was already aging, and many of them decided to retire early because of the fear that they had. A tremendous amount of our staff was just plain afraid to come to work. They have children at home, they care for elderly at home, and it presented a huge problem for the entire industry. The staff was afraid to get on the trains, the buses, or whatever transportation they utilized to get to work. Fortunately, we were able to maintain staffing levels where it was safe for the residents. Our census was impacted greatly by the fact that many elective procedures in hospitals were delayed. Patients were, or potential admissions were not leaving their homes, people were not falling, people were not getting the flu. So our census dropped dramatically. That was somehow how we were able to maintain our staffing levels. Now, as we move forward, we're starting to see our census improve. Unfortunately, many of the staff are not coming back. There are shortages of LPNs and RNs and even CNAs in certain sections of the state. It's not a one-size-fits-all. There are CNAs available for certain shifts, for weekends. It's a problem. You know, there's staff, we're a 24/7 business. It's not always the same that there's CNAs or nursing staff that are willing to work the shifts that we need. And in order for us to retain and recruit staff, we need funding. We have programs where we develop Jerry aides into CNAs, and we pay them while they attend school to become CNAs. We sponsor CNAs to become LPNs. These programs all require funding, and the majority of the industry is suffering catastrophic losses at this point. Our facilities are in dramatic danger of not surviving. The censuses are historically low. They're starting to creep back, and I am concerned that as our census improves, that there's not going to be enough staff to take care of the patients, in which case many facilities will be forced not to admit patients, and there could be an issue with access. We are requesting that, along with additional funding, that the state really looks at all these programs that were presented today to really expand the workforce collectively with the stakeholders, with 1199, the collaborative approach with the union, with the associations, so that we as New Yorkers can go forward in the future. These facilities are our infrastructure, and it's key that we maintain our infrastructure as our population ages, so that we can have places where our citizens can be taken care of. Thank you.
Okay, thank you. So we heard from the previous panel about high executive salaries and the expenditures on consultants coming in to help keep unions out or whatever. I'm wondering how much of your budget actually goes directly to care for the residents?
Our facility currently meets all the requirements that are in this budget, meaning we're already spending well in excess of 70% on our direct patient care. In addition, we exceed the 40% on direct facing care. That, to me, is not necessarily the issue. The issue here is the flexibility within the budget that allows us to spend where we need to spend money. And acknowledging that there is a shortfall in the funding, there is no flexibility. I can tell you that depending on the acuity level of our different units, we staff it differently. And if we look at it as an average, we're meeting these requirements with a number of hours. But on certain units, I may need more CNAs, I may need more RNs, I may need more LPNs to basically have language that kind of puts us in a box where we're not able to adjust. And there may be a facility that has a disproportionate of number of patients that require different level of care, where they might not fall into those regulatory numbers. That could present a problem in the future. The other issue is right now, I'm in major competition with every other building, with every hospital, with every doctor's office. There are no LPNs and RNs. It takes a special person to work in the long-term care industry. And there are many RNs and LPNs that find it much easier to go and work for a hospital where they get 3 12-hour shifts, for an agency where they can dictate the hours that they want to work, or even a doctor's office where it's 9 to 5, 8 to 4. Those are the challenges we face.
Okay, thank you. And you mentioned about needing to put different kinds of staff in different places. I'm wondering about the long-term care residents who are maybe not classified as needing acute care or whatever. Do they tend to get the least of the, say, RN time and that sort of thing, whereas post-op recovery may get...
Again, there are different clinical issues where different patients have clinical needs where it could require a nurse for wound care, CNA for behavioral issues. I am not personally a clinician, but those are the issues that we see on different floors if there's a high acuity for patients who are receiving wound care, which could be long-term patients. Behavioral psych patients require direct hands-on CNA hours. There are patients, for example, Lewy body dementia, which may require one-on-one. It's very different depending on the acuity of a patient.
Well, thank you so much for the work you do and for your testimony. I will see if we have other questions.
I'll ask one quick question.
Okay. Senator Benjamin.
Be very quick. Doug, you made some interesting points around flexibility, which I generally think is logical. I guess my concern is how do we ensure within some flexibility that might be necessary for a certain facility that there's accountability towards ensuring that the appropriate resources are going towards care for residents while having that flexibility? Do you have a thought?
We're in a very highly regulated industry. We have annual surveys. We have 5-star rating, which we submit quarterly MDSs, which measure acuity of patients. There's a lot of data out there that could substantiate outcomes without tying us to certain metrics. And I know my building has been 5 stars since the day the 5-star rating was initiated. And we take a lot of pride in providing the appropriate care for our patients.
Questions? Senator Serena?
Hi, everybody. I just want to say thank you for being here. And, I agree with you. It's not one size fits all. You don't know who you're going to have in the facilities. And I think that really puts a strangle on you because, like you said, Doug, you're a 5-star facility. So I didn't have a question today. Just wanted to say thank you for being here and your testimony and for all that you do.
Let me follow up with one final question, which was about the LPN vacancies. Was that you, Michelle, who brought that up? Oh.
Yeah. Yep.
Do you have a sense of how New York compares to other states in terms of that kind of staffing shortage?
I don't have a sense of that, but we could certainly look into it more closely for you. I mean, I get the impression that certainly New York's not alone in facing this demographic shift. We all know that millennial generation is having fewer children, and you know, this shift is kind of long-standing, right? But we can certainly look into that for you. We just know our members have had LPN openings before the pandemic that have gone unfilled. And so for us, a medication technician role could take some of the stressors off of RNs and LPNs that are there, and also encourage CNAs to get a sense of what more responsibility might look and feel like. I'd also like to note that assisted living doesn't have medication technicians currently, and Michelle might be able to elaborate on this. They can assist residents with self-administering medications, but they can't administer non-invasive medications themselves. But med techs do currently exist in the OPWDD settings, and training is already available for that setting that could easily be used for nursing homes. And we've seen a lot of success with this model in other states, such as Maine. They have med techs for, I think, over 10 years now, and they've seen great success with it. So we just think it's time for New York to really start thinking more innovatively in this way.
So are there workers who are classified as med techs, but they do something different in assisted living?
No, there's not an actual med tech role in assisted living. Michelle, do you want to elaborate on that?
Yeah, no, we don't have a med tech category at all. Medication, as Sarah said, can only be administered by an aide. Like, they can hand it to the person, but it's like a self-administration, and there's like 6 steps they have to go through to do so. LPNs and RNs are the ones that can administer, and then it's usually only in like an EALR setting, which is an enhanced assisted living residence, because there's some barriers that basic ALRs don't really employ nurses necessarily that can at least work in their nursing capacity. Right. So there's a little bit of I guess a barrier in terms of that. Which is one of the things, like that was one of the great things about the advanced home health aid category, because they would have been allowed to, well, they are allowed to administer medication, you know, after completing certain training. But as I said, we were having a lot of trouble getting that one off the ground.
So the category exists, but there are no people who actually have that.
There's a lot of barriers to it. Funding is one of them. Just getting a training program that you know meets all of the regulatory requirements. There's also some educational requirements that we kind of thought were a little greater than necessary for this category of aid, but
so it's a category that exists, but we don't have any mechanism for having people
we don't have it.
actually
It's not off the ground yet.
get that. Okay, all right, that's helpful to know. Thank you very much. Thank you for your testimony and for the work you do.
Thank you.
All right, we're going to take a 20-minute break here and come back for our last few panels in the nursing and assisted living realm, and then we'll move on to the home health area. All right, we're on. Okay, thanks. Welcome back, everybody. We're on the 6th panel of our hearing, and that's Dallas Nelson and Deirdre Gilkes. Not sure I got that pronunciation right. I also want to mention a switch on panel 8. Agnes McCrae, who was scheduled to testify a lot later, she came in from Syracuse on a train at 5:30 this morning, and she's got a 4 o'clock train to catch home. So we're putting her on panel 8. But for panel 6, we'll start with Dallas Nelson.
Hi.
Hi.
I'm Dallas Nelson. Good afternoon, and I love talking to you while you're well hydrated and nourished. But thank you for the invitation. I'm from Rochester, New York, but I'm here representing the New York Medical Directors Association. That's an organization that's goal is to educate and advocate for long-term care medical directors and medical providers. I also direct a group that serves as primary care for 15 nursing homes and 33 senior living facilities. I am the medical director of 2 nursing homes 2 assisted livings, and one of those nursing homes served as a COVID-positive unit for the state. I also have primary care patients across the continuum of care, of long-term care, and I am a granddaughter of a nursing home resident. So I wanted to let you know that an engaged, knowledgeable medical director can genuinely improve a facility's care by applying science to care. And one of the things we medical directors are supposed to be experts in is quality assurance and process improvement, QAPI. And QAPI teaches us that the systems generally create the outcomes they are designed to produce. The long-term care system is currently producing a severe shortage of frontline workers, namely nurses and CNAs. Before COVID, the staffing levels in some of my facilities was below what was needed to render proper care. The staff was chronically stressed, and because they were covering more work than they could possibly do. The long-term care industry was plagued by frequent turnover of staff and leadership. Then, COVID-19 made the nursing homes the center of the hotspot of the most serious outcomes of the pandemic. And each surge of the pandemic decreased staffing further in my nursing homes, further worsening our ability to respond to the pandemic and make the residents safe. The rate of death of nursing home workers was amongst the most dangerous jobs in America. CMS, Senator Mayer, said that it was 80 deaths per 100,000 FTEs, which is higher than the logging industry. Frankly, the long-term care facilities became an environment of overwork, fear, and danger. I can write the most beautiful state-of-the-art medical plan for my patients, but if nobody is there to execute them, it does not matter. As a society, we are paying in human suffering for the current long-term care system. Our parents and grandparents are suffering from staff shortages, and as a result, there's a greater incidence of falls with fracture, death, secondary to failure to thrive, and skin breakdown. The problems are not a result of laziness or greed. The quality improvement teaches us that searching for bad apples will not necessarily result in widespread positive change. More effectively, we need to bring together people with deep knowledge of the system, frontline workers, and those who control the resources and regulations to study the root causes of the problem and design interventions to fix the system. The pandemic highlighted how intertwined all the levels of healthcare are. We need patients to move from the hospital to the nursing home, back to their assisted living and home, and vice versa. At each level of the healthcare system is needed to serve the entire complement of vulnerable people, and they are all competing for similar finite pool of resources. The New York Medical Directors Association felt that the Reimagining Long-Term Care Task Force was a good first step in that direction. It may be too late for that bill, but we would like further legislation to spur on the effort to start to redesign the system of long-term care. We know this can be done. We also know that we can have a collaborative relationship with government. The Colorado Medical Directors Association regularly meets with their Department of Health to work to fix their long-term care system. And we would hope to have a collaborative relationship with our Department of Health. Assisted livings need supports to be able to respond to infectious outbreaks, which currently do not exist. And our hope is that all the stakeholders responsible for the care of the vulnerable elderly will work together to collaboratively improve the system. Thank you.
Thank you. And I don't want to mispronounce your name again, so I will let you introduce yourself.
Hi, my name is Deirdre Gilks. I'm a registered nurse. I'm presently employed at Rutland Nursing Home, which is part of Kingsbrook Jewish Medical Center. I'll just tell you a little bit about myself. I was a CNA. I started out as a CNA in the same nursing home, worked my way up to become an RN. I went part-time, so it took a little longer than the person who would not generally go full-time. With me is my daughter up there. She's 12, Gabrielle. And I brought her here to see, what it is about, not just, mommy buying you this or that, So the problem we're having now is Rutland Nursing Home has about 446 beds, including an acute care vent unit of 30 beds, an acute step down with 34 beds, a pediatric unit, and a rehab subacute, and several regular long-term units. Staffing has been a chronic problem in nursing homes and long-term care facilities for many years. COVID has just opened up what was been long ago been happening. Okay, at Rutland, for example, the RN staffing in our acute vent and step-down unit has worsened, and there are fewer RNs assigned to those units. And I'll explain. For 29 vent units, you have only 1 RN with 2 LPNs. That's like a disaster waiting to happen. These are acute patients. They came directly from the hospital to us, and some of them are unstable. Sometimes the facility, they look at just numbers, not acuity of the patient. And we are burnt out, the nurses. In addition, on many of our long-term resident units, there are no RNs assigned to provide direct patient care. They are staffed entirely by LPNs and aides, which an RN manager oversee the direct care. The reductions in RN time for both regular long-term residents and patients on the acute unit impacts the quality of care and contributes to staff burnout and turnover. The situation we faced during the worst of the pandemic made staffing the resident care worse. Many staff were exposed to virus and become sickened, and others quit or retired because of the horrific working conditions we faced. We believe that legislature should consider the following measures to improve recruitment and retention of staffing in our nursing home and to create a more stable workforce to provide care for an increasing aged population. The new nursing home staffing law is a good start, but it does not go far enough. The new law sets minimum of 3.5 hours of total nursing care, including RNs, LPNs, and aides, of which at least 2.2 hours must be nursing aides and 1.1 hours RNs or LPNs. Many nursing homes are already meeting this minimum standard, and it does not set a minimum number of registered nurse hours per patient. And I'll give you an example. On Friday, I had 47 patients with 3 nurses, including myself. I'm charging 47 patients, the auxiliary staff, I have to document, I have to discharge, do care plans. It's not enough time, and it's too much. We think that the legislature should amend this law to phase in higher staffing requirement in stages with a goal of 4 to 1 hours of total nursing care, including at least 0.75 hours of RN time per resident day. RNs are very important to assessing patients, implementing care plans, and ensuring that infection control protocols are fully implemented to protect residents and staff. In addition, it is important to establish separate direct nursing to patient ratios for the acute care units where residents are permanently vented or under more intensive care. These acute care specialty units should not be included in minimum nursing hours calculations for the residents on the regular long-term floors. Improve staff working. Salaries and working conditions in the nursing home industries are worse than in hospitals and other Articles 28 facilities. This is a major contributing factor in the high turnover and staff burnout. To address this issue, the legislature should consider measures to require or incentivize employers to meet local, regional, or statewide benchmarks for pay and health and pension benefits. In addition, the legislature should consider enacting legislation to mandate that all employers create active committees in all nursing homes that give the workers a direct say in establishing staffing plans, infection control, and other workplace safety policies and general work conditions. I'm not done, but time is up.
Time is up, but thank you so much. Thank you to both of you for your testimony. I wanted to go a little deeper into something you said about how the facilities look at just numbers and not the acuity of the patient. I think that was.
Yes, that's one of my biggest fight, pretty much every day, because they'll say, okay, you have 3 nurses and this is what the state is okay with. Therefore, they're not penalized because we give you the minimum what the state says is required, but the acuity is much higher. You know, we need more staff. It's just what it is. We need a law which recently passed, but they need mostly for nursing homes to say, okay, as an RN, I have 10 patients per nurse, not 20 patients per nurse. How much can I give to that patient? And these are patients that are you and I, that have aged, that have retired, that are now in nursing homes, that had lives that you and I lived. You know, not just an old person in the bed, or is somebody's mother, grandmother, aunt, uncle. And we can't just look at them as numbers. And that's what I've been advocating and fighting for pretty much every day. Every day.
Right. I hear that and I appreciate it.
So we
Thank
need
you for-
ratios. We need ratios to nurses, just as what they have in the hospital, 6 to 1. I've moonlight many places. In the hospitals, I have 6 patients to 1 nurse. In the nursing home, I have 20 patients to 1 nurse. Sometimes you have 40 patients to 1 LPNs. It's impossible to direct good care, good quality care. It's not getting, they're not getting it, period. They're not.
Judging from your testimony, it sounds like the nurses often spend a lot of their time managing staff rather than on direct care. Would you say that's true? And are they the right people to be doing the?
When you say managing staff, what do you mean?
Well, I'm just taking from what you said, that the nurses would be deciding how.
No, I'm saying if I have 20 patients, how much care can I deliver, you know, safely with 20 patients? It's too many patients.
But you're not then supervising CNAs or?
I'm still doing that. I still have to make sure they do what they have to do. I do these assignments. So I'm the nurse in charge. I still have 20 patients. I have to do the assignment for the CNAs and the LPNs, and then I have an assignment for myself also.
See, that was what I was wondering. How much of your time goes to making those assignments?
So it's a challenge every day.
Okay. I have some other questions, but I'd like to see if anyone else is. Shall we? Okay.
So first place, I want to thank both of you from different perspectives, because your focus is on the care. And it's so appreciated by me, and I think those of us who all experienced COVID, that your focus is on the patients. I really do appreciate that you are talking about that in such a serious way, both of you. Doctor, I'd like to ask you, you gave an example of states where there is regular conversation between medical directors of facilities and the State Department of Health. Has there been any of that here?
So has there been here?
Here in New York.
We have been privileged to have intermittent presentations from the state at our meeting, but we don't have collaborative, sit at the table sort of discussions on how to manage those, which was very evident throughout the pandemic. Many regulations rolled out very fast, and many of them were, if I was like, do they know that's not possible, you know, to do, such as the twice-a-week testing. We were getting the results about 14 days after we got the first one, and we had people working positive, but we didn't know because we didn't have the resources to implement the policy.
And not to focus exclusively on these rules, but the rules came out without input from you as medical directors, correct?
That's correct. And usually on Sunday night, about midnight.
Yeah. So we all lived through it too, because our families had to experience the consequences, but thank you for that. And then on the nursing side, you gave the example in a vent unit,
Yes.
right? Are these
Ventilators.
Yeah, long-term vent patients or post-COVID vent or mixture?
Long-term. So they might be coded in the hospital, and they brought to us
as event
patients. Yes. So some are stable, some are very unstable. But the hospital cannot keep them anymore, so they come to us.
And they cannot go home.
They cannot go home.
So 29 patients with one RN.
One RN, sometimes with one RN and 2 LPNs.
Is that a night shift ratio or a
Sometimes
day
night
shift?
shift ratios, yes. When
And-
they're severely short, yes, daytime.
And so you are a member of NYSNA?
Yes, I am.
Correct? And NYSNA has a collective bargaining agreement? In the
Yes.
facility you're working in?
Yes.
Does it have any ratio?
There's a ratio at least, I believe, 4 RNs to 1 LPNs. Sometimes it does not occur.
I see, okay.
And I'm mostly from the subacute rehab. So
Yes.
people that do like the knee surgery in the hospital, they would come to us, and then we would, give them the rehab and so forth, and then send them home. So the turnover is pretty fast. And some of these patients also has COPD. They have
Yes.
other issues other than the knee surgery that they may come in from. So they are, some of them unstable, pretty unstable. Respiratory issues in the heartbeat, they're coding and so forth.
And of your colleagues that work with you, other nurses and CNAs and others, LPNs, approximately how many became COVID positive? Do you know, in your
Pretty
facility?
much, I would say 90%. I was one of them.
90%?
Of the staff, yes. A lot of us got sick. Because before COVID hit, apparently it was around. We didn't have masks on. I was given medication. The patient coughed, not knowing he had COVID. We thought it was the flu symptoms. We tested him for the flu. Turned out it was COVID. Then I caught it and it just spiraled down right then. I was out and I came back and it was just horrible. A horrible experience that I'll never forget.
I'm so sorry.
We lost so many patients too, so many. It's nothing like what you see on the television, nothing, nothing.
Yeah, well, thank you for sharing, because we do know how terrible it was. We don't think it's like
I
television.
remember my husband said, "Are you going back to work? Do not go back to work." I was like, "I have to go back. Who's gonna do the work?" Even my daughter, she was crying, "Mommy, don't go back," but I had to.
I'm so sorry.
But
Well,
somebody have to do it.
Thank you for coming. Thank you for what
Yeah.
you've done, both of you. Thank you for what you've done. And there's consequences to
Yeah.
all the sacrifice you made, and we have to make sure we address them. So thank you for being here.
Yeah, thank you. We're so glad that you're here. We're so glad your daughter has her mother, and for the work that both of you do. Let me ask a couple of brief questions. One of them is, you said you started as a CNA,
Yes,
and
I
now
did.
you're an RN. Are there ways that the state can help people make that transition, develop from CNA to RN if they want?
Okay, with my hospital, it's a hospital and a nursing home joined together. But at the nursing home, we have 2 unions. We have NYSNA, we have 1199. So 1199 has this program where they are now doing, where the CNAs are upgrading. We presently have them in school, and they're doing their LPNs. So hopefully, we're hoping that when they're completed, that they'll come and give back to the facility, and that's what we're hoping for. So they do have that. 1199 has that program. NYSNA, I'm not sure, but I did that on my own, though. I just went back to school and just did what I
Good for
did.
you. Fantastic. And then, Doctor, I wanted to ask you about the input issue that you raised about being able to meet with the Department of Health, for example, and have them hear your input about these things. Is there nothing like that now in New York State? I'm glad that Colorado has a model, but it's startling.
Right. Colorado has a journal club, and they all get together and learn the state of the art and geriatric care together. I lectured some of their state DOH surveyors in Colorado, but we don't have that sort of dialogue as geriatric medicine experts and experts in long-term care. We would love to have just a dialogue about the application of different regulations, the effects of those, what would incentivize that sort of the best practice in our industry and what it's like, you know, on the ground. We really, medical directors, you know, we don't have jobs if the facilities don't exist, but we're primarily there for the patients and really want to advocate for them getting good care. And it's hard to do.
Okay. And finally, I do have a bill to try to incentivize more people to go into geriatrics, but I don't know if you have ideas about how we get, I know there is a crisis like all these other workforce crises we're talking about in people specializing in geriatrics, either at the nursing or the physician level.
Mm-hmm. Yeah, I mean, geriatrics as a medical discipline is not considered real medicine. I don't know how to even, it's reputationally difficult, but I love taking care of these patients. But it's one of the few specialties that you can train longer and get paid less in. So it's hard to attract people into a field that is, number one, not respected because of ageism in society, and then remunerated more poorly, and works in conditions in which you can write orders and they will not be executed due to staffing shortages. You know, that is a very, very disturbing thing for a doctor to go through. And you have a very hard time keeping doctors in a situation where they cannot render good care.
Well, as somebody who used to teach at the college level, I'm very familiar with the training extra years and earning less. But can you just take 1 minute left and describe what geriatrics is for someone like Gabrielle, potentially? When I heard about what geriatricians do, it's actually a really exciting field, potentially.
Oh, geriatrics, I love geriatrics because I get to take care of complex patients, right? And I must balance their multiple comorbidities to, the primary goal is that they do well, feel well. So it's very patient-centered, it's very individualized. You can't apply all the guidelines to every patient or you'll hurt them because they're so complex that all the guidelines conflict. And you also have the opportunity to listen to them more and work to hone their care to what they want and what they want out of the medical system. There's nothing cookie cutter about the medicine that I practice, and it's very rewarding to be with people when they need you so much.
And you're looking at their medical situation, but also their social situation and their family situation. There are so many dimensions to it.
Yes, it's a very person-centered care, and individualization of the care is very important. So you need to know the medicine so that you can apply it very carefully to this very vulnerable population.
Thank you for that. We want to lift up geriatrics as much as possible. Anyone who's listening, think about going into this field. It's an important one. Thank you both for your important work and for your testimony.
Thank you for having us, Liz.
All right, panel 7 is Hannah Diamond, Maria Alvarez, and Lindsay Heckler. And we'll go in that order. Hannah, if you want to start.
I want to thank the Standing Committees on Aging, Health, and Labor for hosting today's hearing on the nursing home, assisted living, and home care workforce in New York State. My name is Hannah Diamond. I am the State Policy Advocacy Specialist at PHI, a New York-based national nonprofit organization that has been the nation's leading expert on the direct care workforce for 3 decades. PHI works to transform elder care and disability services by promoting quality direct care jobs as the foundation for quality care. My testimony today focuses on the nearly 530,000 direct care workers, including nursing assistants, home health aides, and personal care aides, who assist New Yorkers across long-term care settings. Action is critically needed to support the current workforce, recruit new job seekers to strengthen the pipeline into this sector, and to help ensure that we never again reach such a crisis point as we did during the pandemic. To that end, I would like to highlight opportunities to improve jobs for direct care workers and increase the availability and readiness of this workforce. First, the legislature must increase compensation for direct care workers. As a result of low wages, often unpredictable hours, and limited annual earnings, nearly 50% of direct care workers in New York live in or near poverty and rely on public assistance, and many are leaving the long-term care sector for higher paying opportunities. Although our written testimony provides 4 recommendations, I will expand on 2 to improve compensation for direct care workers. First, the legislature should direct the Department of Health to establish, with stakeholder input, livable and competitive base wages for direct care workers across long-term care settings. The Department of Health should integrate these base wages into Medicaid rates through a transparent rate-setting process. And then the Department of Health must also mandate a base rate that managed long-term care plans must pay providers to fully cover costs associated with labor. Second, the legislature should enact and fully fund the Fair Pay for Home Care bill. By providing home care workers with a living and competitive wage, this legislation will attract and retain workers and help overcome a worsening workforce shortage. If enacted, this legislation would lower poverty rates among home care workers, reduce expenditures on public benefits, and increase spending within local economies. Second, we must strengthen direct care worker training. Current training standards and programs, for the most part, do not sufficiently prepare workers for their complex and challenging roles. The first recommendation would be that the legislature should direct the Department of Health to facilitate consistent feedback from all relevant stakeholders to monitor the state's implementation of the state's ARPA spending plan. This oversight is critical for ensuring that all of the provisions within the plan are appropriately implemented, including but not limited to those related to training. Second, because the Workforce Investment Program's funding ended in March of this year, immediate financial support is needed to ensure that WEOs can continue to meet the training needs of the long-term care workforce. The legislature must provide immediate bridge funding for WEOs so that they can continue fulfilling their important role, either through the ARPA spending plan, if it's approved, or through other funding mechanisms. And third, beyond this initial bridge funding, the Workforce Investment Program should be reviewed and renewed for an additional 4 years, with key amendments based on lessons learned. Third, we must create opportunities for advancement for direct care workers. Career advancement opportunities within direct care are also critical for retaining workers, for amplifying their contribution to care, and achieving quality outcomes and cost savings. To develop advanced roles, PHI recommends that the legislature enact and fully fund the Home Care Jobs Innovation Fund. And second, as the new 1115 Medicaid waiver is designed, the Department of Health should consider building in advanced role demonstration projects. And finally, PHI recommends that the state convene a direct care workforce task force to develop a coherent and sustainable response to the challenges facing the direct care workforce in long-term care. To produce evidence-based recommendations, the state must also improve its efforts to collect data about direct care workers across all long-term care settings. To accomplish this, the state must survey all relevant departments and agencies to catalog existing workforce-related data collection mechanisms, as well as to identify gaps and inconsistencies. The state must also survey direct care workers themselves to make sure that their voices are included in discussions surrounding challenges and solutions. In conclusion, PHI appreciates the opportunity to testify today and looks forward to ongoing conversations about how to best support direct care workers in long-term care. Thank you.
Thank you. Yes, Maria.
Yes, hi. Good afternoon, I guess. Thank you very much for holding these important hearings. My name is Maria Alvarez. I am the Executive Director of New York State-wide Senior Action Council, and we are a consumer-directed and consumer-governed organization.
Is your mic on?
Yeah, I don't know, your mic is on. I think maybe it's not.
Go ahead, say again.
Hello?
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 Okay.
That next year will be 50 years old, so. Today, we've heard wonderful testimony from my colleagues here, and I've given you my complete statement. So I wanted to just less than 4.5 minutes to talk about some issues that I think we need to keep up in front, and that is the community. So my testimony will be one that will identify issues as they're affecting elders and caregivers today and the impact this will have for the future, along with possible solutions for your consideration. Right now in New York State, we have more people who are 65 years and older than are 13 years and younger, which means that this is an aging state, and all of these issues about nursing home and care and home care are really the future, is really what's going on, because there are going to be 1 million more seniors 65 and over after between the year 2016 and 2026. So, and you know, just to talk about what the doctor was saying before, when anybody talks to me about healthcare, 2/3 of the cost of healthcare that comes out of the Center for Medicare and Medicaid Services is on seniors. So when anybody talks about healthcare, we should be keeping senior citizens up in front, because those are the consumers. Anyway, I wanted to talk to you about something that's going on in the community. So, and it's calls that I receive all the time. People are not being able to go back to work because their loved ones are not cared for. There's a workforce shortage. So we have people, and these calls that I receive are about people who are not able to get back to work because there's not care for their mother, that they can't do. So what do you say? Okay, we'll go on Family Medical Leave Act. Well, then we're asking women of color, mostly, who are caregivers, that's who the pool usually is, to stay home, caring, doing a very hard job for and collect 67% of their paycheck every week for 12 weeks, because that's what it is, right? Or and if it runs out and they can't receive that health care, that home care, they won't have pay, because their jobs won't be able to pay for them for something that they're not doing. But what I want to bring to your attention, though, is that the population in general, moving forward, will be women, minorities, and people. And healthcare is the most the largest growing industry. We need to figure this out. This is a tremendous opportunity for women who are low income and minorities to get ahead. We need to give them an opportunity to get ahead. And I just feel that in any other industry, people would say, oh great, we have a need, let's figure this out so that we can make a good profit and move ahead. But that's not what happens in this industry. What they do is they do not value the worker. The worker is not valued here. They are made to work longer hours. They're made to work, travel far distances. They don't give them enough hours so that they could have benefits. This is, in any other scenario, this would not be acceptable. Why are we not giving this the same respect to what the future is? Because let's be pragmatic about it. If these women cannot get back to work, or if the minority communities will not be able to get to get ahead, we're going to have a less tax base, more burden on the state, and nobody's going away because people are here, people are getting older, and they're here to stay. So we need to figure out a way to make this an opportunity for growth for what is going to be the future of New York State.
Thank you.
Hi, thank you for the opportunity to testify today. I'm Lindsay Heckler, a supervising attorney with the Center for Elder Law and Justice. We are based in Western New York and provide free civil legal services to older adults and people with disabilities. Our primary goal is to use the legal system so that our clients can age with independence and dignity. And as partners with the Regional Ombudsman Program, we advocate for people living in nursing homes and assisted living. Now is the time to invest in the people of New York and ensure all individuals have the ability to age with independence and dignity. This means investing in the long-term care workforce, while at the same time reforming the delivery of long-term care services and supports. Both are necessary to ensure that every person who needs these services and supports receives them, they are of quality, and promote independence and autonomy in the least restrictive setting. While our testimony is specific to the workforce issues in nursing homes and assisted living facility, we encourage the Senate to act holistically and not in silos. It is essential to implement policies that prioritize keeping older adults and persons with disabilities in the community and out of institutionalized settings. For example, including the fair pay for home care in the next budget. If we are taking appropriate measures in keeping older adults in the community, then the number of nursing home beds in the state will naturally decrease. What cannot happen, however, is rampant, widespread closure. People will be harmed. In addressing staffing shortages, it's important to remember that nursing homes make the choice to admit new residents. Once a new resident is admitted, it is the facility's responsibility to ensure that person's needs are met. If a facility is not properly staffed, whether it's nursing, social work, dietary, housekeeping, or other, that facility has the responsibility to not admit no more residents. For example, a 120-bedded facility in Buffalo has been cited 6 times since December of 2017 for insufficient staffing, most recently May 2021. In this May inspection, the Department of Health found the facility failed to ensure that residents with pressure ulcers received the necessary treatment and services to promote the healing, prevent infection, and prevent new ulcers from developing. This is the 3rd time the facility has been cited for this exact same violation since July of 2018, 3rd time. In addition, this facility repeatedly ranks at the bottom of staffing levels in Western New York and has one of the highest usages of contract staffing, which is associated with lower quality of care. When addressing the issue of the workforce shortage, a question has to be asked. Why don't people want to work at certain facilities? Why is there high turnover? Yes, low pay is a factor. However, there are other keys to recruitment and retention: teamwork, respect, and organizational culture. These things cannot be legislated, and at the end of the day are the operator's responsibility. The words, "that's not my job," should never be uttered in a nursing home, yet we hear that often in these bad performing facilities. Enforcement of the staffing requirements is needed to ensure resident needs are being met. While the state can offer carrots such as grants or awards for nursing homes to improve staffing levels, at some point the stick needs to be more strongly used to get operators to comply with their mandated responsibilities. In addition, the state can reinvest how Medicaid dollars are spent such that residents who live in these repeat underperforming facilities have meaningful opportunity to return to the community or other location of their choice. Now, nursing homes aren't unique in being understaffed. Adult care facilities, ACFs or assisted living, also face challenges. In general, ACFs do not have the same requirements as nursing homes, and the level of staffing and type depend on the facility's licensure. We know there are ACFs that are not properly staffed. However, there's no publicly available information on staffing in these facilities. For example, an assisted living residence with enhanced and special needs beds in Williamsville was cited in February of 2021 at the endangerment level for failure to ensure there were enough staff to comply with the supervision and monitoring requirements needed to assure the safety and welfare of the residents. A resident also eloped in November 2020. This same facility previously made headlines when a resident who had dementia wandered from her room December 2017 and almost froze to death. Staffing matters, and we need a strong direct care workforce in order to achieve holistic reform and support older adults to live in their location of their choice, often the community. People should not be left in nursing homes because there is a home care workforce shortage, nor should people be subject to neglect in long-term care settings because of insufficient staffing. Thank you for your time.
Thank you all. I have a couple of questions, I guess one for each of you. I'm wondering about, you talked about poverty level wages or people earning, working in these facilities and not breaking above the poverty line. Is there research that can give us some guide to what the cost to the state is of having people working in these facilities who are also on public assistance, presumably? Is that measured?
I would argue that if you pay people a higher wage, then expenditures related to public benefits decrease. So that's, to answer your question, I think that investing in workers in general, paying them with a livable wage would pay for itself by reducing those public benefit expenditures, providing them with more financial stability, which then they can contribute back into their economy. So it would be a worthwhile investment to invest in workers to improve their financial stabilities and also improve quality care at the same time.
Thank you. Yeah, that's what underlies our Investing in Care Act, which that's the philosophy. You put the money into these jobs that could be created tomorrow, and there's a lot that comes back to us as a state budget, but also into our communities. I'd love to follow up with you about the MLTC Workforce Investment Program and how it was ended in this
It
last
ended
budget.
in March of this year.
Was that a planned thing, or did we do that in our budget?
It was just not renewed funding.
Okay.
So the funding ended. There is, within the ARPA implementation spending plan, there is a provision within there that can allow WEOs specifically to train the workforce and help to provide them with training for advanced roles specifically. So that's something that we're very interested in. But I think that, one, we don't know that the ARPA spending plan is going to be approved by CMS. And even if it is approved, it's only 1 year. So we really need to provide the Workforce Investment Program with extended funding so that we can see the impact of the work that the workforce investment organizations are doing. And we really need to be quantifying kind of how that is impacting the workers so that then we can hopefully scale up this initiative and all of the pilot programs that it's helping with.
And then, Maria, we work together all the time, and I am grateful for all the work you do. I wanted to just pull out something that's in your written testimony that you didn't mention, but it's about a trend in New York of sending nursing home residents to other states because there isn't the staff. Is that the reason for it, or what? I'm not aware of that even happening, so I don't know what the scale of that issue is, and I wonder if you can just say a little bit more about it.
Yeah, well, so.
It's on page 13 of her testimony if other people didn't
Yeah,
get
I'm
there.
sorry, this is a very long testimony. I have a lot to say, obviously, and I couldn't say it all in 5 minutes. But yes, there is a trend where it, especially that happens in a lot of rural areas where there is not, there a lot of the nursing homes, I think somebody here was talking about how they're shutting down and they don't have enough care in the area. So what ends up happening is that they have to send them to other places to get care. And it's just a shame because we have, it's almost like, for example, in New York City, you have a lot of people, there's still a shortage, and it's for different reasons. But if I've traveled the state, and I've never been to a county that tells me I don't have a workforce issue. And so some of the solutions are that they have to go out of state. In the North Country, they send people to Vermont, to other places. Actually, I have a colleague right now, it's not for workforce issues, but for care issues, that's in Boston, because apparently there's not the care that he needs here in New York. So, yeah.
But it's the residents making that decision, or the facilities are actually sending them?
No, the facilities.
Wow.
Because really, what a family wants to be close to be able to visit and see what's going on in the nursing homes.
Right.
On my, again, I was trying to come across with a case study that it's not unique. It comes, I've had 3 of those calls in the last week about the same thing. But basically, somebody who, not being able to get all the home care possible so that she could get back to work. Now she's saying, well, now I'm going to even look into placing my mother in a nursing home. Now, the whole guilt, first of all, about because they didn't think that they would ever have to come to that. But then it's, well, I've got to find somebody close, a nursing home that's close enough, that doesn't have violations, that doesn't have infectious diseases, that will let me visit. These are all things that are very real for a consumer. That we can't, can you imagine somebody with having your mother with dementia turning her over to a nursing home and not being able to and by the way, it's a lot much in their care that they need to see people that they know
Right.
and not being able to visit, right?
Yeah.
So then that paralyzes the person even more, and they'll say, well, I don't know if I could put my mother in any nursing home right now because all of these things are happening.
Right.
And a lot also has to do with the we get a lot of calls and people complain that where do I go? What recourse do I have if all of these things are happening in a nursing home or for home care? The Ombudsman program, we've had many conversations about how underfunded, undermanned they are. Actually, I had to tell you this because we've had ombudsmen from the local offices saying, we're only 1 or 2 people who have to cover various counties, all the institutions in various counties.
We're working on
Tell
that.
your elected officials, and they're telling us, tell your residents or the families, to tell the elected officials what's going on. We cannot handle this.
Right.
Call the Department of Health, to have nursing homes that receive fines. First of all, it takes them for a long time just to get to to visit these nursing homes that people are complaining about. When they finally come up with fines, there are fines that are so low, frankly, that it's a cost of doing business. The nursing homes actually budget in their budget for fines. I mean,
Yeah, thank you.
It's
I'm going to break in
humanity.
just so I can ask
Yes,
one
I'm
more
sorry.
question here, which
Yes.
is to Lindsay. What does the state need in order to enforce the staffing levels that we are requiring? What needs to be put in place to do that?
Well, I would pass legislation that, for one, creates a do not refer list to nursing homes that are routinely understaffed, such that hospitals are not allowed to send patients to those nursing homes. Also, while I am very critical of the Department of Health does not have enough people doing the actual surveys. But at the end of the day, it is the operator's responsibility. Yes, we can increase the Medicaid rates, but it takes a leader to run a nursing home. And the operators really need to do more to create that professional working environment that people want to show up to every day. Because as you've heard from many people, nurses themselves today, it's really hard work.
Is there some kind of credential that the operators have to get in order to have that job that could be then tied to performance in this?
We could have a whole separate hearing on the relevance of the Public Health and Health Planning Council, but I'd be happy to discuss with you that separately. They do supposedly go through character and competency assessments.
Okay, great. Thank you very much. Thank you all. Do we have others? Yes. Senator Borrello, I'll let you go first this time.
Well, thank you. First of all, thank you again for being here. Morgan, I was Hannah, I was kind of taken aback a little bit. We've been sitting here criticizing private institutions, the pay rates and so forth. Yet, here we are, the state sets the rate for direct care workers, and according to your testimony, New York State, and the funding behind that for Medicaid, which continues to be cut, is paying on average $14.24 per hour. So I just want to make sure I'm getting this correct because it's in your testimony. So New York State government is paying less than fast food wages for direct home care workers at the moment. Is that correct?
It's absolutely correct. This industry, on average, I actually have a statistic that I would love to share with you. In comparison to other sectors in the state, this is New York specific, in the state with similar entry-level requirements, these jobs are on average receiving $3 less per hour. And then for other jobs with lower entry-level requirements, these jobs are receiving 65 cents per hour less. So yes, this industry is not paying a competitive wage, and it is the largest industry and the most quickly growing industry in the state.
But in last year's budget, the state was going to try and fix this by creating some kind of a wage parity, and this wage parity has resulted in lower than the minimum wage currently that we pay fast food workers. Is that basically what you're saying?
My argument is that it's not competitive, and therefore workers are leaving for other sectors.
So we didn't fix anything by doing this.
I think that we have more work to do.
Yeah.
Yeah.
So we'll pay someone, a taxi driver, to take somebody to a doctor's appointment, $200, $300, $400 for one trip, but we're not paying minimum wage to home care workers. So
We're not paying a livable wage
yes, okay.
to home care workers.
I just want to point out that we're, basically kind of the pot calling the kettle black as we criticize people in the private sector, not-for-profits, when New York State's not living up to that commitment in its own right. So thank you.
Thank you. Senator Serino.
Thank you, Madam Chair. And Maria, I wanted to say thank you, and for all of you, thank you, but for you mentioning about how when places close and family members can be displaced anywhere. We just had a situation where it was my constituent, but the assisted living facility was in another senator's district, and the daughter went on vacation. I think she was away for almost a month. She didn't know where her mom went. So we worked together and we were able to find out. But that we should have safe, reliable places for people to go in the communities, and so that they don't have to travel out and and especially like somebody with a little bit of dementia or whatever, it's scary too. So I appreciate everything that all of you do, and like I said, thank you for bringing that up. Thank you.
Thanks, and Senator Ramos.
Thank you. Thank you so much. I really appreciate your point about livable wages because I do feel that fast food workers have finally been able to be acknowledged and dignified in the work that they do. And pitting one workforce against the other really doesn't actually solve our issues. It's not that fast food workers make too much, it's that home care workers make too little. And I really appreciate your point there. I'm wondering your comments on career advancement and workforce development and apprenticeships. Based on what we've heard today, it sounds like the bulk of these programs largely come from the unions. From what I've heard, it's $11.99. It's nice though that offer these opportunities at a greater scale and have perhaps even a greater rate of success than anywhere else. Are there ways, and I apologize because I know much more about the construction industry than I do about this one, where state-approved apprenticeship programs can only be offered by unions? I don't think that that's the case in this industry, but what can be done in order to, offer the same quality of apprenticeship and career advancement programs outside of the unionized workforce?
Sure, so that's the Workforce Investment Program plays a really significant role in in helping the workforce with retention and recruitment related issues. So it's an organization like PHI or like the union that receives funding to work with providers to, for example, when it came to the pandemic, to provide trainings about infection control or stress management to the workers, to design advanced roles, which I would love the opportunity to talk a little bit about. We've been talking about advanced roles, to take a CNA to an LPN or a nurse, but we want to make sure that these positions, nursing assistants, home health aides, personal care aides, that those positions, there are opportunities within those roles. So some examples, you have a peer mentor who could provide support to new ongoing hires. You could have a transition specialist who is following a client while they're in the rehab or a nursing home post-discharge for 30 days to make sure that they don't have a repeat hospitalization, which is therefore improving their outcomes and then meeting a value-based payment. You have advanced home health aides that can assist with medication administration. All of those roles need funding, both for the training of those roles, for delivering that training, developing the training, paying the workers while they're receiving the training, then paying the worker a higher wage after completing the training. So all of that needs to be funded within the advanced role development process. And the Workforce Investment Program, again, hopefully if it were to be funded, would help with that. But also like the Home Care Jobs Innovation Fund would be a great avenue to support kind of innovation as well.
Interesting. So it sounds like because there's such a high rate turnover in the industry, there really isn't a pipeline or an avenue for institutional knowledge really to be passed on.
Right. There's a loss of that knowledge, which is tragic, and that's why we're trying to provide advanced opportunities that capitalize on the expertise that these workers have to both support other workers, because supervision is such a challenge within this field. So providing support, capitalizing on the workers' expertise and giving them room for advancement, which is respect and recognition of the work that they do.
So how are best practices developed and taught to home attendants or other people who work in this industry?
So when the Workforce Investment Organization or the Workforce Investment Program had funding, we worked directly with providers and worked with workers to...
But you're not mandated to? Do you have to? Does every facility have to come to you for this?
No.
Mm-hmm. Right. Interesting. Okay, Maria, I'm wondering about, just from the consumer perspective, the quality of care and how it differs from facility to facility. Are there any specific criteria and or indicators that I should be looking out for? I'm Latina, so I would never put one of my parents in a nursing home. No offense to those who, but it's a cultural thing. We don't do that largely. Our parents live with us, but how, what should I be looking out for as a consumer if I'm in that situation?
Okay, so for example, nursing homes, they have a code, right? And they have rules about what visitation is, what type of, even down to the food that they receive. They have rights. Residents have rights, and what we have found is that, especially during the pandemic and now post-pandemic, what's happening is every nursing home is interpreting the guidelines as they see fit. So, for example, a visitation order, where during the pandemic at the beginning they were allowing nobody to come, and then there were severe problems with people calling us saying, I don't know anything about my my loved one, to then all of a sudden the rules started easing up. However, there are times where in one nursing home they will say, this could be compassionate care. If you have Alzheimer's, compassionate care means that they should be able to get a visitation from at least one person under COVID. While another nursing home will say no. So it took us a long time to go in and advocate, and this is case by case, and we're not the only ones receiving these calls, but and then that puts a big strain on the ombudsman, right? And you have to keep on doing that.
Is there any type of consumer reports? I see you, Lindsay. And I have questions for you too. Is there any sort of consumer reports grade or where I can quickly see that one facility is rated higher or one agency is rated higher than the other?
Yeah, yes, there are. The state has a report card for every nursing home, and you could see what their stars are, and infectious disease, things all the way from infectious diseases and staffing ratios and things like that. You can see all of that there.
All right, thank you. Lindsay's eager to jump in, but can you also, no, don't be sorry, but can you also maybe add a little bit about, I wanted to learn from you about the actual oversight that is provided by DOHMH. I'm a huge critic of the governor's insistence on austerity budgeting. I believe that the DOL is just as underfunded and over capacity as the OHMH, so I would like to know a little bit more about that. And then I'll have another one. Okay.
In short, we just don't know how many surveyors are currently working outside of FOIL requests. So we have submitted FOIL requests and are looking through the information, But people are filing complaints and waiting well over a year for a response. And to be blunt, the only way you're going to get a Department of Health surveyor into a facility is if the complaint alleges that harm has occurred. They are so backed up with the complaints that even on their annual surveys, which is partly governed by the federal process, they can only investigate so many complaints at a time during their annual survey, but then they only have so many people to actually physically investigate. So a lot of these investigations, I question the thoroughness of them when they are only calling the facility, asking what happened, then unsubstantiating that complaint.
And they're not visiting them?
Yes.
Oh, wow.
They have resume visitation. So in the example of the nursing home and assisted living residents, which are two different surveyor teams, they are catching some of these insufficient staffing deficiencies. But quickly back to where people can see the rating system. Yes, there's a CMS rating system. Yes, there's the nursing home profiles with the state. I do not put stock in the CMS rating system because a lot of these star ratings are based on non-complaint data. It's what they are putting into the system. If I'm a consumer or their representative, I'm looking at the payroll-based journal staffing data that is put out by CMS.
In your testimony, you said that there are certain things in work culture that cannot be legislated, challenge accepted. What are the types of things in work culture that you think, that you feel, and I mean to put, because it's something I would like to work with you on, that perhaps, are out of the box and we should be looking into?
Well, I think there are, and I defer to the specific workforce training programs, but it's how's your administrator, how's your director of nursing, how is the operator when they come into the building? Are they a hands-on approach or do they hide in their office? When there's one CNA for 20-plus residents and they need more help, are other members of the team, if they're there, available and willing to jump in? It starts at the top for leadership. And that's what it's just a small piece of the puzzle. Whenever not my job is heard, there should be a problem there.
I have 3 seconds to ask you if you know what the pay ratio usually is between CEO and average worker in these facilities. I do know. Because I saw some pretty nifty watches up here earlier.
I'm not that skilled.
All right. Cool, thank you.
Anyone else have a question? I do want to just follow up on one thing from what Jessica was asking about the 5-star rating system. We hear about that a lot. It's a federal thing, or a national level thing. Yes. In your experience, does it actually line up with the quality of care that's being provided?
I would never put my loved one in a nursing home that's rated below 4 stars.
Wow.
5 stars and 4 stars have their challenges. But and this is my personal opinion and also based on professional review and experience about going into these locations, the 1 star and 2 stars are most likely to have repeat deficiencies and not address the problems.
And can I just say something about nursing homes? Up until recently, there were New York State had public and county-run nursing homes, things like that. They've all been sold off. Not all, 3% are still public, but they've been sold off to profit-making organizations whose interest is really the bottom line. But a lot of these things were done without public input, and that if I said anything here today, it's that I said a lot, but we need more public input into any decisions that are made at these levels.
Well, thank you. Thank you all for your advocacy and your good work and for your testimony today. Our next panel, we have Marcella Goheen and Agnes McCrae. And unfortunately, Ian Magerkurth had to leave. So it's a Central New York thing. Agnes McCrae. Yeah. She has a 4 o'clock train to catch, right? Yeah. Ian Magerkurth, who was on our list from the Alzheimer's Association, was unable to.
Hi, good afternoon, everyone. My name is Agnes Craig, and I am a human rights advocate, and I live in Syracuse, New York. For the past 27 years now, I have been a part of excuse me, I have been a part of the Consumer Personal Care Assistance Program. Now, I must tell you that before that, as I was transitioning, I was told that because the aid service that I currently had was going out of business. So I actually paid out of pocket to maintain my services because I remember the nurse saying to me, we don't have those services that can support you. So she left, and I was on my own for 11 months. I had to pay out from my SSI to get service. Now, why did they tell me that I wasn't, that they could not fulfill my needs? Because see, I don't consider myself as a person with a disability. I call it extraordinary differences. So, and from the time I was a child and old enough to dream, I always wanted to just live my life the way I wanted to. Didn't know how it was going to be accomplished, but I always knew I wanted to be, have children and go through that whole thing. So because I had children, without even asking or finding out, they decided that that there's no way that I could have any type of services. So I ended up paying out of my pocket. And then the Personal Care Assistance Program came along. I got the phone call from the founder who brought it to Syracuse, Sally Johnson. She's like, there's a program for you. And I was hesitant. I said, okay, I'll try it. Here I am, 27 years later. My children are grown now, and I have always kept my aid services. I always had a roster of persons that I hire to take care of not only my personal needs, but to help me to become a very successful, darn good advocate. And I must say that they've always put my needs ahead of their families. If you look at my testimony, I'm talking about one specific attendant that I had for 14 years. And after 14 years, because her daughter was with me, she came before her daughter was even in kindergarten, and after 14 years, she had to choose between her daughter's needs because she was a single parent and taking care of me. I am lucky because my youngest son, who you see right behind me, has put his college career on hold for a minute till I am able to find staff. And it's very hard to find staff. We had an ADA celebration yesterday as it celebrated 31 years. And the advocates were all talking about going to different places so that their staff can make more money. It's not only about fair pay for home care, it's about my health as well. I have not seen a hospital in the past 11 and a half years. I'm very proactive in taking care of myself, but I know for being an advocate that it's, like I said, it's not only about the fair pay for home care, it's across the board. It's having the attendants now to take care of those elderly patients who live on their own. The agencies are strapped. They're not showing up because you can make more money elsewhere. I think that we, in light of the Disability Awareness Act and other programs, which gives us the right to freedom and the right to choice and the right to choose, we really need to look at this and choose health now. I know of another person that had this, he was on his own for 4 years independently, living out of a nursing home and living independently. Since the pandemic, he went into a nursing home 3 times because all of a sudden his home and what he knew was deemed unsafe.
Okay, Agnes, I'm sorry, can you wrap up your testimony and then we'll have questions for you, but.
And I just wanted to say that also we need to put more options on the table, because health is really about wealth, and we know with COVID now and everything is happening, I do not want to put myself at risk, and I don't want to have to choose between whether I'm going to be paying rent with my or paying for someone to come in and take care of me. Will I all of a sudden be deemed unfit after 27 years of independently making that choice on my own? Thank you very much.
Thank you. And Marcella.
Hi, good afternoon. Thank you so much for the opportunity to testify. Thank you, Senator May, for your service, Senator Rivera, Senator Ramos. My name is Marcella Goheen, and I'm a caregiver advocate and the wife of Robert Victor Viteri, who lives in a long-term care facility. I am founder of EssentialCareVisitor.com, a digital online advocacy tool that educates, advocates, collaborates with private and public partners to collaborate with family consumers to serve their vulnerable loved ones in a long-term care facility. I founded EssentialCareVisitor.com on March 12, 2020 at 1 p.m. in the afternoon when I was told by our administrator and senior staff that I would no longer be able to enter the nursing home to continue my collaborative care with my husband, who I'd been serving for the past 4 years up to that point. I was a daily caregiver 5 to 7 hours a day as he suffers from a rare neurodegenerative process that has no name. It would be 9 months later until I saw him again, after I had to file an unprecedented Supreme Court lawsuit to sue the facility to abide by the federal law, which was his federal disability to receive his caregiver, and his person as he is nonverbal. I currently am a daily caregiver to my husband, serving him in collaboration with the nursing home staff daily. I testify today on the shoulders of so many vulnerable loved ones in heaven who we lost. Vicarachi, Mr. Birch. So many on my husband's floor. He was one of the only survivors. And the many residents still alive who are needing to receive the full quality care in a post-pandemic setting that is their federal resident right, according to the Omnibus Act of 1987. I also stand in unity with the staff, the aides, the nurses statewide today, who continue courageously to serve our vulnerable residents without care tools and appropriate compensation to do so. They are serving, as you and I sit here today, from their gut, while they work within a healthcare system that is collapsing around them. And these workers still choose to come to work daily to help my husband and the thousands of others like him. To them, I say thank you. I'm also standing on the shoulders of my 92-year-old mother, who was part of the 1987 Omnibus Act. She ran nursing homes from 1986 to 2006. She told me when I was 11 years old, when she walked me through her nursing homes, you see these people, some of them have families, some of them don't. Most of them don't. It's our job to take care of them. We as family members are witnessing unspeakable staffing issues statewide. Put simply, the problem is there is no staff. Staff have been laid off in union-busting ploys. However, vulnerable populations are rising. Staff are leaving through their own choice. Staff are traumatized. Staff are collecting unemployment. Staff are exhausted. And more concerning, there's no staff to recruit. But according to the personal caregiver bill, which in June 24th, suddenly we're not in a pandemic, we're not allowed to enter because we're no longer in a pandemic. So facilities are practicing various versions of the caregiver bill. There is a catastrophe happening. The accelerated human decline and unnecessary loss within long-term care settings is a tragic disaster. We are being told by staff statewide, it is worse than the pandemic. Maybe the same, says another. If there's no staff to get residents out of bed, give them their medication, take them outside, turn them, feed them, bathe them, we are breaking our oath as a society and commitment to our vulnerable. We are harming them. I introduced today a family consumer advocacy project that was dreamed up by EssentialCareVisitor.com. It is also thought up by a couple of nurses in the facility I'm in, as well as the caregiving staff that I have had the privilege to collaborate with over the past 8 months as I was able to enter my facility through my lawsuit. This plan is a hopeful solution containing an interdisciplinary emergency response, and it is an emergency. I have 49 seconds and I'm not done. I'm so sorry.
It's all right. We'll have questions for you.
It's called a multi-generational recruiting process that will serve our loved ones who are now dying, not because of the staff and nurses do not care, but because there's no staff to care. Our essential campaign is called Raise Up Care. Raise Up Care will work to break the collective trauma response that every seat at the table is enduring. This campaign is not a should or a may or a could. It is a must if we are going to save lives. The R in Raise Up Care stands for we must reframe, restore, and renew long-term care facilities. We must retrain and re-educate all the staff and all the stakeholders. We need to ask ourselves, what does it mean to care as a human for a vulnerable human? It is not something that we like to talk about as a society, yet is the one thing that we all have in common. We are all going to get sick and we are all going to leave this earth. The residents are us. A in the Raise Up to Care is we must acknowledge, affirm, and address the trauma in long-term care facilities. The Angel Care staff who are working tirelessly as we sit here today and continue to fight to restructure nursing home reform, we cannot lose these senior staff. They are more than our heroes. They are the best of ourselves. But not only do they need their higher salary reform and aid to resident ratio adjustments, they need mental health services as well as trauma-informed care settings that address their own trauma. Having survived something so complex with our family members, as well as witnessing the trauma of our own vulnerable residents. I'm sorry. And the I is to incentivize, invest, investigate care systems for all stakeholders. The S is to provide sustainable quality care models, and then the E is for empower, engage, and educate. And
I'm going to cut
that.
you off there,
Yeah.
but thank you both. And I did give you both a little extra time because this is why we're here, to hear your stories and not just talking points from government functionaries, but from real people who have real stories to tell. And Agnes, I see you in our community multiple times a week. You truly are an amazing advocate for people with extravagant differences, and all of us, honestly. And your son, whose name I should know, and I don't, but who does such wonderful work as well. I honor both of you. And I don't really have a question. I get to talk to you all the time, but I do thank you for lifting up the Fair Pay for Home Care and the other ways that we are trying to invest in care in this state, because it is obviously so important to allow people to be independent as long as they possibly can and want to. So your independence is a beacon for so many people about what our programs should be doing, what home care should be about. And so thank you for coming all this way to help us understand that. And Marcella, we've worked together a lot, and the work you've done on visitation in nursing homes. I wanted to ask you, as somebody who's been in the facilities on such a regular basis, one of the reasons I was so determined to advocate for helping people get in to visit their loved ones is a belief of mine that when you don't have family members coming in, that it allows some of the facilities to kind of conceal what is really going on, or at least the family members were concerned that because they weren't able to get in, it wasn't just that they couldn't visit their loved ones, but they couldn't see what the conditions were inside the nursing homes. And I'm wondering if to what extent you feel the visitors are kind of complementary to the staff and necessary to the staff in the sense of providing the whole continuum of care that people need in the nursing homes.
Well, at this stage in the game, we're essential. At this point, my experience is showing me that when I first got in December, it was all neuro care for my husband, but now it's 8 months later, and I'm doing 70% regular care that is not as neuro care and 30% neuro care. So that's a very micro model of my experience as a consumer, but at this point, you need the families in there because there is no staff. There's one nurse to 45 patients. I'm getting calls where there's, as you've heard before today, where there's no staff. Nurses are working 2 floors. There are 2 aides for a floor of 30. How do you feed, clothe, bathe, get them out of bed? Forget getting them out of bed. They're not getting out of bed. So now you have people in bed all day. So it's an accelerated decline, bed sores, escalating potential for blood clots. It's a disaster. When I use the word disaster, I thought it might be too strong to use for the Senate, but I think it's actually accurate. So for a facility to not let family members in at this point, it's actually, you're asking us to hurt our vulnerable yet once again. So you're not letting us in because you're letting us in an hour at a time. Our loved one needs more than an hour at a time. So if that answers your question, it's a beautiful collaboration. The model works. The personal caregiver bill is spot on, and I wish the facilities would acknowledge it and not continue to take what parts of it fit conservatively to not letting us in, but to letting us in. I'm in a very unique position where I was able to advocate for my husband, and this is my husband in December when I finally got in, who was very happy to see me, who's nonverbal.
Well, thank you for
But he's
bringing
able to.
him here too.
I brought him Robert Bateri, and he's actually starting to talk a little bit again. He's saying yes, no, and we're getting him up in his
that's
standard.
wonderful
So
to hear.
yeah.
He's so lucky to have you.
Yeah, he is. Lucky to have you, and please give him our best, too. Okay, anyone else have anything to say? No, we're good? Okay, well, thank you both for coming and for your very powerful testimony.
Thank you.
And safe trip home, Agnes. All right, our next panel is... All right, so that was the conclusion of our nursing and assisted living section, although as everyone can see, they run together, and it's not that easy to separate them out. But we are up to the home care thing. I think we're going to go ahead without a break, but we'll take a break in at some point later in the afternoon.
We gotta stretch. Occupational hazards of our own, we gotta stretch.
You want to take a stretch? Yeah.
We'll take money and then
If we take a stretch, that means another 20 minutes.
Yeah, no, let's keep going, but hell, I'm going to have to get up and leave for a few minutes at some point.
This is
But-
all I'm saying.
All right, Jessica. So this is panel one of the home care section, and we have Rona Shapiro and Lilith Clacken, Jason Brooks, and Martha Davila. Is that right? Hi. Let's start with Rona.
Okay, good afternoon, and thank you, Senator May. Thank you, Senator Ramos. Thank you, my friend Gustavo Rivera, for being fighters for social justice and to make the lives of home care workers and the people they serve better. And of course, I have to give my love to my senator, Shelley Mayer, who is from Yonkers. So I'm an executive vice president with 1199. I lead the union's home care division, representing over 60,000 home care workers across the state. And I appreciate the fact that you have given one of the first hearings on home care workers in the Senate. I would also, I'm joined today by 3 workers, Lilith Clacken, who is 1199 SEIU rank and file leader, along with Jason B. Brooks and Martha Davila, who are home care workers who will share with you their experience as home care workers. I think that there's no stronger testimony than you just heard from Agnes McCrae of why we have to transform the home care system in New York State. And I think this is a task that is way overdue, and that together we can do it to make it a better system. The challenge that we face is how we make home care a more attractive profession so workers will come back to the job and new ones will take up the job of a home care worker. We can do this, but it will take resources and a commitment to elevating home care workers to a valued part of the larger healthcare delivery system. If we are serious about preparing for the increased demand for home care, we cannot just assume workers will be available to fill vacancies. We must transform these jobs or we will not meet the demand, and we will continue to lose workers to better paying jobs or even lower paying jobs with consistent full hours. We can no longer just talk about this. We have to actually make the changes in New York State that can change the job of the home care worker. What we're doing in 1199, and I've been doing this a long time, and working with home care workers has been the honor of my life to do that. And while we fought many years for pennies, we finally did get to a $15 minimum wage with wage parity, and that was 3 years ago, and the workers have gotten no raise since that time. In 1199, we're fighting like hell to get billions of dollars, federal dollars, into home care workers and home care services around this country. We just had a rally in New York City with Hakeem Jeffries pushing for the Better Care, Better Jobs Act. We have our own home care training fund, 1199 training fund, the best in the country. We are using the monies that we get. There's not enough money to upscale the job, to upscale the workers. We're creating pilots. We're working with managed care companies like Health First, who actually is investing in pilots with one of our 1199 agencies, Premier, who's in the room, to figure out how we create new and different jobs and tasks for the home care worker that produce better health care outcomes. In the Health First model, the workers will be paid more, they'll have a Chrome tablet, and they will be able to, in real time, talk about what is going on to the client so we can intervene in any emergencies. The home care workers are the eyes and the ears and the lifesavers of many of their clients. And we do not take advantage of the skill, the language, the cultural affinity that they have with these workers, with these clients, and the time. They spend more time than most families do with the client. And unfortunately, they're still invisible. We're making sure that the $2 billion slated for home care services in New York State gets dedicated to hazard pay and other initiatives for transportation, pilots for guaranteed hours. We're working with the training fund and our agencies to figure out how do we recruit new workers. Many of the agencies that we work with do not have enough money because they actually follow wage parity laws to hire expensive people to do advertising for recruitment of workers. The training fund, we're talking about building a hiring hall so that we can both help the workers and the consumers get clients. What do we need to do together? We need to make family-sustaining wages. We need to pass the Senator May and Godfrey's Fair Pay for Home Care Workers, calling for wages of $22.50 plus wage parity. We need guaranteed hours of work so home care workers can maintain a steady income. And we need pay differentials for personal care assistants working with high-need consumers.
Okay, I have to cut you off. Sorry, Rona.
Okay. Thank you. So I would like to introduce my beloved sister, Lilith.
Good afternoon to my elected leaders and to all the visitors here today. My name is Lilith Clacken, and I'm a home health aid worker, very proud 1199 member and a delegate. And I work for 2 major agencies in New York. My mission today is on behalf of thousands of home health aides who are advocating, and we need better pay, compensation for the essential tasks we perform along with other healthcare workers before the COVID-19 pandemic, during the pandemic, and hopefully long after the pandemic is gone. I would like to take a few moments to detail for you my job description, which goes beyond and above these tasks mentioned. The patient in my care presently is a stroke victim who has been rendered immobile on one side. This unfortunate health challenge has significantly reduced her capacity of taking care of her personal needs, which also diminishes her sense of dignity and independence. I endeavor to restore some of her dignity by practicing the training given to me by my employers during initial training and ongoing in services, which enable me to maintain certification in caregiving to a level of professionalism. I assist her out of bed. I assist her with toileting, bathing, and more importantly, safely transporting her around the house. I make her meals, accompany her to doctor's visit when needed, supervise her taking her medication, and simply being beside her to take her to the bathroom whenever she needs to. I'm a passionate caregiver who believes in keeping my patient comfortable, clean, and as happy as is possible under the circumstances of her not being capable anymore of taking care of herself. My patient cannot be left alone. The importance of me being there is undoubtedly the key to her living a dignified life. Her families have that important peace of mind, knowing their loved one is in the hands of a capable, trained home care worker, which puts no monetary value. The companionship I provide is invaluable, and so I urge you to provide us, home care workers, with a better salary so that we can in turn take care of our own families in a very acceptable, responsible way. During the pandemic, I refused to stay home, knowing my patient need me, and I wanted to be able to provide for my own family. While we appreciate the applause and the lip service of thanks, we demand hazard pay from the $1.6 billion slated for New York from the American Rescue Plan of 2021. We worked in our patient's home during this fearful period, and so we're expecting compensation. We demand better pay, as we should be able to take care of our own families while providing care for other families. And this is the heart of most issues facing home health aides. The work is undervalued and underpaid, and it creates hardship for the aides who stick with the work and makes it harder to find new workers. We have a rapid aging society, and so this should be taken into account as we meet the needs of our most vulnerable seniors who have served this country and should be given the right to stay in the comfort of their homes while we professionally take care of them. I now take a moment to thank my greatest union, 1199, because they have provided, when our agency could not provide the PPE, they were assisted to us, and I thank them. I'm a great, proud union member. We need the federal Better Care, Better Jobs Act passed so our home care workers can continue to provide this crucial service and attract younger workers in this field. Thank you so very much for allowing me to address you, and I anxiously await your response to our cries. Thank you.
Thank you.
Good afternoon, everyone. I'm a little nervous. I look up to all y'all. I'm just being honest. Every single person on this panel, thank you for one. Good afternoon. My name is Jason Brooks, Jason B. Brooks. I'm a home health care worker from Rochester, New York. I appreciate the opportunity to share my experience as a PCA with you. I started doing care work 8 years ago when a friend's mother got cancer and needed a tracheotomy tube. My friend told me I would be perfect to care for his mom due to the reason that my patience and my humbleness. Everything went right. I cared for her for 2 years. After this experience, I decided to see if I could keep going in home care and make a living doing this work. Actually, more of a career is what I wanted it. I have to be honest with you, it was right. It was the right decision, but it's been a struggle for 6 years for me. I worked for a lot of agencies, and all of them non-union, and each time you have to fight for more hours, stable hours, better pay, or even just getting paid for the work that you do at hand. I've never had health insurance through my job in all these years. I really haven't. It was hard to get. I like to work with just one agency, but you really can't. We're constantly looking for that extra quarter or those extra hours we need to get by. I'm usually working for more than one agency at a time and doing per diem work where I can find it. I can't even imagine what it's like to work 40 hours and be able to support yourself. And if the client you are caring for goes into the hospital or dies, your assignment is over. This happens regularly. Then you are out of a job until the agency finds another client, and this can take a couple weeks, few weeks, maybe even a month, particularly for men, because most people are more comfortable having a woman as their home care aide. This really is one of the hardest parts of my job. You spend months or even years taking care of somebody in the day out, and they pass, and you're out of work. No thanks for all you do. Keep on pay, well, you don't keep on the payroll until we find another client. Instead, you just wonder how long you're going without a paycheck. The other frustrating part of this is the work is always having to fight the agencies to get all the pay that you have worked, that you have earned. Regularly cheated out of hours, just recently. I've worked and I've always, asked for a raise or need a raise, and the agencies, they ignore it. They ignore it. Sorry, y'all, I'm getting a little emotional. Sorry, I'll make it quick. So again, did I make the right decision 6 years ago? I have to say yes, but we can't go on like we have been. We can't be forced to always search for more hours to get a paycheck big enough to take care of our needs. We can't be forced to work for agencies that provide no health benefits. We shouldn't have to look at our paycheck every 2 weeks to see if the agency is paying us correctly. We're human beings taking care of human beings. We need to take care of ourselves in order to take care for others. And that's so big on me right now. I'm exhausted now from working 3 shifts, 12 hours back to back. So we need the legislators. We need you. We really do. We really do. Me, myself, I can say that I'm crying out for you guys' attention and your help because we need you. To make sure that the money that we get in our agency goes to the PCAs and make sure that the agencies pay a living wage, make them provide health care. We need guaranteed hours. We need support agencies that employ unionized workers. Otherwise, each year will be a struggle for PCAs. And each year, more and more will decide they can't take it another year. So I thank you. I thank every last one of you on the panel and everyone in their rightful place. Thank you for listening.
Thank you. And Martha.
Buenas tardes, mi nombre es Marta Dávila. Trabajé para la agencia de Preferred Home Care los últimos 4 años. Gracias por darme la oportunidad de compartir mi testimonio. Actualmente estoy desempleada. Me estoy recuperando de COVID-19.
Good afternoon. My name is Marta Davila. I work for Preferred Home Care. I have been working there for around 4 years. And thank you for giving me the opportunity to be talking today. And right now, I am unemployed and recovering from COVID-19.
En enero de ese año, la agencia para la cual yo trabajaba me enviaron a hacer un reemplazo al asistente de una persona mayor. Cuando llegué, me di cuenta que habían 2 personas en casa que estaban enfermas. 2 días después empecé a sentirme mal, tenía dolores de cabeza, fiebre, muchos malestares. Fui al médico y hacerme el test del COVID y salí positiva. Luego me enteré que las 2 home attendants que trabajaban antes en ese mismo caso también habían salido positivas al COVID. Ahora, por más de 6 meses después, todavía estoy recuperándome de las secuelas del COVID porque me he quedado con mucha ansiedad, problemas respiratorios y musculares.
Back in January, my agency sent me to do a replacement to take care of an elderly person. When I arrived, I saw 2 people instead of 1, and they were sick. 2 days later, I started getting a headache, a little fever. I was dizzy. I went to see my doctor to do the test. Was positive with COVID-19. Also, I heard that the other 2 home care workers who also taking care of the same patient was positive too with COVID. Now, after more than 6 months later on, I still feel dizzy, afraid, and with fatigue.
En la agencia para la cual estuve trabajando nunca nos proporcionó el equipo necesario para poder protegernos. Muchas de las trabajadoras teníamos que comprarlo con nuestro propio dinero, máscaras, antibacteriales, batas para poder protegernos durante la pandemia. También casi siempre el sueldo de nosotras era incorrecto. Teníamos que estar siempre recalcando y chequeando porque las horas que nos pagaban eran incorrectas. Esto le sucedía a muchas de las trabajadoras en esta agencia.
The agency that I work for never provide us with the PPE equipment. We had to buy our own masks, gloves, even gums. Before I got sick, the agency stopped also provide us the health insurance. Most of the time, my paycheck was not correct. It always missing days and hours. I always had to push to get my full hours pay. And this happened not only with me, also happened with the other aides.
En este momento me estoy preparando para volver a trabajar, pero todavía me aterroriza de pensar que vuelva a enfermarme otra vez. Y sí me siento un poco nerviosa porque el recordar de lo que uno está pasando, de verdad, siempre a uno no es fácil. Yo trabajé todo el año de la pandemia en el 2020, me protegí mucho lo más que pude. Finalmente, creo que fue una irresponsabilidad de la agencia mandarme a un lugar donde sabía que habían personas que estaban positivas. Yo también tengo familia. Estuve arriesgando mi vida todo ese tiempo. Pero por eso es que estoy aquí, porque yo creo que
Perdón, doña Marta, si puede terminar en pocas palabras para poder resumir.
Para poder terminar, quiero que por favor presten atención a nosotras, las trabajadoras de Home Care. Es muy importante, también nosotros estamos colaborando mucho a ayudar a las personas y necesitamos que nos respeten y que sean justos con nosotros. Gracias.
It's a lot of things to translate. Okay, right now I am getting ready to go back to work, but I am still terrible getting sick again. I feel so nervous, but I feel the agency who we work for need to do better job of taking care of the workers and the clients. The state should clamp down on the agency that don't treat workers fairly and put the health of us aides and the clients at risk. I feel afraid, but just tell the government to do something for us, because some agencies, they didn't take care of us like they supposed to be. Thank you for your help.
Thank you. Thank you all for your testimony. I just have a couple of quick questions. One of them was for Rona. You talked about how agencies had a trade-off between investing in recruitment and paying the workers. Was that you who brought that up? So like either they were going to spend money on advertising and that sort of thing, or they were going to put it to worker pay. So do you have a sense of what the costs are of recruitment and advertising, and just so that we can figure out what we need to add into to the reimbursements for these agencies?
Thanks for the question. My point was that, the horror stories that you hear from home care workers and that you've heard today, unfortunately, we continue to throw Medicaid dollars at them, and I don't feel provide the proper oversight, and I'm hoping that when new monies come in, that we are very protective of that Medicaid dollars, because as Senator Rivera said, the budgets get cut, And the agencies that continue putting money in their own pockets and not in the workers' pockets, such as who Martha works for, they continue to get money from the managed care companies. So my point was that our 1199 agencies, I know how much money they spend because they have to spend 1909. They sign a collective bargaining agreement. There's not a lot of fat. As a matter of fact, the agencies that do the right thing are suffering to be able to pay the workers' health care, pay the benefits, and pay the money. There's no excess money to, like if they wanted to advertise for recruitment, if they wanted to, you know, do like some of the for-profit bad actors do, then they would not have that money. But the training fund, we've already done a pilot with an online thing trying to recruit new workers. The problem is there's not enough money being offered to workers. That is just the fact. We could talk whatever we want, but
let me
we
follow
gotta,
up on that,
yeah.
because the Senate majority tried to get $624 million into the state budget this year to supplement the wages of home care workers. And what we were told was that there was no way to guarantee that that money would actually go to the workers. We could pay that, but it would go to the agencies and they would do with it what they wanted. So I'm wondering, what's the solution to that? How do we earmark the money specifically so that it goes to the workers?
Should I say it should go to 1199 agencies? That's probably not what some of the other folks in the room want to hear. But there has to be ways, oversight. You know, you can just, you know, and we've talked to various people in the state. There has to be oversight. So when the managed care companies give money to an agency, they have to prove that this money is going into workers' pockets. Now, they will sign attestations and just lie and say yes, and if nobody, you know, checks it out. But I think we all have more of a responsibility, the managed care companies, the state legislature, to make sure that there is oversight and there's qualifications for this money. There is a KEVAC program where some of the agencies got extra money because they had health insurance, because they had training programs, because they proved to be quality agencies. I think agencies who show that they're investing in workers, I think managed care plans who show that they're willing to invest in the workforce should get dollars to do that. If you hear of plans who are not doing anything, we should, you know, question. I don't even know why we need so many managed care plans in New York State. Everybody is taking a piece of the little money that is given for home care from the home care worker. Everyone gets that piece except the home care worker, and that's why we're here today. And I couldn't think of a better group of senators to talk to help us win this fight.
Well,
I'll give you all 1199 hat if you help us.
yeah, I gotta say, Jason, there's a union that wants you, I'm sure. Like, I was just gonna say, when I get to the point of needing home care, I hope it's the Liliths and Jasons and Marthas who are there to take care of me, because you all are very impressive and what you had to say is really powerful. Is there anybody else?
Yeah, I have a bunch of questions.
Oh, all right, Senator Ramos.
Hello, hi, good afternoon. You know, it's really overwhelming for me, and I think everyone, to see the inevitable human and emotional connection that there is between the home attendant or nurse and your patient. And I really admire the work that you do. And I can only hope that we can figure out how to make sure that we're honoring your vocation monetarily, that you're properly compensated, that you're afforded, you know, the ability to live the life that you deserve. And so I wanted to understand a little bit that was mentioned, I think it was you, Jason, about upon a patient passing, I imagine there's a lull in between a new assignment to another? How does that work? If the person who you're caring for passes away, is that when you stop being paid? Do you not get paid until you get a new patient to care for? How does that work?
Basically, what happens is if a patient goes into the hospital or if they decease, everything stops. Your pay stops. You don't get another client until, speaking for myself, it's usually hard for me due to the fact that I'm a male. So I have to do male-on-male clients. So it's a little harder. So a few have passed away from me, and it took like 3 weeks, maybe a month, to find something else. In that meantime, I had to jumpstart myself to another agency to keep living.
So you rely on yourself to be able to either plan ahead if you can, because unfortunately these things also happen unexpectedly, I assume.
Yes.
So if you don't have a plan, or if you weren't expecting the person to pass away at that time, what do?
There's really nothing too much to do. You're working for the agency, so at that time, like I said, if they do go into the hospital or they do decease, it's up to the agency to really replace you. And they really don't replace you as they should, so you're just in limbo, honestly.
That's some very difficult uncertainty. And it seems like that's the theme. There's a lot of uncertainty, actually, with this work, which is really ironic because you yourself are a health benefit to another human being. You are a health benefit. That's incredible. A piece of legislation that I tried to get passed, and I was not successful in the last session, was the Corona Presumption Bill. And I guess this mostly affects you, Marta. The ability for a worker to be able to qualify for workers' comp if and when you get hurt on the job, which of course getting infected with coronavirus or anything else for that matter, while on the job in the course of your work should be covered by workers' comp, in my opinion. But that's not something that we were able to obtain. Marta, ¿entiendes inglés? Sé que no lo hablas, no entiendes. Entonces yo te traduzco si quieres. Yo tuve un proyecto de ley en la sesión legislativa pasada, asumiendo de que si un trabajador fuera infectado o infectada por el coronavirus en el transcurso de su trabajo, pues entonces como cualquier otra enfermedad o como cualquier otra herida que se obtenga en el curso de su trabajo, pues entonces tú como trabajadora deberías de tener el derecho para hacer un reclamo de compensación de trabajadores. Pero desafortunadamente no pudimos lograr pasar ese proyecto de ley, así que me quería disculpar contigo, pues porque me parece a mí aún lo más correcto en hacer. I just said that I wanted to apologize to her because I still believe it was the right thing to do for her to be able to, obtain lost wages and be able to provide for herself and for her family because she got hurt while she was on the job. I want to hear more about the wage theft. I carry the SWEP bill. We just passed a construction wage theft bill, but you're actually the first to mention it here at this hearing today. Tú eres la primera en hablar sobre el robo de salario dentro de esta industria a través de los muchos paneles que hemos escuchado hoy. Así que quería entender un poco más qué tan problemática es esa práctica, si es muy común. I want to know how prevalent the wage theft practice is in this industry. You're the first to mention it here among all of our panels.
Sí, siempre esto, y no solamente conmigo, con muchos de los trabajadores. Cuando iban a ver el cheque, que él tenía que mandar timesheet porque el clicking no le entraba. Entonces no era solo con una persona. De muchas maneras, el overtime también. Nunca ellos precisaban la cantidad correcta. Entonces era siempre para nosotros estar llamando, averiguando por todo esto. O sea, no nos...
¿Y tú, en ese momento qué haces? ¿Qué utilizas como recurso? ¿Tienes la oportunidad de ir a tu sindicato y ellos te colaboran con hacer un reclamo con el Departamento de Labor?
No llegué ahí, solamente hablé con la Unión por otro tipo de irregularidades que estaban pasando también con los pacientes, pero ellos realmente me dijeron que iban a ayudarme, pero nunca me ayudaron, realmente, nunca. Entonces yo pienso que nos ignoran o esperan que nos cansemos y siguen haciendo lo mismo, y esto no puede seguir pasando.
¿Cuánto dinero te robaron?
En los 3 años, entre overtime y días que quizás pues unos 3,000.
3,000 en total.
Quizás unos 3,000 o más. Solamente
That's
a mí.
not chump change. That's $3,000 not chump change. She said that she. Do you want to translate for her?
No, you can do it.
That she really she went to her union in order to find recourse for filing a claim with the Department of Labor, but by and large she has felt ignored by the DOL, and it's not really been easy, or it's been practically impossible in order for her to recover her lost wages, and that over the course of about 3 years she lost $3,000 in overtime pay.
Discúlpenme, ellos ahora mismo tienen una demanda colectiva, casualmente por eso.
¿Tú ahora tienes una demanda con ellos?
Otros trabajadores iniciaron esa demanda.
Es que es la misma agencia.
Sí.
¿Cómo se llama la agencia?
Preferred Home Care.
Preferred Home Care?
Sí.
So I'm learning that there are now several wage theft claims made against this employer called Preferred Home Care.
9/11/99, Senator Ramos.
Not surprised, not surprised, Roma, not surprised. Okay. Pues muchísimas gracias por tu participación hoy. No sabes qué tan importante es tu voz, ya que tantas de las personas que hacen este trabajo son mujeres latinas, mujeres andinas como tú y yo. Así que de verdad te agradezco que estés acá.
Y una última, yo sé que me pasé el tiempo, pero
yo también.
Vi tantas cosas, no solamente contra nosotros los trabajadores, también con los pacientes, que yo por eso decidí hablar y decir, no, yo tengo que decirlo porque esto lo van a seguir haciendo si nadie habla, si nadie dice esto.
Okay. So she's saying that there's also malpractice with the patients, not just the employees, and I think that that's a really important point for everyone to understand. And just to translate what I said earlier, I just want to thank you for being here. Your voice is really important. So much of this work is done by Latinas, especially Andean women like you and me, and you're the only one who's testifying here today amongst everyone. So thank you for taking the time to do so.
Thank you, and I will also underline that she made clear that because of the way that they were treating not only the workers but the patients, she felt it was necessary to speak up, and she stepped up in that regard. Solamente quería agradecerle también como compañera el que esté aquí y agradecerle su voz. Next we'll have Senator Rachel May. I'm sorry, Shelley Mayer, because Rachel May is not here. This was a test, and you passed it. Shelley Mayer.
Thank you, Chair. First, I want to thank all of you who are the actual providers of care, because you truly, particularly during COVID, as you described, you really took extraordinary risk, personal risk, and had consequences. And I know I speak for all my colleagues, we take it very seriously and know that you are owed more than you got. And that's our job to fight. But I have a question for you, Rona. The agencies that basically fail to do the right thing, that still get state Medicaid dollars, either through managed care plans or in some other direct route, when 1199 or anyone complains to the Department of Health about their conduct, is there a response?
Justice moves slowly in strange ways in the New York State Department of Health. So we have reported several agencies, and We have fought with several agencies, and unfortunately, they are still in business and collecting dollars. And when we have proof, we talk to the managed care companies. You know, we have a lot of stories, to Senator Ramos's point, like Martha, because when we organize non-union agencies, we hear these stories. And the city of Consumer Affairs in the city has taken on some of these agencies for not paying sick time or doing that. But there has not, they're still receiving Medicaid dollars.
So there's work for us to do in pushing the state, and I don't mean the legislature, I mean the Department of Health and our colleagues in government, to ensure that when state dollars are going out to these agencies, it comes with the responsibility to do the right thing, not to cheat the workers, not to put the patients at risk. And so we have to work together to push that further along than it's gone so far. But thank you all.
And thank you.
Thank you.
We have a last quick aside from Senator Ramos. Go ahead.
Sorry, I totally had more questions. Sorry.
Just a
I wanted
few.
to ask you, Rona, about organizing. You know, because we touched upon that a little bit with your colleagues over on the other side of the industry. How does it work with a much more isolated, you know, with isolated workplaces? How can you organize someone like Martha?
Well, actually, we've got very creative during COVID. It's hard enough to find workers when COVID is not on, but we organized Concepts of Independence, which is the largest consumer-directed and the oldest in New York State, 7,000 workers, and we organized them virtually. And I don't know if any are here today, and we've organized another agency through Zoom and through house visits and finding the workers. And some of the employers have begun to find us and to realize that we really partner with our agencies that do the right thing. And so some of the agencies have found us and are interested because they want to do the right thing and they want to win for their workers. And so we've actually, we try to organize Preferred and Edison, and Isabelita was the organizer, and they were not nice. I say it that way. So it is very difficult, but I think Jason is very interested in helping to organize workers.
Oh my God, you're a natural.
You know.
Yeah.
You're a natural organizer.
He is.
Now I'm gonna put you on the spot.
He is.
Yeah.
Okay.
Yeah.
So,
I see it.
anyway, so we continue to organize workers, and I think COVID kind of shone the light on the inequities, and I think your hearing is helping to do that.
And what's the union density?
Senator Ramos?
Do you know what percentage of the industry? I'm gonna ignore Senator Rivera. What percentage of the
ignore.
industry is the union density high?
Yeah, about, no, not home care organizing. It used to be, I'm not going to make it up. I'll get back to you on that. Let me ask my lawyer.
Thank you, Senator Ramos, and thank you all for being here today.
Okay.
Moving on to the second panel of the
Gustavo, are
second
you
hearing.
from the Bronx?
Just a little bit. And I will also say for the record that I will apologize to you because I have been referring to last year as the Rona.
Oh.
And now when you sat down, I'm like, oh, I have been, okay. Thank you so much. Good Rona. You're the good Rona. The next panel will be Ilana Berger from the Carrier Majority, Agnes McCrae, Board President of Arise. Oh, I'm sorry. Agnes McCrae was already with us. A reader for Sandra Moore Giles from the Senior Home Care Consumer. Sandra Abramson, family caregiver, please make your way down. And Mildred Garcia Gallery, Ageless Companions. You may start when you are down. Thank you so much.
Should I start? All right. Hi. So thank you first to Chairs May, Rivera, and Ramos, to all the staff who worked really hard on this hearing, for the opportunity to testify. My name is Alana Berger. I'm the New York Director of Hand in Hand, the Domestic Employers Network, which is a sister organization to the National Domestic Workers Alliance, and I help coordinate New York Caring Majority. New York Caring Majority is a coalition of older adults, disabled people, family caregivers, home care workers, and home care agencies and providers from across the state, organizing to make long-term care services and supports affordable and accessible to all New Yorkers, and to make home care jobs living wage jobs. So like many others here today, I am also here to talk about the importance of investing in home care, specifically raising home care worker pay through passing Fair Pay for Home Care. I wanted to start with just a short quote from an official in the Nassau County Health Department reflecting on the home care workforce shortage. And they said, "Until we can offer home care aides a sense of worth, a sense of recognition, a fair salary, fringe benefits, and some sort of career-type mobility, we're going to have a problem getting sufficient aides and retaining them." It's a great idea, I'm sure we all agree. There's one issue with that. It's from 1987. We never solved this problem. So in the 80s, home care was growing as an alternative to institutional care, and the population of older adults had started to grow. As a result, the demand for home care workers began to rise. But like today, the pay was low, conditions were challenging, and it was hard to find and retain workers. So almost 35 years later, the challenges are still with us, and by not solving these challenges over the past 3 decades, we've let them develop into a full-blown crisis. The Rona has only made matters worse. Sorry, Rona. So I'm strongly here to advocate for the passage of Fair Pay for Home Care, to increase worker pay to 150% of minimum wage. There are so many reasons to support it, and hearing from workers, hearing from consumers, and the compelling stories are the most important. So I, though, want to talk today about the economic argument. I'm going to be an economist today, although I am not one in real life, and sort of focus on a report that was done recently by CUNY researcher Isaac Jabola Carolus and Professor Stephanie Luce and Ruth Milkman, who couldn't be here, who did a study called The Case for Public Investment in Higher Pay for New York State Home Care Workers. Published this just earlier this year. And they find that lifting wages, like what we would do with Fair Pay for Home Care, would require a substantial public investment, but the resulting savings, revenues, and economic benefits would far exceed the cost. So the CUNY report begins with the same sort of demographic story we already know. Between now and 2040, New York's overall population is projected to grow only 3%, but the number of adults aged 65 and over will grow by 25%, and the age 85 and over by 70%, and that continues to the point where between 1970 and 2030, the over 65 population will have doubled its share, growing from about 1 in 10 to 1 in 5 New Yorkers. Additionally, the Center for Disease Control and Prevention says a quarter of the state's population has a disability. It's likely to increase because of COVID long haulers. They just published this week a study that found that potentially 1 in 5 COVID-19 patients will leave a hospital with a new disability. So based on this, projections between 2018 and 2028, the number of home health and personal care aid jobs is going to grow by an average of over 26,000 a year. Every year, these occupations add as many jobs to the state economy as the next 40 largest occupations combined. This is good news, which means home care is a vital growth sector, but these jobs are going unfilled because people cannot make a living on the pay. So the steady flood of workers leaving these jobs adds to another 72,000 openings, which is far more than any other occupation. The exit, so people leaving the workforce, is much higher than any other sector. In total, we face about 100,000 openings each year in home care, adding up to nearly 1 million job openings over a decade. So CUNY looks at what would happen if you invest in something like Fair Pay for Home Care. It would lift the wages of 85% of home care workers statewide, about 200,000 people. It would cost about $4 billion, which is a lot of money, although in perspective, it's only about 1% of total spending within New York's healthcare system. What they find is despite the cost, what we would get back from economic spillover, which is the money from higher wages in communities, new sales tax revenue from that spending, new income tax revenue, savings in public assistance, and then productivity gains because of less turnover would result in about $7.6 billion in money coming back to the state, totaling about $5.4 billion overall, given the investment in. So it would also create about 20,000 new home care jobs every year, and then 18,000 jobs in other sectors because of this economic spillover. So it's a huge economic benefit. I'm going to be like 30 more seconds just to say, in addition to the economic benefit, we also want to see who's benefiting. So there's 200,000 home care workers who are 90% women, 75% Black, Hispanic, Latino, and Asian, and 67% born outside the United States. So public investment in higher pay is also a powerful tool to advance equity in race, gender, and immigration status. And then for folks who need the care, just if you look again at the aging population, the number of adults aged 65 and over has grown much more among Black, Latino, and especially Asian residents. So solving the home care shortage is also a crucial piece in ensuring that care is available to communities of color. So I will leave it there just to say that it's a great economic investment. It's an investment in equity. Please support fair pay for home care as well as the Home Care Jobs Innovation Fund and eliminating the global cap. Thank you.
Great, thank you. So it says a reader for Sandra Moore-Giles, is that you? Okay.
Can you, is this on?
There you go. There you go.
Okay. Hi, yes, my name is Margarita Stein. I live in Saugerties, New York, and I am reading Sandra Moore-Giles' testimony. I know Ms. Giles from the New York Caring Majority. We advocate alongside each other, and I just want to say she's a remarkable person who puts her body and soul into this work. She is featured in an outdoor art installation currently in Freedom Plaza in Washington, D.C., and she traveled to D.C. earlier this month to speak and to cut the ribbon with Secretary of Labor Marty Walsh. And the only reason she's not here today is because, for reasons of her health, her doctor told her she should not make the trip from Kingston to Albany today. So I have been asked to read her testimony, and I am really honored to share her story in her words with you today. My name is Sandra Moore-Giles from Kingston, New York. I am 75 years old. I've served and cared for my community my whole life. I was a foster mother for 106 children and adopted 4 children. I have worked as a chaplain on Rikers Island and in our prison system. I run the food pantry at my church. I'm on the board for the Office of the Aging in Ulster County. I'm getting older now, though, and now I can no longer do that because of my health. Now I need help. I just received a letter from Fidelis and my doctor saying I need 20 hours a week of home health care. I can't even fill 5 hours a week. Because of the stress and the strain of not having a home health aide, last week I was hospitalized for a blockage in my heart. I wish I could be with you all today, but I'm getting heart surgery tomorrow. Who is going to take care of me when I get out of surgery? No one wants to do home health care work now because the pay is too low. You can make more working in fast food than you can taking care of a human being like me. I need help. I need an aide. Who is going to help me? I do not want to end up in a nursing home. And I'm not alone. I live in a senior building. Many of my neighbors are going through the same struggle. We need to make home care jobs good jobs. We need to support seniors to live independently. We need you to pass fair pay for home care as soon as possible. Thank you, Sandra Moore-Giles.
Thank you. Thank you for being here to do that. Sandra.
Hello, my name is Sandra Abramson. Thank you, Senators. Better? Thank you. No? Can you hear it now?
Yes.
Okay. My name is Sandra Abramson. Thank you, Senators Rivera, May, and Ramos. I'm a 75-year-old senior living alone in Senator Benjamin's district in New York City. I'm here to tell you my story and about why it is so important to have a well-paid and trained home care workforce to care for seniors and people with disabilities in New York. In 2006, it became increasingly clear that my partner, Terry DeFiore, later to become my wife in 2011, when we were permitted to marry in New York State, was having increasing physical, psychological and emotional difficulty with day-to-day activities. She was losing her balance and falling. She would break into laughter in inappropriate times. She, who had been able to problem solve with ease, was continually making errors in judgment. It took us nearly 3 years to learn that she had progressive supranuclear palsy, or PSP, a degenerative neurological disease that would render her progressively incapable of caring for herself. However, we were very lucky. In 2002, we had decided to look into purchasing long-term care insurance. No insurer would sell me a policy, as I had had a stroke several years earlier, but Terry was in perfect health and was able to purchase the Platinum policy, long-term care from Genworth. It covered her for life and had a high monthly payment. Little did we know that Terry's perfect health condition wouldn't last for more than 4 years. Genworth didn't know that either. By late 2008, Terry, who had worked in the construction field as a site safety manager, began to show increased signs of her illness. Her task was to keep workers and others safe. As her disease progressed, however, she could barely keep herself safe, let alone care for others. She stopped working on December 1st, 2008, and in 2009 of April, Genworth started covering the cost of caregiver to be with Terry during the day, as I was still working and Terry needed someone with her so she would be able to attend our local senior center, go up and down stairs, eat, and do all the things she could still do. In 2010, when Terry moved downstairs, she needed 24-hour care so that I could get some sleep and be able to do what I needed to do to care for myself as I supervised her care. We were working with Visiting Nurse Service of New York, VNS, to find and supply caregivers. VNS supervised the caregivers and charged us a little more than $20 an hour, while they paid the workers about $9 plus an hour. Genworth's reimbursements, totaling nearly $13,000 monthly, covered Terry's care costs and other essential costs. We had several caregivers over the years through VNS. They were generally competent, caring, and compassionate. However, at some point I began to consider asking some of the caregivers if they would work for us privately. We could offer them nearly twice what VNS was paying them. After some back and forth, one agreed. I found someone else. From 2011 on, I supervised a caregiving staff of 3+ women who were wonderful caregivers. I did all the scheduling, the invoicing to Genworth, as well as the payroll and tax payments. We were able to pay them over $18 an hour. After living with this horrendous disease for nearly 7 years, Terry died in 2013. Genworth had paid out more than $600,000 to cover her caregiving costs, although she had paid less than $15,000 in premium. Had she not had the insurance as well as other disability insurance and Medicare, we would have had to sell our home and other assets to pay for her care, or she would have had to have been declared indigent and gone on Medicaid. Terry's story would not be my story if I were to contract a debilitating disease. As I said, I don't have any of the insurance coverage that Terry had. I would have almost none of the support or income that she had, and I have no one to care for the daily, weekly, monthly tasks that I performed for her at no cost to anyone but us. We were able to keep Terry at home. In all that time, she never went to the hospital for nearly 7 years as she struggled to live with dignity. We were lucky to have the funds and a home that we could transform into a workplace and living space for caregivers working 24/7. New York is the epicenter of a national income care worker shortage, with a projected shortage of 50,000 workers by 2023 and over 83,000 by 2025. This shortage means tens of thousands of New Yorkers are currently at risk because they cannot receive the services that they need to live a high-quality life in the community, with hundreds of thousands more on the brink of disaster. Low wages are the reasons for this crisis. Governor Cuomo claims that New York is the most age-friendly state in the nation. While we appreciate the sentiment, if Governor Cuomo wants New York to lead in this area, we have a long way to go. I'm now 75. As I age, I wonder how I will live if I get sick and need the kind of care Terry needed. Without fair pay, where will we be able to find the kind of caregivers that Terry had? Thank you.
And Mildred.
All right, Senators and Senate committee members. My name is Mildred Garcia Gallery. I'm a proud Latina. I have been a home care worker for more than 30 years and the founder of Ageless Companions, a Long Island-based staffing agency. I was introduced to home care at 19 while I worked for United Cerebral Palsy. One client, a young man in particular, named Theory, truly impacted my views on home care. He was wheelchair-bound, and he was in a special program for eating. One day during lunch, he began to choke, and he turned blue. Although I was scared, I jumped into action. I suctioned him, dislodged the piece of food, and thank goodness he began to breathe. We both sighed in relief. I was shaken, but I felt capable and competent, and I hadn't felt that at that age, at that time, and it really gave me direction. It made me want to do better and be better. It changed the direction of where, or the projection of where I was going to go in life, because I was not one of those, my circumstances did not allow me to go to college directly out of high school. So home care actually saved me in a sense. I'd like to continue on. So I continue to provide the best possible care for all of my clients. One of the most memorable clients was Ralph Cipriani, a 95-year-old World War II veteran, and his wife, Christine. Ralph, when I met him, was 98 pounds, but his will to live was as strong as my will to care for him. I learned much about life from Ralph. I learned about patience. I learned about the value of human contact and human interaction and how much that does feed and nurture a person. Together we worked tirelessly. His doctors were impressed with the amount of progress he made in such a short period of time. Our growing friendship encouraged him to fight a little bit longer. Unfortunately, Ralph lost his battle, but on his own terms, at home, with dignity, with love and support, and I was proud to be a part of it. And I'm proud to still currently care for his wife, and they were married for 71 years. And anyone knows being married that long, a loss like that can actually take you down. But it didn't, because she has us and we have her. This has been my life's passion, my life's work passion. But with the low pay, I wonder every day, how can I stay? How can I continue to stay in a profession that does not value me? How can I support my family, my 3 daughters? I'm trying to put them through college. This work makes me feel wonderful, but it doesn't pay the bills. I know that I am one of thousands of people who love home care work. But we're feeling forced to leave a profession because of its low wages. So I am here to ask you, to beg of you to say this is the time. We need it more than ever. The families need it. They need our care, but we need to be cared for. To go on to continue to care in a way that you care for your own family, but yet to go home and to come home to your own empty pantry, to not be able to provide for your children the things that you want, that you see maybe the families that you're caring for. And it really is about the humanity. I feel that we have lost that sense of humanity, where possessions and things mean so much, and at the cost of our loved ones' lives, of how we care for them. We have got to put that first, because without human compassion and us coming together to solve this problem, I don't know what else is going to happen. I don't know who else to ask for. We have exhausted every area, and this is a job that I and many others are so proud to do. And there are all these misconceptions about us, and those are stigmas, and that's not the majority of us. It is the minority. I speak for all of the ones that love to do this, and we don't want to leave. We want to stay and do this work that we've been doing for long, or people that just came into it. We want more people to come and join us, but they're not going to for this pay, when they can go to the Holly Lobby or wherever and make more money. So what are we saying? That the value of our loved ones is not that much.
Thank you. Thank you so much. Thank you, all of you, for just reminding us how important this is. Lana, I wanted to follow up with you because you talked about 100,000 openings a year, and all of you talked about what this job means. One of the things it means, if we have 100,000 people who are looking for care and not getting it, is that there are a lot of families that are stepping in and doing that care. There are a lot of people who are putting their own lives on hold in one way or another, stepping away from the workforce, or going part-time, or all of those kinds of things. I have a bill to create a family caregiver tax credit, but it's a tiny drop in the bucket in terms of what the costs are. So I'm just wondering, when you talked about the $7.6 billion return on a $4 billion investment, I'm very familiar with that. We have the bill on the Investing in Care Act that is specifically designed to activate that, that investment. I'm wondering, was this also considered in there, the opportunity cost of all of the family caregivers who were going to step in, or neighbors, or whoever was going to step in and do this work voluntarily because somebody had to do it? Is that calculated
I would say
in there?
it's not in the CUNY report that looked at those numbers does not look at that. So that's an even additional economic benefit that is not quantified, at least in that report. And from all of the numbers I've seen about the amount of money taken out of the economy because of family caregivers, it's billions. So I think I would say that the CUNY report's numbers are fairly conservative in terms of the economic benefit of investing in this workforce.
It would be great to fold that in so that we can be telling
Well, we
the whole
should-
story when we are
As I
advocating
said earlier,
for
I
this.
in fact only have a college degree and I'm not an economist, so we can set the economists back on that one.
Perfect.
But I do just also want to say to that, in terms of the numbers and the shortage that we're hearing, and you'll hear more from people, but on the daily we're getting calls from folks who sometimes family members step in, but sometimes people don't have family members, and they're actually, the only option is either, we have members who are staying in bed for 24 hours who can't get out of bed without an aid. And ultimately, if you can't find somebody, your only option is an institution, and that is not where people want to go. So we're in a real crisis right now.
Right. And to Sandra, I wanted to say thank you for kind of explaining how long-term care insurance can work, but what we're hearing is that a lot of the companies are going belly up. People have invested in those and they aren't going to get the insurance anyway, or it's not what it was cracked up to be. So that's a whole nother area of healthcare where what we really need is the New York Health Act. But we have to look at that, like what
we knew how
provisions
lucky we
can
were.
people make?
We
Sorry?
truly knew how lucky we were. I mean, when I said it was the platinum policy, they didn't know what they were getting into. I mean, we didn't know what they were getting into either, obviously. Sorry. We didn't know what we were getting in. They didn't know what they were getting into. They paid out over $630,000. It really was the platinum policy. No one can get that anymore.
Don't feel sorry for
right.
them. They were getting premiums from a lot of other people.
They were part of General Electric. I don't feel sorry for them.
Anyway, thank you all. Does anyone else have questions?
Thank you all.
Oh, Brian?
Sure, yes.
Oh, don't go anywhere.
I'm sorry, I'm sorry, I didn't. No, first of all, I want to thank you for this testimony, and I, obviously, to Sandra, I really appreciate hearing how much you did for Terry, and, in my heart, I believe that you should have been compensated as well. I do, I feel very strongly that family caregivers, when possible, because I do accept the fact, I do understand that some don't, is what you're looking for. My father-in-law passed, and his wife and my wife were able to take care of him at the end, and there's the love that you bring to that, and so I want to just thank you for your testimony and for being here to help us as we're figuring out steps forward. And obviously, I'm a proud supporter of fair pay for home care workers. So thank you for being here.
Thank you. No, you can go. All right, we have panel 3 next. Mary Lister, Ignacio Reyes, and Joanne Lump. Thanks for me.
By the way, folks, by the way. Just as a quick thing, folks, after you're done, you don't have to go up the stairs again. There's actually an elevator a little bit outside that door.
Thank you.
I want to make sure that you're good, you know?
Thank you. All right, let's start with Mary.
Good afternoon.
Touch the button, make sure the light's on there.
Say something.
No.
One more time, just touch it once and then say something. Say something. One more time. Try it one more time.
Am I supposed to?
No, but just,
Do it again.
just press it slow, like just a little bit, just a little touch, just a little tap.
Hello?
There you go. I'll say it once again. We need to get new damn mics. Anyway.
The austerity budget does not allow for technology.
Hi, my name is Mary Lister, and I'm a home care worker from Buffalo, New York. I'm a founding member of the Queen City Worker Center, and I organize with other home care workers throughout the state with the Ain't I a Woman campaign. I've been a home care worker now since 2013. During this time, I've served in so many roles for so many different people. I've been a community habilitation worker for a young woman with cerebral palsy, assisting her in achieving her career goals. I've been a consumer-directed aide for an older nonverbal man who uses a wheelchair, helping him get dressed every day, cooking him meals, and cleaning up around the house. One of the people I currently serve is an older woman with advanced Alzheimer's who requires assistance in every single task of daily living, from eating to toileting to walking. Not a single person goes into home care because it pays well. I have stayed in home care so many years because I love it. I enjoy assisting people to live the life that they want with dignity and as much independence as possible, and I'm good at it. Most of my years as a home care worker, I earned minimum wage. But I urge you to consider what is truly necessary to grow the home care workforce and to make possible a real minimum wage increase, an end to the 24-hour workday. Long work hours in any field are correlated with increased workplace mistakes and on-the-job accidents. Many studies have found that, in the medical field specifically, rates of injuries and mistakes skyrocket during shifts longer than 12 hours. In home care, there is no such thing as a small mistake. A mistake in medicine could mean health complications for the person receiving care. A mistake in a transfer could mean a broken hip. And a mistake that injures the worker themselves can take us out of the field permanently, creating this issue of a home care workforce shortage to get worse. The incidence of disabilities suffered by home care workers is confirmed by a study by the University of New Hampshire Institute on Disability Statistics. They found that home care was the industry in New York City with the most workers to become disabled. In New York State, home care was fourth. 24-hour shifts is causing more people to become disabled and need in-home care. Why this difference between New York City and New York State in general? In Buffalo, where I'm from, and other upstate cities, the 24-hour shift is not yet common. Care recipients requiring round-the-clock care have generally managed to get split shifts rather than one worker doing 24 hours. But if, as we are all hoping today, the minimum wage for home care workers increases, upstate home care agencies will have a huge incentive to start implementing 24-hour shifts for 13 hours pay. This has got to stop. If we want an end to the home care workforce shortage, if we want a sustainable and a thriving economy of care, then we have to put an end to treating home care workers like disposable machines to be used up and thrown out. We need to not only raise the wage, but end the 24-hour workday. Please immediately support Assembly Bill 3145, Senate Bill 359, legislation supported by and created in large part due to the organizing of home care workers that are here today. Thank you.
I'm sorry, could you please repeat the bill number?
A3145 and Senate 359.
359.
I will double check that, but yes, that's what.
Thank you, ma'am.
Ignacia?
Muy buenas tardes para todos.
Buenas tardes.
Buenas tardes. Mi nombre es Ignacia Reyes. Yo trabajo por 23 años de home attendant. Y yo estoy representando todas las home attendant de 24 horas, porque casi todas estamos lesionadas. Y venimos acá para que POMO nos firme el salario robado, que nosotros luchamos mucho por él, todas las home attendant, y ahora queremos que nos recompense el salario robado que tengamos. 24 horas, 23 años. Así es que todos tienen que quitarle las 24 horas y compartir las 12 y 12, que a 24 horas es un trabajo inhumano para nosotros. Yo misma estoy lesionada de una pierna por no dejar caer mi paciente. Y POMO tiene que darnos nosotros, cumplir con nosotros todas las home attendant de 24 horas. Ok. Gracias.
I'm going to translate for Ignacia. My name is Ignacia. I have been a home attendant for 23 years, most of that 24-hour shifts. And I come here to speak on behalf of all workers, home care workers, who work 24-hour shifts. We can't continue with this. Many of us have come out of this injured. We've got to stop it. It's inhumane. The 24-hour shift is inhumane. And on top of that is the wage theft. Cuomo didn't sign the bill that would have helped to stop it, but this still goes on. So we have got to stop both the wage theft and the 24-hour shifts. Thank you.
Ignacia Reyes casi no puede caminar ni subir escaleras por las lesiones que he sufrido. Y entonces, ahora no quieren pagarme. Y la ley 99, el cheque que me da es de $119 por 23 años trabajado 24 horas. No hizo nada por nosotros, las home attendant. No hacen nada, la ley 99.
Right now, I'm so injured, I can't go back up those stairs. And I'm a member of 1199. They really haven't done anything for us.
Tienen que estar por ahí. Tienen que estar por ahí. Sí, ok, muchas gracias para todos. Y la senadora que nos ayude a todas las home attendant de 24 horas, que hable con POMO y que le diga, firma la ley de salario robado, que nos tienen a todas las home attendant.
So, senators, please call Governor Cuomo. Tell him he's got to sign that bill to stop the wage theft.
Ay, apóyenlo, por favor.
Sí, señora.
Well, thank you, senators, and other participants for convening this.
Por todos que seamos escuchados aquí en el Senado.
Thank you.
Todas las home attendant de 24 horas que seamos. Okay.
Gracias.
Okay. As you can see, people feel very passionately about this question. But my name is Joanne Lum, and I'm here with the National Mobilization Against Sweatshops and part of the campaign called Ain't I a Woman campaign, which Mary and Ignacia and I are all part of. This is a campaign that's statewide, and it includes workers groups, disability rights groups, student group, women's groups, and others. And we've been organizing for 20 years or so around the valuing of caregiving and against long hours of work. And we're here today because we agree that it's urgent for the government to take action to address the shortage of workers in home care. And to value the work of caregiving, raising wages is critical, it's needed. But to make this wage increase real, we need to end the wage theft that happens, for instance, in 24-hour shifts. So many workers like Ignacia work 24-hour shifts, don't sleep, and are paid for only 13 hours. That means 11 hours for free. So this renders the minimum wage law meaningless, this type of wage theft. So even if you raise the wage, it also means more wage theft. We also, as part of we need to end the 24-hour shift, also as Ignacia said, more fundamentally. And at the same time, we need to hold the scofflaw employers accountable. As some previous people have spoken about, there are a lot of agencies that don't comply with the law, that don't do right by the workers. And actually, we've worked with hundreds and hundreds of home care workers to file lawsuits and labor complaints at the Department of Labor exactly for that reason, to recoup stolen wages, wages that weren't paid, especially in these shifts of 24 hours. And some of the workers have also initiated protests against their agencies. For instance, right now, the workers of the Chinese American Planning Council, CPC, have been leading protests against their agency because they still have not been able to recoup their stolen wages after waiting 6 years, 7 years almost, with a claim. There's so many more with the same story, and these are at union and non-union agencies. It's so prevalent. So we've already heard a little bit from Ignacia about these 24-hour workdays, and Mary has spoken to it also, but we began in our campaign to see home care workers coming forward about 6 or 7 years ago. And first it was about the wages not paid, the overtime, the hours that weren't paid. But then more and more, they began talking about how the 24-hour shifts destroyed their health, as Ignacia mentioned, destroyed their families, destroyed their lives, basically. And for those with no work or not enough hours, these 24-hour workdays negatively impacted them too, because some people were overworked and then leaving other people with not enough employment. It also, these 24-hour workdays sends a message that there's no floor, that caregiving work is so devalued that a woman can be made to work every single hour of a day. No man, it's no wonder that so many refuse to be subjected to these conditions. People earlier spoke about the pandemic and how it's made it worse for home care workers, and we've certainly seen that. We saw so many home care workers coming to us for PPE, and we lost a few members to COVID in our organization. And because of the lack of protection in their work, a lot of workers have decided not to continue working in home care. Also, many others, because of health problems and illnesses, as a result of years of working 24-hour shifts, they've decided to retire early. Even before the pandemic, home care workers were made to work 24-hour shifts for days on end at half the pay. And it made it hard. Many people talk about how it's made it hard to provide proper care. We were talking about it earlier with some other participants. When you're sleep deprived, when you're stressed.
Joanna,
This-
can you wrap up? please?
Sure. So I just want to reiterate then that we call on legislators and participants here today to unite, to join forces, to call for wage increase, an end to the wage theft, and an end to the 24-hour shift, so that we can really show that we value the work of caregiving. Thank you.
Thank you.
Thank you so much. I was wondering, Joanne, if you could provide a little more context for those at home who may be watching and are not aware about the 13-hour rule and how many home attendants are, working 24 hours a day around the clock to care for these folks. Because of course, even if the patient is sleeping, sometimes they get up in the middle of the night, they have needs, they need to use the restroom, they need, right? So the home attendant has to get up as well, right? And do their job. Can you talk a little bit about the court decision that took place and kind of a little backstory?
Hello. Oh. So at first there were, back several years, maybe 6 years, there were 3 court cases, state court, where the workers, there were workers who were working 24-hour shifts and bringing claims for their owed wages, where the courts decided in these 3 cases that it doesn't matter if you slept or not, you should be paid all 24 hours. And we celebrated. But then immediately that the Department of Labor issued emergency regulation to say, no, that's going to bankrupt the industry. We need to keep the 13-hour rule. And so subsequently, there were appeals to those court decisions, went to the highest court in the state, and the highest court overturned the lower court decision. So basically the law now is that it's okay to work 24-hour shift. You're entitled to 8 hours of sleep, 5 hours of which, at least 5 hours uninterrupted, plus 3 hours uninterrupted meal break. So it's very clear, the law, actually. But the problem is that in reality, when workers can't get that 5 hours uninterrupted sleep and they report it, then they're either ignored or they're threatened. And there have been cases where agencies have told the home care worker, put the patient to bed at 9 p.m. and just, in the night, just go to sleep because we're not paying you for the night. And if there's a problem, call 911. So there was one case where the worker, of course, she's not going to ignore the patient. You're there to work, to be there on call. And so she went, as usual, to help the patient. And she reported that the next morning to the agency that she had to get up to help the patient. And she was fired. We subsequently were able to work with her to get reinstated. But this is just an example of how on the ground, what is really happening, so that workers are pressured to not report that you didn't sleep.
So do we know approximately how many workers have been victim of this 24-hour shift, and how many workers are owed wages?
I don't have numbers. Our worker center is very small. We work with other small worker centers, but I would say, we have seen, like I say, hundreds and hundreds and hundreds of workers, and we've filed claims for probably in our campaign, maybe more than a dozen agencies, different agencies, and like I say, some are unionized, some are not unionized. And those that are unionized are in different unions. Some are Local 1303, some are 1199, some are some other that I haven't really heard of. But anyway, it's a mixed bag. Right. We have heard from others that the percentage of overall cases that are 24 hours is very small and partly because the managed care companies don't really want to give that a lot of times. I mean, it's a big fight sometimes to be able to get those hours for those who need it. And so, but now we hear that more and more workers are actually feeling emboldened, and maybe it's because of the campaign, but feeling more emboldened to say no. But the problem is that all along, workers have said that they took 24-hour shifts not because they like them,
Right.
but because you're
They were
told-
pressured.
Yeah, like if you're...
How, sorry, because we
Okay,
do have limited
sorry.
time, right? How do you propose that not-for-profit organizations with a limited operation budget be able to, compensate the workers for their lost wages?
They take on, that's the law, compliance with the law, and maybe the government needs to help them on it. But I mean, one shouldn't operate a business if you can't comply with the basic minimum wage and overtime law.
No, I agree with you. I'm just thinking that if an organization were to pay out, and then the organization were to fold, then what happens to the actual industry? I'm just trying to think, kind of one thing after the other chronologically. So workers get the money that they're owed, that they're rightfully owed, but some of these organizations and/or actual for-profit businesses fold. Then what happens to the industry?
Maybe they should work.
Okay. For at least some of these nonprofit agencies, there's a false misconception that they're strapped for cash. Some of them are very good at fundraising money. I'm sure some of them are strapped for cash, but some of the worst, the ones who have stolen the most wages from their workers, are building a new building right now that's very luxurious and nice. And their CEOs are making upwards of 6 figures a year. So it's hard for me to, I think that at the bottom line is we are coming from worker centers, and the law supports that we should get the minimum wage for the time that we're working, and that's not happening. And so if the
I
agency-
understand, but
yeah.
my question is about the future of the industry.
Yeah.
So again, you guys get your money, right? Assuming you guys get your money, who then, and these organizations fold, for-profit, not-for-profit, how does the industry rise up? Because people will still need care.
Mm-hmm.
So how would that? I'm trying to find the rebuttal to the DOL's assertion that their emergency clause after the court decision where they said, no, but wait a minute. What's the rebuttal to that?
Well, first of all, like I say, there should be compliance of the law, and so they should figure it out, and they should look into maybe the profits of the managed care companies. We've asked several different venues, government agencies, to investigate into the money stream of Medicaid going to the managed care, going to the home care agencies. We can never get any numbers. So who knows? This was the redesign, Cuomo's redesign of Medicaid back in 2012, was it? Or
2011.
2011, thank you. And so that's where when the introduction of the managed care company into the system came in. So maybe we should look at the profit margins of that. But I think it's problematic that many, I'm not saying you are, Senator Ramos, but many justify the maintenance of these 24-hour work days on these women, subjecting these women, immigrants, women of color, to 24-hour work days because there's no money. I mean, if we're here, I think many of us here want to end violence against women. We want to address racism and sexism in our society. And then we subject women of color, immigrants, to 24-hour work days. What does that say about us as a society?
And how far back would you want to go?
Well, the state labor law allows 5 years going back, the statute of limitations. So this is just the minimum, the bare minimum. We're talking about just the minimum wage and overtime that's owed. So when we're talking about raising the minimum wage, that's why we say to make it real, the law needs to be enforced. And if it's not enforced already, then it's just going to mean there's going to be more wage theft. That's our concern.
Okay, very valid concern. Well, in my last 30 seconds, I want to assure you that every Democrat on this dais right now is a co-sponsor of S359, the bill that you are advocating for fair pay. And we hope that the other senator joins us too. Thank you.
Yeah, thank you so much. I just have one comment that I want to make, which is about the calling 911. If they said, you know, if your sleep is interrupted, and that's just a way of passing the cost on, again, to the taxpayers. I mean, if taxpayers are supporting the home care, we're supporting the police at a much higher level, and especially they're getting overtime if it's in the middle of the night. And so the idea that you would just say, pass that cost on over there, it all comes home to roost with us as taxpayers. So altogether a broken system. Thank you for bringing that to our attention.
I got a couple.
Oh, okay.
So I'm glad that Senator Ramos pointed out, we are all co-sponsors, I am as well. I wanted to ask you something about it though. It's perspective in nature, is that correct? Because if we're talking about we can all agree that the 24-hour rule is a problem. And we can also agree that it's the state that's messing up that by not changing the law, right? The decision that was made regarding the current state of affairs, and correct me if I'm wrong, obviously, because you know about this much more deeply than I do. But the current state of affairs, that decision that was made basically said the state has to change the law to make sure that this happens, and so we're the ones messing up. By passing, if I'm not mistaken, if we pass the bill 359, it would solve the problem going forward. It wouldn't necessarily address the issue of past salary. Is that correct?
Yeah, the law to prohibit 24-hour shifts would, moving forward, means split the shift. It's 12-12 for two people. So moving forward, and it would indirectly address what has happened in the past, because now there's less chance of the wage theft because you have two people working 12-hour shifts who need to get paid 12 hours each. But right, as far as the compensation for the 6 years going back and those claims, that's for each agency to resolve, to pay it up. You know, the workers were owed this amount of money. They filed lawsuits, they filed complaints at the Department of Labor to resolve those, pay the workers.
Gotcha. And as far as because it's obviously, I mean, I just want to make sure, it's obviously, we're the ones that are messing up, right? The state is the one that's, by not passing this bill, we're making it so that this is just, that bad actors can get away with abusing their staff in a much easier fashion.
That's true. At the same time, we need to hold those bad actors accountable too. I mean, for actions already taken, because there are, you know, very prevalent violations of the minimum wage and basic wage law.
But is there possible as well that there are good actors who are caught in the middle because the law is what it is right now?
So as Joanne had mentioned before, even under this law that we want to change and we want to turn into split shifts, even right now, the law says that if a worker does not get 8 hours of sleep at night or does not get 5 hours uninterrupted sleep, you must be paid for all 24 hours, and agencies still aren't doing that. And so I think part of what we feel is that not only do we need to pass this bill to make sure that going forward workers are not literally worked into the ground, but also that for the agencies who are flouting the law as it currently stands, firing workers when they report having to work at night, telling their workers not to help the clients when it's during the nighttime hours, they are breaking the law as the law stands. And so I think that for the workers working for those agencies, they feel like, you know what, this is day in, day out. If any of these home care workers were to break the law day in, day out, not only would they be fired, they'd be in jail. But instead, these agencies are making record-breaking profits, some of them. I know some of them are struggling. But so for us, the law is part of it. Yes, the state needs to step up. We need split shifts. And also these agencies that are blatantly breaking the law and not paying the workers the amount that they're owed when they're not able to sleep need to be held responsible as well.
Okay. Thank you. Thank you, Madam Chair.
Okay. Thank you all. Muchas gracias.
Muy
Ignacio.
bien, Rachel. Raquel, muy bien.
Estamos enseñándole.
Ahí vamos.
All right, panel 4 is Rebecca Prevey, Tara Klein, and Carlin Cohen. And we're going to ask Carlin Cohen to go first, if possible.
Chao, Ignacia.
Sí, por ahí me invito,
Nos
sí,
vemos pronto.
para que no tenga que subir para arriba. Cuídese, señora.
No, pues ni modo de subir para abajo.
Usted me entiende, cuando no-
Can I ask you guys a question?
Yeah.
On S359, this, because I'm not on that committee, so has that moved out of committee? I don't know, Senator Ramos, if you have it?
It has not.
Okay, that's why I didn't know about it, but I'm willing to take a look at it. I am the sole Republican up here. So,
Appreciate
no, that
it.
was
Thank you.
triggered towards
for that.
me.
Thank you for your consideration.
Yeah, hasn't moved though, so that's why I didn't know about it.
So Carlin, can you go first?
There you go.
Just
Just press it once, really quickly.
really lightly, just like,
Go ahead.
Hello?
There you
Yes.
go.
Oh.
There you go. We need new mics.
Good afternoon. Thank you for the opportunity to testify at today's hearing. My name is Carlin Cowan, pronouns they and she, and I'm testifying on behalf of the Chinese American Planning Council, CPC, today. I'm going to start with a personal story. When I was 11, my mom got sick, couldn't get out of bed sick. She had to go on disability, and it took years of doctor's visits, PT, and more before she could do simple things like walk or change her position unassisted. My dad and I had to figure out care for her, my chronically ill younger brother, and the household, while of course still managing work and school. I tell this story because we all have a care story here today, and if you don't have one right now, you probably will. 7 out of 10 of us are going to need long-term care at some point in our lives, and it's often earlier than we think. New York State is aging rapidly. By 2030, 5.2 million people in the state will be 60 or older, not to mention more than 1 million disabled New Yorkers that need care to live in their homes with dignity. The good news is that New York State is constitutionally mandated to provide these services to all New Yorkers because of the U.S. Supreme Court Olmstead decision. The bad news is that the state severely underfunds the nonprofit organizations and workers they outsource these services to, and New York is now the epicenter of the home care workforce shortage crisis, with a projected workforce shortage of 83,000 workers by 2025. The cause of this workforce shortage is chronic low wages and poor working conditions pervasive throughout the sector, a direct result of state funding decisions. According to the New York State Department of Labor, the median annual salary for home care aides is $24,800. The low wages chronic to the sector are deeply rooted and directly connected to the systemic devaluation of care work as work that is traditionally performed by women, historically enslaved Black women in the United States. Today, the home care workforce in New York State is 90% women, 75% people of color, 67% immigrant, and the state continues to enshrine the devaluation of care work in its programs, practices, and reimbursement rates. CPC, as well as its affiliated home care organization, CPC Home Attendant Program, or CPC HAP, have 4 core recommendations to reform the home care sector and build a just and caring New York. CPC has been advocating on these issues since 2017. Number 1, end the Department of Labor 24-hour rule. One of the most urgent issues in the home care sector is the 24-hour rule, where home care workers are assigned 24-hour live-in shifts and are paid for 13 hours of work, with 8 hours allocated for sleep and 3 for meals. This is based on a Department of Labor rule that was upheld in a 2018 Court of Appeals decision. CPC believes that no worker should have to be away from their home for 24-hour shifts, and that workers should be paid for all hours they work. The state must immediately end the 24-hour rule in favor of 12-hour split shifts, where home care workers are fully compensated for each hour worked, which can only be accomplished through passing A 3145, Assemblymember Epstein's bill, S 359, Senator Persaud's bill. This will cost $1 billion a year, which is a fraction of the New York State's $212 billion budget. Nonprofit home care organizations like CPC HAP are 100% Medicaid funded, required to comply with all of their state contractual, legal, and union agreements, and must provide the type and hours of care assigned to each client by Medicaid. They cannot simply drop existing 24-hour cases due to the patient's Bill of Rights. CPC HAP and many other nonprofits have stopped accepting 24-hour cases and strongly seek authorization for 12-hour split shifts for existing cases, but are more often than not denied by the state. This neither solves the problem for workers who must work these shifts or people that need round-the-clock care. This is why the system was changed to make 12-hour split shifts the standard instead of a rare exception. Number 2, pass fair pay for home care, S5375A6329. Fair pay for home care would raise home care worker pay to 150% of the highest regional minimum wage across the state, allowing workers to remain in rewarding critical care jobs instead of making impossible decisions about moving to higher wage jobs in different fields. It would also wipe out the home care workforce shortage in less than 5 years, creating 20,000 additional jobs per year for the next decade, according to a recent report. Number 3, remove the arbitrary spending cap on Medicaid and fully fund Medicaid to meet the needs of more than 1/3 of New Yorkers that rely on it. Rather than removing the spending cap, the governor chose to cut $1 billion in Medicaid funding in the middle of a global pandemic. Rather than remove the spending cap, the governor has chosen to depress home care wages through reimbursement rates and cause a workforce shortage crisis. By removing it, we can both fully fund our home care workers and the people that need care. And number 4, last but absolutely not least, pass the New York Health Act and guarantee universal long-term care for day one for all New Yorkers. New York State has rationed care for far too long, prioritizing government austerity and private profits over our quality of life and dignity. As a result, workers have suffered, older adults have suffered, and disabled New Yorkers have suffered, disproportionately women, people of color, immigrants, and low-income New Yorkers. But it doesn't have to be this way. New York has the resources to fully fund Medicaid and long-term care services to meet their growing need and its constitutional obligation to provide for it. We don't have to choose. We can and we must build a robust long-term care system with good jobs where workers can thrive, and seniors, disabled New Yorkers, and every one of us who needs home care can receive the full care that we need in our homes with dignity. Thank you.
Senator Ramos has to leave at 4 o'clock, and she specifically asked if
I apologize. I just, I wanted to kind of see the whole of the issue. And I agree. I mean, a big part of the conundrum of this money, especially for our not-for-profit organizations and not our for-profit agencies, right, is the fact that, the big guy on the second floor just insists on chipping away at the money that we need in order to care for each other. So I'm wondering, is there anything else aside from that we can help, that we can do to help not-for-profits achieve the solvency they need in order to do the right thing for the workers? And I'm wondering if your organization has an idea of how many of your home attendants are impacted by this 13-hour rule, 24-hour shift.
Absolutely. So CPC HAP, which is an affiliated organization, I'm at CPC, the Social Services Agency, just to clarify, has 54 24-hour cases that are staffed by about 130 workers. There are about 11,000 cases across New York State, staffed by about 33,000 workers. So while it is, a small portion of home care across the state, it's still a very urgent issue because, as you heard from the previous testimonies, we have workers working under these conditions that they shouldn't be, and in homes for 24 hours without getting compensated for all the hours of their labor. So nonprofit home care agencies like CPC HAP, as I mentioned, are 100% Medicare funded, which means all of the funding is tied to Medicaid rules and reimbursements, and then of course they're subject to union agreements, Department of Labor laws, et cetera. CPC has been advocating. First, we were actually advocating when the court cases were going through, the Court of Appeals decision that I mentioned, for the state to pay back wages for the workers to make up for the gap between the 13 hours that Medicaid pays for the time in home and then the remaining hours that Medicaid calls sleep and break mealtime hours and doesn't pay for. So at CPC HAP, if a worker gets interrupted at the first recorded interruption, CPC HAP pays out the full hours for between the 13 and the 24, but that's not the standard across the industry, and I think that those are some of the problems that you heard about in the previous panel, and the only way to make it a standard across the industry is to have it standardized across Medicaid rates. So we were initially advocating for the state to fund back wages, which would have cost $6 billion. The Court of Appeals decision essentially meant that the state was upholding its own Department of Labor law. And so since then, we've been pushing on the A3145, which is the bill to end the 24-hour rule. That would solve the issue going forward, but of course, it would not deal with retroactive compensation. I think that I'm not a legal scholar, I'm a humble advocate, but I think that there's a very difficult path legally to what that would look like based on the Court of Appeals decision, but I think there are a lot of people that are more expert than me on that. But that's why we're really focusing our efforts on moving forward, ending the 24-hour rule, and increasing wages for home care workers.
Thank you, and I apologize that I have to run, but I have to go back to the city. Thank you, good to see you all. Good to see you, Tara.
Thanks. Next we have Becky Prevey, and you're not going to read your testimony, right? This is like 90 pages here, so, okay.
Is this on? Perfect. No, Senator May, I would never do that to you. First and foremost, I want to say thank you to Senator May, Senator Rivera, and Senator Ramos for hosting what is really a very important hearing on this issue. My name is Becky Prevey. I'm the Executive Director of the Association on Aging in New York. We're a not-for-profit membership organization that represents the 59 offices for the aging throughout New York State. Our network leverages over 1,200 community-based organizations, and I'm here today on behalf of this network and the massive issue we are facing with the lack of direct support professionals for our community. The services provided by local offices for the aging are predicated on ensuring individuals are able to age in place with autonomy, dignity, self-direction, and respect. Our home care services are part of Medicaid prevention, which is something that hasn't been talked about at length today that I think is very important. We provide home care services for individuals that do not qualify for Medicaid but don't make enough money to actually privately pay for those services, so we're able to provide personal care level 1 and personal care level 2 services for anyone over the age of 60 that qualifies for our programs and services. This distinction is important as our services have been proven to prevent future Medicaid costs, which is what a lot of us have been talking about for years. And we also include a significant cost share to the state as far as what skilled nursing facility placement costs for nursing home residents, and the state share of New York State Medicaid to that program. Our average client is actually an 83-year-old female who lives alone, who has substantial limitations taking care of activities of daily living, such as bathing, toileting, dressing, meal preparation, grocery shopping, etc. The average client also has 4 or more chronic conditions, and they typically qualify for skilled nursing facility level care. Another alternative that we see in the community is some individuals who are forced to actually spend down to Medicaid or MLTC services in order to access them. And our network knows from our own client data that about 10% of people who are waiting for services through our network in New York State go directly to a skilled nursing facility without ever touching another level of care at a very high cost to the Medicaid system. An additional 6% are forced to spend down all of their resources to access MLTC plans in their community. We do know that the state savings to Medicaid just for this 10% equals about $70 million per year, and that the home care workforce crisis is impacting our network significantly across New York State. We utilize the same home care licensed agencies as Medicaid providers, and we're already at an unlevel playing field when we start for home care services, as our traditional authorizations are much lower than Medicaid, and we attempt to serve as many individuals as possible under a fixed budget structure. A lot of people have talked about the demographics of aging today. I think it's really important. New York State is actually 4th in the nation with the over 60 population. And as referenced earlier, census data has indicated that the fastest growing segment of that population is actually the 80 plus. And when you look at the overall growth projection through 2040, New York State's going to grow by about 1.3%, but the population over the age of 80 is going to see a 42% growth in that time period. We also know that about 70% of the older population will need some form of home care during their lifetime, and that these home care services prevent emergency department utilization and transitions to skilled nursing facility care. In addition to the explosion of the aging population, we're faced with a massive direct worker shortage. The number of home health aide and personal care jobs projected to rise from about 440,000 to over 700,000 by 2028. In addition to this need, home care agencies have to recruit an additional 70,000 aides just to replace those leaving the field each year. In a survey done in the fall of 2020, 85% of participating agencies indicated worsening staff shortages. This data is staggering when you take into account the growth in our aging population, the demand for workers, and the unbelievable shortages that we're seeing across the state. In an effort to focus data-informed metrics regarding the economic impact of the home care workforce crisis, we worked on 2 research projects, which I did provide in the written testimony. They have been cited today, the CUNY report and the Cornell report. I wanted to touch base very quickly on the Cornell University report from 2018 that looked at safety net programs that direct workers are dependent upon based on their annual salary of about $20,000 per year. The annual savings if workers are paid a living wage of $35,000 just in Medicaid and SNAP alone would be $665 million. In addition, the 2020 CUNY study looked at the economic spillover of increasing direct worker wages in 2 target areas. So we looked at different benchmarks. Target 1 was to raise workers in New York City to $40,000, $35,000 for Long Island and Westchester, and $30,000 for the rest of the state. Again, this was referenced earlier. The cost to implement these wage increases would be $4 billion, but the economic turnaround benefit is $7.6 billion in return. Target 2 of the study took this a step farther, which I wholeheartedly agree with. They looked at $50,000 for New York City, $45,000 for Long Island and Westchester, and $40,000 for the rest of the state. Cost is $6.3 billion, but when you look at the economic benefit, we're over $12.9 billion in return. So you're looking at a net gain between 3.7 and 6.6 billion. I also wanted to just mention, Senator May, that we have about 4.1 million unpaid caregivers in New York State. Their economic value is worth $32 billion. The economics of this issue are extremely important. However, numbers do not take into account the human and emotional toll that a lack of workforce causes. This is one issue that all service providers, regardless of payer source or population base, are in agreement on. The disability and aging communities are both dealing with an overwhelming lack of direct support professionals that leave us paralyzed to help those we are tasked with advocating for. These workers are caring for our friends and loved ones and are responsible for assisting with the most intimate personal care needs. They have to be passionate about their work, extremely caring and extremely patient, and for far too long this workforce has been marginalized and underpaid. They are heroes and need to be paid a living wage to ensure we are able to care for our most vulnerable populations with compassion.
Okay, I'm going to ask you to wrap up.
It's wonderful to see that our minimum wage has increased in both the public and private sector. Everyone deserves a living wage. However, I find it troubling that I paid more to wash my car this morning than a direct worker is paid for an hour of their time. Now is time to do something about this issue. Thank you very much.
And Tara.
Thank you. And good afternoon. Thank you so much for hosting this hearing. My name is Tara Klein. I am a senior policy analyst with United Neighborhood Houses, UNH. We are a policy and social change organization that represents 44 neighborhood settlement houses across New York. My testimony will focus on the economic crisis facing nonprofit home care providers due to state funding and policies that perpetuate near poverty wages and unfairly pit home care workers and employers against one another. 3 UNH member organizations provide nonprofit home care services to their communities as state-licensed home care services agencies, including CPC, and I will echo a lot of what Carlin shared in their testimony, as well as St. Nick's Alliance and Sunnyside Community Services. Together, every year, these settlement houses provide services to over 4,500 individuals and nearly 7,500 workers throughout New York. While the home care industry is comprised of both for-profit and nonprofit home care agencies, these community-based organizations serve distinct roles. Embedded in settlement houses, these organizations serve their neighborhoods with culturally competent care and offer many important wraparound services and programs beyond home care, including early childhood education, youth development programs, adult literacy classes, senior centers, and more. New York's home care industry is at a crisis point. The number of older adults is growing, while demand for home care is increasing as it's a preferred method of care. Meanwhile, there's a looming workforce shortage due to a systematically underpaid workforce comprised largely of women of color and immigrants. These poor wages are predominantly due to state policies, including low Medicaid and MLTC reimbursement rates, a 1% cut to the sector last year as part of the MRT2 process, as well as the Department of Labor's 13-hour rule of 13 hours of pay for a 24-hour shift. Nonprofit home care providers in particular are stymied by these policies, unable to pay the fair wages they know their workers deserve due to a lack of funds. I want to share a couple of recommendations that UNH offers to stabilize and strengthen the sector while ensuring nonprofit providers are able to remain financially viable. These recommendations are all going to require some financial investment, but it's the state's responsibility to do this, and they really need to step up to the plate here. So first, we need to eliminate the Medicaid global spending cap. Any significant home care pay reform is going to require additional funding and Medicaid support. This can't happen without eliminating the global cap. Next, UNH supports the Fair Pay for Home Care bill sponsored by Senator May, which we've heard about today. This would ensure that home care workers are paid uniform and fair wages across the state. Really critically, this bill includes a funding mechanism by establishing a fund and subsidizing Medicaid payment rates when necessary. This will ensure that pay rates are funded through reimbursement rates and do not unfairly fall on the providers. UNH also supports the split shifts bill, which we've been talking about by Senator Persaud and Assemblymember Epstein. which would cap home care worker shifts at 12 hours in most cases. This would really help rectify the problems with the 13-hour rule by capping the number of hours an employer can require a worker to work at 12 hours, cumulatively 50 hours per week. This would massively reduce, if not totally eliminate, the number of 24-hour shifts. We need to end the 13-hour rule and fully fund 24-hour care. While we believe that 24-hour shifts should be the rare exception and not the norm, and absolutely never forced, home care workers simply should be paid for every hour they work. It's very simple. This is going to require the Department of Labor ending the 13-hour rule so Medicaid and MLTCs can legally reimburse for all 24 hours in a 24-hour shift. The state must also increase Medicaid funding and reimbursement rates to cover the full and actual hours worked, including potential overtime hours, and this needs to be done through the budget. Next, there is a need for the state to do better data collection and evaluation. We also believe there's a role for industry-wide oversight that can be looked at, including a short-term task force and possibly a permanent oversight office or position. And then finally, a little off course here, but I wanted to mention that homebound older adults and people with disabilities require a continuum of services and interventions to live healthy and meaningful lives. Many people who receive home care services also at some point rely on local home-delivered meals programs to combat food insecurity and receive additional supports. But unfortunately, the state's home-delivered meals programs are systematically underfunded, leaving the workforce in a similar position as the home care workforce, with nonprofit employers unable to pay fair wages or maintain stable programs due to unjust government budgeting and policy decisions. And so we wanted to thank the legislature for including $8 million in this year's budget to address some of the unmet needs for home-delivered meals and other services. But advocates estimate that the full unmet needs this year was closer to $27 million. And so we hope moving forward, the state will make a serious investment into this workforce, as well as the home care workforce. So thank you very much.
Great, thank you all so much. I don't want to take a lot of time, but I do want to ask Becky something about, it's kind of a follow-up to what Tara was saying. So home-delivered meals, for example, are seemingly a pretty simple intervention that can keep some people in their homes, right? It could be just that, or one or two services like that, that if they could just get access to them, then the savings, just speaking economically, the savings to Medicaid would be enormous because they wouldn't end up having to go into institutional care. So what happens when an older adult, say, needs one or two of those services and can't get them?
So what we have seen, especially throughout COVID, is essentially a 70 to a 90% increase in the demand for aging services. So that's something that we were able to turn on with some federal dollars, as well as the additional state investment. What I can tell you as far as access to very basic services, so in many instances, a discharge plan from an acute care facility may require a daily check-in. Well, that's your home-delivered meal program. Could we also put it in a personal response system? Very, very low budget items, correct? But what happens is when you essentially have that client and you can't turn the service on, you then stopped the safe discharge plan for minuscule dollars per day. When we talk about the home care lens, what we have really struggled with across the network is, we really try and prevent spend down to Medicaid, because Medicaid obviously has a place, but it's very expensive, and we can support our customer who qualifies for skilled nursing facility placement between $6,000 and $9,000 per year on aggregate. The problem that we're running into, especially with licensed home care agencies, is there's been a lot of conversation about the direct workers themselves, but a lot of these licensed home care agencies are nearing bankruptcy and they can't, hardly make payroll. And so what they're telling us, this actually just happened in Ontario County this morning, they are no longer taking Office for the Aging authorized cases. They're only taking Medicaid cases with extended authorization periods. So it puts the aging network, who's predicated on saving Medicaid dollars in the long term, at a huge disadvantage, because now we don't even have access to the same number of home care workers. And so that's something, we're really working closely together as advocates. I think this is probably the first time we've had a consolidated disability, aging, payer source conversation, because we're all saying the same thing, is that this is a massive issue And, you know, I know many of us were here back in 2016 when we had 2 hearings, one in Albany, one in New York City, that went well over 10 hours talking about the exact same issue, which is we don't have a robust workforce. The New York Times said in 1987 we were headed to a crisis. We're now in 2021, we're at a crisis, and we really need to facilitate some type of change, not only because of the economic cost, but because of the human cost to these individuals who are told you're authorized for this service, but we're sorry we can't serve you. It's just unjust for the community.
Well, thank you. I have to say, I joined the Health Committee this year, and one of the shocking things was to learn that there really are 2 health budgets when we do. There's the budget that is the public health budget, that is all the preventive side of things, and then there's the Medicaid budget, and we don't get to do cross accounting. So if you invest more in prevention, you're going to save way more than that on the Medicaid budget. Doesn't matter. We can't make that argument. So we have to figure out how to do the smart budgeting.
Well, and I do like to highlight the fact that if you look from an economic standpoint, and my colleague Alana raised this, we've all become economists, right? Because how else do you talk about this issue to get some teeth behind it? And the economic lens is really something that has gained attention. And, you know, when we worked with CUNY on the CUNY report, it is startling data that you're going to double your money in the billions by an investment. To me, it seems like stop being reactive to these issues and losing nursing home beds and licensed home care agencies going bankrupt. Why not do the investment on the front end to gain long-term gains, which is exactly what I know you support as well as your colleagues. So thank you.
Can I add to that as well? So CPC, the Social Services Agency, has a home delivered meals program for seniors that we've done for years. And it's been chronically underfunded by the city and state for years, to the extent that our senior services director calls it Meals on Heels, because we cannot actually get the funding to repair the trucks that we would theoretically deliver Meals on Wheels in. And there have been seniors on the wait list for those services for years. And during the pandemic, we were immediately flooded with calls from, hundreds and thousands of seniors that needed delivery, and there was no funding for it. And CPC and other nonprofits found donations. We had all of our staff running around all 5 boroughs delivering meals to people. Money that will never get reimbursed by the city or by the state. And nonprofits have been doing that for years and years, but during the pandemic, it grew to a whole nother level. So when we talk about the cost of underfunding, you're not even talking about how much the state is actually underfunding the program, because you're not even considering all of the work that nonprofits are doing that will never get reimbursed. And we have so many seniors that are on the wait list for services, whether it's for meals, whether it is for home care or more, and it's literally someone's life on pause. And we do, thousands of welfare calls every week to our community members, and we know that if we lose touch with someone because they weren't able to pay their phone bill or whatever else, that they might not be getting the services they need, and it's literally someone's life on the line. And
yeah.
That's not even taken into account when we talk about how much it's underfunded.
Right, and I can just quickly add that in New York City, we've analyzed that home delivered meals programs are reimbursed by the city about 20% less than their actual cost of doing business. So programs are actually losing money on this and on these programs. In some cases, it's hundreds of thousands of dollars. And I think, as Carlin just mentioned, during COVID, this got much worse, even with the Get Food program in New York City. And so this is really a long-standing problem that is bubbling up and getting worse right now during COVID as more people are experiencing food insecurity. And so we really need to make those investments now.
Okay. Well, thank you. Thank you all for the work you do. Anybody else weigh in?
I'll just make one quick comment. Thank you for being here. I think all of you underlined something very basic, which is that it's been said 1,000 times, but I guess it needs to be said one more time. In this state, unfortunately, and it has to do with the executive, let's call it what it is, we have been consistently penny wise and pound foolish. The idea that there is so much money that we could be saving if we actually invested, that money up front is not an expense, it is investment, an investment in things like funding the workforce to the right way, funding those service providers who are actually doing the work. That will actually, investing in a program like providing meals to seniors, et cetera, all of these things are not expenses. They're all investments that will get us better communities, better quality of life in those communities. And if we only had somebody that thought a little more long-term and not just about the budget right this second, we'd actually be in a better place. Would that be accurate to say? Okay. I said it, sir.
You said it.
Hi. You're
Don't
watching,
make them
so
say it.
hi. Thank you, Madam Chair.
Okay, yeah, thank you. Thank you all. And-
Thank you.
And as I keep saying, thank you for the good work you do, too. So we have 5 more panels to go and about 18 more people. I want to urge folks, I value what you have to say, but if you can, not repeat things that have been said before and really focus us on what new you have to contribute, that would be really helpful, and I will try to keep my questions to a minimum, too. So our next panel is Claire Prendergast, Melissa Wendland, and Jean Moore. Thanks, Senator.
At this point, there's only 2 of us, so.
Yeah. Why don't you just get started, Claire?
Sure. Is this on?
Yep.
Yes, it is.
Oh, wonderful. Hi, Claire. It's good to see you. Thank you for today's conversation. As you mentioned earlier, this is overarching with long-term care and home care, and that's exactly what we're looking at in Rochester and the Finger Lakes region. Thank you for your visit a couple of years ago as we were talking about the healthcare workforce and what we were looking at in terms of home care. I'm Melissa Wendland. I'm the Director of Strategic Initiatives at Common Ground Health, formerly Finger Lakes Health Systems Agency. We are a health research and planning organization that has served the 9-county Finger Lakes region for over 40 years. We work to collaborate with leaders in healthcare, insurance, government, business, consumers, and look at the region's most pressing health challenges. Analysis of quantitative and qualitative data is the core of our work and foundational to driving a fact-based understanding of issues that foster our planning and programs. We track trends, raise awareness to the health inequities of our region faced by marginalized communities in rural, suburban, and urban areas. This includes our growing aging population and those that serve this population. 10 years ago, in 2011, Common Ground Health, then Finger Lakes Health Systems Agency, convened the SAGE Commission to develop a comprehensive long-range plan for aging health services in the Finger Lakes. Central to that plan at the time were objectives at creating person-centered care that accommodated those 65 and older, taking into consideration their preferences to live in the least restrictive setting, delay institutional care, and allow older adults to remain in the community as long as possible. We worked with partners developing an interactive modeling tool that looked at the economics of what would be required in 2030. 10 years into it, we're looking at what we've done that's worked well, what's been successful, what's changed in the community, and what we need to focus on moving forward. You have my report. We've talked a lot about earlier testimony, looking at the multiple challenges that we're facing. The key for us was 10 years ago, we underestimated the severity of the impact of our growing population, the decline in available family caregivers, the fragmented and unsustainable methods to pay for our care, the workforce shortage, and the healthcare disparities that exist among our elders. The number and percentage of people of color in the older population is increasing even faster, and serious healthcare disparities exist among our Black and brown communities. The city of Rochester has a 36% increase in its older adult population over the past decade. It's the highest rate of increase of any major city in New York State, with the highest poverty rate of any city at 31%, and the number of older adults in poverty in Rochester has increased by 38%. Poverty among older adults is rarely discussed, And the impact to the community is magnified as these seniors are often caregivers for multi-generational families. This is significant right now for us, particularly given what has happened as a result of COVID. There's been strides that have been made and recognized by the state from our first report in 2011. But we have a long way to go, a long way to go. And we'd like to take this opportunity to say a crisis is a terrible thing to waste. We love the opportunity to come together and partner with you. I thank you for sharing and reading the report. There's two things that I want to walk away with today. The highest demand in healthcare in our Finger Lakes region is home health aides. It is essential for fair pay and competitive wages for these essential workers. The continuation of the decade-long struggle to fill direct care positions and stabilize our essential workforce needs to improve. I'd also like to say that we recognize long-term care costs are unsustainable for governments, and the vast majority of people lack the resources to privately pay. We have recommendations of what to do, and that's included in my report. Finally, I'd like to say long-term care needs to be a person-centered, coordinated, and seamless across all various care delivery sites with a focus on supporting those that we are serving in our most vulnerable populations. Thank you.
Thank you. And Claire.
Hello. Senator May, Senator Rivera, it's such an honor to be here. Thank you for the opportunity to testify. My name is Claire Pendergrast. I'm a PhD student in sociology at Syracuse University. I'm also a graduate fellow for the Lerner Center for Public Health Promotion. My research focuses on the Aging Network, which, as Ms. Prevey just described, is a comprehensive network of service providers that aim to keep older adults in their homes and communities as long as possible. And often that is something like a home-delivered meal or a home repair that can enable someone to be more mobile around their house rather than having a fall that could end them up in the hospital or a nursing home. And so in my remarks today, I will summarize my recent research on the value of community-based services for older New Yorkers, their families and their communities, and public budgets. Per request to skip redundant things, I will not tell you about exactly how much the population is aging. I will say it is aging faster in rural areas, and that that's an important conversation because when a larger share of the population is older and also the working age population is declining, folks moving away for work opportunities or education, there's often a growing care gap where family members who would love to support their relatives simply are not there. And similarly, as we see demographic trends, there is a growing care gap amongst the population as a whole because folks having fewer children means the ratio of potential caregivers to folks in need of care is just untenable, and that requires us to acknowledge the unpaid care that family members have been providing for so long, and that will fall onto formal services. And so community-based services address a continuum of care needs, and I think that's really important because for many folks it is in-home care that is on a daily basis, but for others a very small investment that can provide these supports can keep someone from having this precipitating health crisis or requiring institutionalization, which can also reduce strain on family caregivers who often are doing a lot of work but simply can't shoulder it all by themselves. And research also supports that that is skillful and emotional labor, particularly navigating dynamics with family members who are there, encouraging folks to accept services they might be initially averse to accepting because it acknowledges a lack of independence, and that's challenging. So the interviews I've done, I've just been pretty struck by the trust that is built from kind of an objective source of information who can recommend the appropriate care and kind of guide people through that process. Or I did an interview with someone who had a client with a raccoon that was coming up through her trailer and she needed a repair, and the process of getting her to the appropriate repair agency was a whole ordeal, and she was patient and kind and felt as though her support with that solved a problem that otherwise never would have been solved and could have been a precipitating health crisis. And per previous conversations, several studies have shown that there is definitive Medicaid savings from investments in the Older Americans Act home-delivered meals specifically, and also in home care. A Brown University study found that Title III, which includes meals, spending on Title III programs saved $109 million in the Medicaid budget, and that's probably increased since that study was done, by keeping low care need folks out of nursing homes. And it is also really important, as we have heard a lot, that investing in the home care workforce is critical to keeping folks in their homes and communities. That's especially important in rural areas. Per previous conversations, that family members might be less available there, but also there are fewer working age folks to hold those jobs. Also in my interviews, I've heard that given the low wages home care makers receive, they often can't maintain vehicles in the way that they would like to. There are long travel times between clients. Folks mentioned care workers not being paid for their travel time. And so all of these add up to what is already a crisis, and I think that a holistic policy solution is needed, but specific attention to the needs of rural communities is really important. In summary, New York State's population is aging, and so this increasing demand means we need more home care workers and just more community-based services, and investing in those proactively is critical. They have been underfunded, and that is a real cost just to people's everyday lives, their families who will pick up those care needs when they possibly can, and that is a cost to family members, as COVID has shown us. And thank you for the opportunity to participate in your deliberations on this important topic.
Great. Thank you both. Any questions? Okay.
Thank you.
I appreciate your
Thank you.
waiting till this point in the day to do your testimony and being timely about it. Are you Jean? Is Jean Moore here? No. Then we'll go on to panel 6, Brian O'Malley, Tanya Anderson, and Heidi Siegfried. Just jump right in, Brian, when you're ready.
Hi. Good afternoon. It's a pleasure to see you all in person, finally. Brian O'Malley with the Consumer Directed Personal Assistance Association of New York State, a statewide association working to improve access to and the quality of the state's Consumer Directed Personal Assistance Program. I want to thank you for having these hearings. They are an important continuation of the Senate's critical leadership on this issue. And, you know, New York's status as the epicenter of a national home care workforce crisis is well documented, and the real world impact of that is readily apparent. The full scope's been detailed by others, and I'll only reinforce one point, that in many counties, there's no longer even a pretense that Medicaid recipients have a choice of their home care services. People are referred only to consumer-directed personal assistance, whether they want that or not, whether they're a good fit for that or not, and home care just is not an option in the traditional personal care side. We obviously support consumer-directed, but it is not for everyone, and we think people should get the services they want and need. Federal dollars are critical to this conversation, but they're not the only part of the conversation. Unfortunately, we saw that with DOH's recent application to CMS on how it proposes to spend the previously increased federal funds under ARPA. These funds demonstrate that they're not merely aware of this problem, it is likely an intentional barrier that's been put in place to artificially limit the growth of these services. Indeed, the DOH argued that they should be allowed to use $415 million of this funding to pay for the, quote, natural growth of CDPA and personal care because, and I quote, while the growth rate of these programs has remained high, structural factors such as workforce capacity limitations have served to limit that growth. However, by permitting New York to address many of these structural factors and promote the capacity and accessibility of HCPS, funding under ARPA will work to create natural growth in PCS and CDPAS based on pertinent minimum needs criteria. In other words, people who are otherwise eligible will actually be able to get the services they're eligible for. These structural barriers were recently made worse by the increase in the fast food minimum wage outside of New York City. In anticipation of the July 1 increase upstate, C.D. Penney surveyed consumers and published an issue brief detailing its impact, as well as the impact of various potential solutions. What we learned was that nearly 90% of workers upstate earn less than the fast food minimum wage, with 2 out of 3 earning the standard minimum wage, totaling $2.50 per hour less. 70% of consumers cited low wages as the reason that their PAs quit, and almost half of the PAs in the region have warned their consumers that they plan to leave in the near future, specifically for higher paying jobs in fast food. These low wages are the result of an overall disinvestment in home care that's seen Medicaid reimbursement rates stagnate for over a decade. Fee-for-service reimburses below cost, while managed care plans operate with little accountability or transparency and routinely cut rates to unsustainable levels, insisting that agencies pay minimum wage and failing to pay for basic legal requirements such as overtime or wage parity. Additionally, within CDPA, the per member per month reimbursement rate, implemented with no distinction between the inherent cost differences on where in the state an FI is operating, has meant agencies are forced to further cut wages. And to be clear, this was the goal. In fact, the purpose of all of this disinvestment has been to force down wages and create structural factors that limit natural growth, and it has worked exceedingly well. Fixing this requires a bold investment in the entire home care system. Fair pay for home care accomplishes this. Others have detailed the specifics of the legislation, but the establishment of a minimum home care wage of $22.50 per hour is critical. Our recent issue brief identified that 90% of consumers upstate and 80% of those in Long Island and Westchester said that an increase in wages would be more effective at helping them recruit and retain PAs than increases in benefits or the provision of transportation or training, other policy ideas currently being discussed. Fair pay for home care is also important because it invests in the entire home care system, for the first time ensuring that the wage increases are fully funded by both DOH and managed care plans, using data already filed by providers to create a minimum rate of reimbursement based on an average of actual costs in a region. Okay. It also funds other expenses incurred by the providers, but I will wrap it up.
Okay, thank you.
It's not green.
There you go. There you go.
Oh, it doesn't change color. Okay. Hi. Good afternoon. I'm Heidi Siegfried. I'm the Health Policy Director at Center for Independence of the Disabled in New York. And our goal is to ensure full integration, independence, and equal opportunity for all people with disabilities by removing barriers to full participation in the community. And so while our mission is to help people access the care and services they need to live independently in the community, and our Open Doors program specifically gets people out of nursing facilities, we also advocate for elderly and disabled people in nursing homes, assisted living, and other residential settings to ensure their rights to quality of care, quality of life, and dignity. So, because you're not going to find many independent living centers that are going to advocate for long-term care, but our main mission is still the home care workforce, so that's what I'll try to talk about first. Yesterday, we marked the 31st anniversary of the signing of the Americans with Disabilities Act, and that's our civil rights statute that gives us the right to participate and benefit from all aspects of society to the same extent as our non-disabled peers. And of course, the landmark Supreme Court decision, Olmstead versus LC, written by Ruth Bader Ginsburg, further requires that care be delivered in the most integrated setting in the community, which New York has really been struggling to meet its obligations under most integrated setting. People with disabilities need access to a readily available and robust home care workforce in order to exercise these rights. And unfortunately, we've had to exercise these rights in an environment of increasing austerity, going on for decades, actually, caused by tax cuts for the wealthy. So 10 years ago, we began dealing with the global spending cap in the Medicaid program,
and also dual eligibles that needed long-term care were required to enroll in managed long-term care companies. And they, that's really been what has driven sort of the lack of access to home care. I mean, it is also the workforce, but it's also the managed long-term care companies that are denying adequate hours of care, and that's the care that's needed to avoid institutionalization. So the thing is, though, when you do the appeal and you get your right to care and you get the hours authorized, the question becomes then, how do you fill those hours? So it's still a problem. It's a problem that has spread from upstate down to New York City, and it has, you know, real consequences. Now, we've had a couple, in the past few years, we've had a couple of different stakeholder groups. We had one in New York City, we had one in New York State, plenty of meetings down in meeting room 6 and all over the place. And all the stakeholders were there, but they were still operating within that box of austerity, no additional money, you know, and all the recommendations always had to be sort of around the edges. And that's what we're still seeing for recommendations, right? So, I mean, we really feel that there has to be this investment. Sydney really did join the Fair Pay for Home Care campaign this year in a big way. And I'm glad that Brian mentioned about the American Rescue Plan, because we finally, you know, we've been saying all year in our spring meetings, you know, watch this, how they plan to spend this billions of dollars coming into New York State, because we saw with the Community First Choice option money that we, disability community, fought for that money, that we never were able to find out whether or not that was spent correctly. And New York drew that money down, and you know, we don't know what happened to it. So Brian mentioned one of the problems. We've also seen the other problem that we just exploded over was that giving $55 million to nursing homes to supposedly train workers to recognize clinical improvements to allow discharge. That is not a criteria for getting out of a nursing home, clinical improvement. And it just shows that the Department of Health does not really understand this issue. So they did say that in giving out this money, you know, hundreds of millions of dollars to managed care companies to do these little around the edges things, that they would have some kind of criteria, some kind of quality measurement for them to be able to access these dollars. And people with disabilities should be included in that quality measurement piece so that, you know, they really know what they're doing and, you know, that they're measuring the right things before the money is distributed. So that's, I mean, I really haven't gotten to the nursing home care, but I will say, you know, we also are concerned about the dumbing down of the safe staffing bill, which we worked on this year. And, you know, we're monitoring what's going to happen with the requirement to pay 70% of your dollars on direct care and 70%, the 70-40 that they're being, we're going to have to monitor that. And the final thing is that the Public Health and Health Planning Council approves when these nursing homes, nursing facilities change ownership, merge, close, whatever. And I go to those meetings, and there are very few consumer reps on that body. It's mostly industry dominated.
I need you to wrap up.
But it should. I mean, that is a place where we could oversee these nursing facilities, and they are now sending to the long-term care ombuds program when these nursing facilities file. So it'll be interesting to see what happens with that, because that'll be an opportunity to, you know, follow
I need to
it up.
cut you off. Thank you, though, Tanya.
Hello. I got the trick microphone, but nice to see you. Thank you. Thank you for having these very important hearings. My name is Tanya Anderson. I'm the CEO of Arise. We're the independent living for Central New York. And we, since 1979, have served more than 7,000 people annually of any age and any disability. At Arise, we actively work to transition people out of institutional settings or give them the supports that they need to stay in the community. And we save the New York State at least $1.5 million annually. Collectively, our ILC network saves New York $125 million each year. Even during the pandemic, Arise's Open Doors Transition Center was able to bring 48 people out of nursing homes in 2020. Much of the focus on this hearing has been on the dedicated workers providing assistance with respect to medical needs and activities of daily living, and that crisis is certainly in those areas. I want us to be mindful that the crisis of care also extends to staff who are supporting individuals with developmental disabilities to have access to their community. The work of Arise really depends on direct support professionals. And let me join in the chorus of voices that are saying that increased pay for this work is absolutely necessary. I want to give you some examples about how this crisis is impacting the programs at Arise. We're one of the founding providers of the CDPAP program, and we are the fiscal intermediary for about 300 consumers. And when these workers disappear, there's a crisis. For example, we've had a consumer in our CDPAP program. He was approved for 80 hours of support. When COVID hit, 2 of his 3 staff left because they could make more on unemployment. So he was left with 1 staff person and 40 hours a week. Couldn't get the care. Arise tried to find staff and failed. He went to another fiscal intermediary, tried to find staff and failed. This man was actually, during the transition, left without any services for a period of nearly a week. He had a health crisis, ended up in the hospital, then transitioned to a nursing home, and that's where he still is. That's one tragedy of many during this crisis. And we currently have 30 people that are approved for hours and are not receiving any services because we cannot find the staff. We've tried direct hiring, we've tried bonuses, we've tried referral programs. Providers are competing against each other for a pool that isn't there. At least twice a month, we get referrals from managed care companies offering us 30 to 40 consumers if we can find the staff, because they cannot find the staff. Arise also operates the Regional Resource Development Center across 8 counties, and this program serves 400 people and has a network of 50 providers on the traumatic brain injury and nursing home transition and diversion waivers. This program also is designed to keep people with adequate supports in their community, and this program also is struggling to staff the cases. There are at least 2 folks in this program that have gone to nursing homes because we couldn't find the staff. Families are filling in the gaps at their own personal expense to their careers and their lives. It's just not sustainable. We've got staff that have been in this program from the beginning, and they say this is clearly the worst it's ever been, and what they're hearing universally is the lack of pay. We have programs that support people one-to-one in the community with developmental disabilities, and we have 120 people who are qualified to receive services that we cannot find the staff. That's 42% of the people that we serve in this program. And these are people that are sitting at home rather than working or accessing the library or shopping or gaining the independent living skills that they need with a little support. And these are not high-cost cases at all. These are people that maybe have as few as 1 to 4 hours a week of direct support professional care. One of those people is actually my daughter, who has a developmental disability, and I can tell you firsthand the struggle in terms of finding direct support professionals to support her, but more importantly, I can tell you about the very critical work that these people do. You've heard very compelling testimony from the workers themselves. They are not in this for the money, they're in this because they care very deeply. This is highly skilled work, and our society is not recognizing it as such. And I also want to touch on the impact on Arise as an employer. 450 of our staff are direct care professionals, and our turnover rate is 30%. At a cost of onboarding staff between $4,000 and $6,000 apiece, the churn is costing us at least $675,000 a year in an industry where there is absolutely no margin. I urge you to continue to consider this issue carefully, as I know you have, and thank you very much for your time.
Thank you, Tanya. Thanks for coming to Albany to share that, and all of you, thank you so much. I don't have a question. Okay.
Thank you.
Thank you so much. Panel 7, Jean Chirico, Caitlin Andrews, Kathy Fiberaio, and Al Cardillo. Thank you. Someone you know. Want to just get started?
It's only 3?
Something I
We can
said?
move on. Mike.
Yes, thank you for this opportunity, Chair May and Chair Rivera. Thank you, Senator Serino, for being here.
My name is Jean Chirico, and I am the CEO and president of the Hospice and Palliative Care Association of New York State. And I understand the crisis of time that we're in. So I'm just going to share a little bit off the cuff. I'm not going to read my remarks to you because prior to accepting the role as president of this hospice association, I spent the last 25 years, almost 30, in the healthcare arena in various leadership positions. So I feel quite confident in my ability to talk to you regarding the needs of the workforce. I ran a licensed agency for 15 years. I was a hospice administrator for 15 years. I also ran part of the Certified Home Health Agency. So I understand all the regulations that fall under the Department of Health line of business. And I sincerely love the people that worked with me. When I first started, I had 500 aides under my licensed agency, and by the time I was finished in my role there, we were down to just about 200 aides. And I feel like we were very progressive. We're in the Finger Lakes region. I was a part of the SAGE Commission that Melissa spoke of. I met with you, Senator May, when you came to Rochester. We offered health insurance, retirement, tuition assistance. We offered personal days, vacation. We kept up with the minimum wage and went faster than we were required to within upstate New York. We're at the max equal to the food workers. We did not want to risk that. And even with all that, we could not keep up with the workforce demands. And I think this is for a variety of reasons, and I believe you've touched on many of those already today. But I want to talk as somebody who was responsible for running the organization, and I have some very real fears about the Fair Pay Wage Act. And I believe in it, and I want to see it happen. But I also realize that if I were running the licensed agency right now, I'd be scared to death because of the compression factor that would happen for the rest of my employees when you raise that wage, and how would you make up that difference? It would have to come out of your bottom line, and there isn't one right now. As a hospice worker, I'd be scared to death because this is a Medicaid kind of Medicaid-supported initiative where the reimbursement would come out of the programs under Medicaid, where hospice serves 95% of its patients under Medicare, but you can't divest the two. If you're going to get a workforce, it doesn't matter whether it's a Medicaid patient or a Medicare patient, your aides need to receive the same amount of pay. And there is a lack of ability, and there is no reimbursement that's coming under Medicare right now. So because of these issues, amongst others, including what's been recently called the minimum wage paradox, where increasing the minimum wage, as you stated earlier, may result in the state saving money because for about 40% of the aid workforce is receiving benefits through the state for child care, food stamps, housing. Those benefits may go away or be greatly reduced. And in the end, what is the actual benefit to the worker? How much money do they then have to put out for child care and for other supports? And so what I'm suggesting in my proposal is that we do that plus that there's some minimum wage efforts that happen, but there's a bigger effort that creates a center, a workforce center, where all of us can come together with these great ideas and be able to work it out so that implementation doesn't devastate, it doesn't harm, it actually helps. Because what if the recommendations that came out of this center could include things like essential workers get a waive on the income limits that are associated with the benefits that they're receiving from the state. Instead of trying to make up the money, add the money to that. So I see an opportunity for all of us, including the interfaith communities, the CBOs, the community-based organizations that were talked about so eloquently, the associations, the Department of Health, OHIP, who covers the managed long-term care programs and these things, all to be a part of this center of excellence for workforce in the community. So I know that I'm at my time limit already, and I appreciate that. I would love to be a part, our association and our members would love to be a part of a discussion that helps address some of these gaps that are there.
Thank you.
Good evening. No. Hello? Okay. Thank you for convening this event. I greatly appreciate the topic being addressed. I am Kathy Fabreo. I am the president and CEO of the New York State Association of Healthcare Providers, and we represent the spectrum of home care providers across New York State. I would like to say first and foremost that our home care agencies are very proud of the work that they've been able to do to keep people safely at home, particularly during this pandemic, with little to no additional support. Some of the stories that were mentioned earlier today are very disturbing and quite egregious. And I want to point out that the vast majority of home care agencies are doing the good work, and that by doing so are actually in a very difficult financial position as they comply with labor laws, et cetera. But we also have a once-in-a-generation opportunity to make significant improvements to the state's home care system with Washington's investment in FMAP of $1.6 billion in New York State. We would like to recommend flexibility in the use of those funds to meet the unique needs of home care providers and their workers across the state. We recommend that funds be directed or a direct payment mechanism be set up to ensure that the maximum amount of funds are made available to workers. Senator May, earlier you mentioned that you have heard that agencies are retaining funds and not getting them to the workers. We see a different story, and we don't see the funds get to the agencies. But some of the examples we would like to see for those home care agencies to use with that flexibility is to potentially pay workers a bonus for time spent in initial training, paying hazard pay bonuses to aides, or paying retention bonuses to those that have longevity and made a commitment to the agency. And we would also recommend that investments in proven strategies like HCP's creating a legacy of care mentorship program be allowed for use of these funds. I'm very aware that many of you have made recommendations for DOH to use this additional funding to increase wages for the home care workforce. And we strongly agree that increasing pay for home care workers is of the utmost importance. But I will agree with Jeannie that there are other effects that this could have that we have to be aware of. We have to make sure that the employers, the providers, are kept whole and not expected to dig into their own pockets to pay the other pieces of the wage component, the unemployment insurance, FUTA, the list goes on, and unfunded mandates where we have to provide training, orientation, health assessments, in-services that are all paid for through this hourly wage that they contract with the MLTCs and the managed care organizations. And the safety net situation Jeannie brought up is critical. We don't want to push people into a position where they are cutting their hours in order to secure their safety net benefits, and that only increases the number of aides that are going to be needed in this system. A little bit about our mentorship pilot program that we would like to see leveraged is we created a peer-to-peer program where experienced caregivers were acting as mentors to newly hired individuals for their first 90 days of employment. And for their services in that program, they were paid a weekly stipend and given additional recognition at the agency as a leader within their agency. So it was a career ladder step for those individuals. And what we learned through that program was that turnover rates at the agencies with this mentorship program experienced 170% lower turnover rate than 2 dozen agencies without a mentorship program. It really provides a connection to the workforce out in the field back to the agency. It connects them to someone who's been there, who's done that, and who can provide individual support and recommendations and care for that new hire. And we would really like to see more investment made in these programs. It was funded through one of the WIOs. Those WIOs are now gone, so we are seeking grant funding to continue the support. But we think it deserves more than that, and that we shouldn't have to go out and beg, borrow for funds and approve a program. So thank you.
Thank you.
Thank you very much, Senators. Thank you for holding this hearing today and inviting the Home Care Association of New York State testimony. I'm Al Cardillo. I'm the president and CEO of the association. I also want to, really start out by really thanking you for the work that you've been doing the last number of years in support of this field. This field really has needed a champion, and you're all really working extensively to try to champion these causes. They are very complex causes, and I think from the testimony that you've heard today, it's been really clear all of the various factors that really go into producing the challenges that exist in our workforce. Now, in my testimony, I presented you with some statistics. I presented you with lots of recommendations for how we might go forward. And I would like to just frame that in a couple of ways here in this opportunity here now. What we're hearing from providers across the state and professionals is that there has been a workforce shortage in home care probably since the 80s. I mean, I know I worked on a task force related to the home care shortage in 1986 and 87. So it's never really gone away. And one of the reasons is actually a good reason. It's because home care works. Home care has been worked in a state like New York into the fabric of the system where it's not just long-term care, although that's a big part of it. Home care provides post-surgical services, pre-op services, maternal and child health, major medical management, public health services, asthma screening. Really across the continuum of need, home care is providing services. It's aides, it's nurses, it's therapists, it's social workers, and case managers, and so on. So it's really a very extensive team. So because the system works so well, and because policies have really been created to try to divert patients from hospitals and nursing homes into home care, the demand is burgeoning, and it's a good demand. But there's been really a chronic understaffing of the system. This has gone on and on. In the pandemic, it's really reached emergency proportions. And no matter who I talk to in the state, and we've been speaking to providers and groups around the state for the last month, they describe this as an emergency. A provider told me today that he's had one recruit in 4 months walk into the office to seek training or to seek a potential position. And again, we know this really cuts across all of the different disciplines. In looking at the situation, our recommendations focus on the need for some immediate help, immediate relief. What kinds of things can we start doing now to make a difference? At the same time, we need to look at really a multi-tiered plan. Something that looks, clearly we've heard a lot about funding today, but there's issues of funding, issues of creating interest in entering this field from the beginning, pipelines from high school, from college, from professional schools, to be interested in coming into the field. Regulations and state programs, which ones are counterproductive to the workforce and counterproductive to the efficiency of the staff versus being supportive of that arrangement. What provisions do we have for technology and the support of technology for workers, for patients, and so on? So truly, it really cuts across the entire board in terms of a comprehensive plan. I also think, I know as you approach the hearing, you've looked at nursing homes, assisted living, home care, other. I think in the case of some of the responses, it would be really important to determine what kinds of responses are common across those fields that the legislature and government could support, so that we have more of a unified kind of a program to assist wherever that patient is, if they're in a nursing home or home. Because what we don't want to do is maybe pay them more in one setting, so now they can't get into the other setting because you don't have competitive salaries. So I think it's important to look across that, look at the training, look at the educational requirements, and then also look at the very unique aspects that relate to home care, assisted living, adult homes, nursing homes. And I think from that, I think a very good package of ideas and proposals can emanate. Some of the things that could be done right now, Senator Rivera, you have legislation and that would provide support for home health agencies that have not had a base year increase in 5 years and a trend factor increase in over 10, and Jean spoke to that issue. There's also the situation where, in the case of your legislation, Senator May, that is really looking at how do you increase the target amounts that we should be providing to workers so that they're working for a wage that really reflects the value of the care and the meaning of the care that they provide. Senator Serino, you've sponsored legislation that creates a multi-state agency task force to look at the marketplace and try to decide, well, what should the wage be set at to really help it make a difference? And how do we promote interest in this field across the state? These are things that are very, very much within our grasp now. I want to mention one other thing. It seems a little off topic, but it's not. Just this one last piece. You've heard a lot in the budget process about the request for offers, the RFO for licensed agencies and fiscal intermediaries. That RFO has not been released yet. That is going to create a calamity in the system if once that starts being implemented and licensed agencies start actually being cut out of the Medicaid program. We asked you if you would repeal the RFO, but at least table that and let there really be, I think, a more rational look at how to regulate the agency supply in the state so we don't undo the workforce and don't undo the patients. And the same with the FI. So I'll conclude.
Thank you. Yeah, and I will just respond about the wage compression that I can't remember. I think it's in the Investing in Care Act, but we really thought about that issue and how do you bring up those at the bottom without disadvantaging the next level workers and that sort of thing. So it's on our radar for sure, but I appreciate you bringing that forward.
Thank you.
Senator Serena? Go ahead.
I just wanted to add the disappointment in the Department of Health proposal from the recent determination of how they're going to use the home and community-based services money, that hospice was not even mentioned within that, and home care got a little wink and a nod of opportunity to apply for a grant under transportation. I understand that doesn't diminish the needs in all the other areas that were in there, but I'm just bringing it up as a lot of work left to be done on the other side. So.
Okay, thank you. Go ahead.
Oh, and thank you so much, Jean and Kathy and Al. Al, you're always a hero here with everything that you bring up. And Jean, what you said, like with hospice, how we've had, you had 500 people at first, and now you have 200. And I think that everyone here agrees that the wages and benefits must increase to attract and keep the workers. But like you said, we need to ensure that in trying to help one group, we're really not inadvertently hurting the New Yorkers who utilize these services, our seniors, our most vulnerable. And I really appreciate you reminding everyone of the need to proceed expeditiously, but in a way that we don't have inadvertent consequences. And I love what you said too, Jean, about the Center for Excellence for Workforce. You guys all have skin in the game. And really, to get something done, I think we really need to have a unified front and hear from everybody. Like we heard some stuff today, but to have these conversations and really delve down into it to see what we can do.
And I think it's unfair to ask the legislature to understand all the nuances and the implications that are in this workforce, and to have you be a part of conversations larger with all the other stakeholders would be amazing.
Be great. Thank you very much. Appreciate everything that you do.
Thank you all. All right, we're up to panel 8. Dana Arnaud, Honorable Christine Pellegrino, Faggy Horowitz, and Jim Hurley. start with Dana.
Okay. Thank you very much for the opportunity to sit before you and have this conversation that's been very, very long overdue. My name is Dana Arnone. I am a former home health aide who put herself through Suffolk Community College. I am a registered nurse for more than 30 years. I am a proud owner of Reliance Home Senior Services, which is a small LICSA with about 300 home health care employees, and we are proud members of 1199 Union. And I'm very happy Rhoda's here, and she's on my side. So, my history as a former nurse's aide gives me a unique perspective and understanding, as well as a great empathy for both the patients and the employees. I've devoted my entire career and my life to home health care and its total reform. I'm here in solidarity with the caring majority, and I stand with my employees in support of fair pay for home health caregivers. It is beyond frustrating that we are sitting here debating the concept of human infrastructure. It's unbelievable to me every time I hear that bus drivers may receive $23 to $26 an hour, your fast food workers receiving $15 an hour, and we have to beg for our aides and our workers who care for human lives to make at least a living wage. The pandemic has brought to light many issues that have been swept under the rug for years. The most important being that there's just not enough caregivers for the number of homebound patients. The need is growing exponentially, and it is only going to get worse unless extreme action is taken. It really is the perfect storm. A recent statewide survey of home health care agencies found that about 23 positions were left unfilled due to staff shortages, and as a result, agencies have been unable to accept nearly 30% of new cases. How are we, the agency, supposed to survive? And I just want to add, as I'm sitting listening to the testimony in my office, I'm having a conversation with the director of my office, and from today until this weekend, we are down 50 workers that we have to staff the cases, and we don't have them. So what's going to end up happening is we're going to end up calling our families that we care for, that they're going to have to step in and either take care of their patients or their loved ones, or go to work or abandon them. So we have this constant we sit there and talk to them every week, and we're begging them to stay with us and ride through the storm together. Once they hear that we can't staff their cases, a lot of families think that there's going to have more opportunity for workers on other agencies, and then they find out that it's the same situation across the board. So that's just as I'm texting back and forth, I'm listening to them, they're like panicking in the office. We sometimes stay there till 8, 9 o'clock at night trying to staff these cases for our families, and it's impossible. So let me just go back. So with the decrease of the employees, that we still have to care for our patients. Overtime in my office is up about 20%. It is unsustainable. So you're going to find more and more agencies, especially small LICSs like myself, they're going to be closing. The governor constantly references that we are New York tough, but we really should be New York cares. Mm-hmm. I find it completely unacceptable that across New York State, I'm going to cry, the elderly, disabled, and homebound are going without water, food, medication. They're not being dressed, bathed, and they lack basic human contact. People wonder why we have such a high rehospitalization rate among this population. They are not being cared for. I can attest that my agency is doing everything that we can to retain and attract home health aides. Reliance, my company, provided an extra $2 an hour to each aide as soon as we were granted the PPP funds. We participated in the 1199 Union's successful transportation pilot program, which they're still, my aides are talking about. We Uber aides to hard-to-staff outlying locations just to provide safe, consistent care to our families. We provide scholarships to PCA school for those interested but unable to afford the certification. I myself have gone so far to start a not-for-profit called All Things Home Care so that we can help other small agencies like myself and that are experiencing the same issues. We celebrated our home care workers every day when they were mostly forgotten and abandoned by the media. Home health care givers are essential to the most fragile, the elderly and the disabled. The homebound deserves to be in their home and deserve consistent care. We need to acknowledge that people matter, the patient as well as the caregiver. There's no one more essential than that worker who's caring for you in your home. We believe that there needs to be fair pay for differentials on Sundays and holidays because these are the most nearly impossible times to staff, and the burden falls upon the agency. We believe that nursing students should be rotated through home care. As we at Reliance, we took it upon ourselves. We have developed a syllabus. We presented to Farmingdale State College, and we are ecstatic to say that nursing students will be starting their clinical rotation through Reliance Home Care this fall. In addition, we feel that it's valuable
I have to ask you to wrap up, Dana.
What? Wrap it up? Oh, okay. In addition, we feel that it's valuable that, this is actually really important, just my last point, that there is a opportunity in nursing students, when they're going through the first year of nursing school, they are completing fundamentals of nursing, which is basically the core curriculum for the PCA and Home Health Aide Certificate. If we can just tap into those nursing students, we can have an immediate workforce, we can have a valued workforce, and we can start the nursing students to begin their opportunities in home care, and really starting to change the perspective that they have. Thank you.
Christine? Just touch it very lightly.
One thing you could do is to start talking as you start talking.
There it is. Okay,
there you go.
I'm on. Senators, thank you so much for being here for the long haul. We understand that it's been an extraordinarily long day and hopefully very productive. We're grateful to you for working together to hear about this topic and for giving me the opportunity to provide testimony. My name is Christine Pellegrino. I'm a former member of the New York State Assembly, a mom and a daughter to aging parents. I am currently the board president of All Things Home Care, a not-for-profit dedicated to improving the lives of the elderly, the infirm, and the disabled. All Things Home Care seeks to work collaboratively and creatively to support and elevate the role of home care workers to improve their quality of life and ultimately make a difference in affecting patient outcomes. We believe that everyone should be able to receive the care that they deserve to live a life of dignity, which makes the shortage of home care workers a real crisis for parents, patients, their families, and ultimately for us all. The shortage of caregivers creates a cascading effect on families and communities, detracting from the overall productivity of the local workforce. When cases can't be regularly staffed or caregivers unexpectedly miss their assignments, care, as we've heard often today, for the patient falls to a loved one who must choose between their family member and their job. We cannot ignore the pending workforce shortage any longer, as the crisis is already upon us. Unstaffed cases and missed visits are a direct result of some of the various issues home care workers face, and I'd like to talk about that a little bit. Namely, home care workers face significant barriers that limit their participation in the workforce. It's often said that it is expensive to be poor. Often, home care workers rely on public transportation. Now, if you've ever been to or been forced to commute by public transportation anywhere in the suburbs of New York, particularly on Long Island, you know how woefully insufficient our suburban public transit system is. Furthermore, roughly 25% of Long Island patients live in areas that are deemed hard to staff because they are not accessible to public transportation, thus resulting in a situation where the patients who need essential care in their home have great difficulty receiving it. And so, the intersection of a subpar public transit system and low wages means that workers must choose between spending their personal time on a labor-intensive, hours-long, exhausting commute, the unaffordable cost of rideshare options, or simply not working at all. The reality is that suburban home care workers may be forced to accept fewer assignments than they could because of their low pay, thus magnifying this crisis. Our organization, All Things Home Care, has launched a private transportation initiative for caregivers who need a ride to work because it gives the caregiver the ability and the incentive to accept work, and importantly, they are able to keep more of that money in their pocket. Therefore, All Things Home Care is calling for the historic investment in initiatives that offer a broad range of support systems for essential workers. We also, as many have, support fair pay for home care legislation because we believe that those who provide essential care should not be relegated to a lifetime of poverty. We support Senator May's Home Care Jobs Innovation Fund and support appropriation of the $15 million immediately from the Federal CARES Act funding for initiatives like our home care worker transportation initiative, as well as funding for childcare, broadband, cellular service, and other workforce-related expenses. This innovation fund will create jobs in the human service sector, such as drivers and childcare providers, and we encourage the unionization of those workers as well. Finally, in order to support home care agencies, often locally owned small businesses who are themselves significant job creators, we call for an industry-wide pay rate standardization and a raise to the reimbursement rate to include the overtime pay and holiday pay for caregivers. Agencies, as we've heard today, operate on very small profit margins and need to be compensated in a way that allows them to, not just to operate, but to thrive. Thank you.
Thank you.
Okay, I think you hear me. I'm Faggy Horowitz. I'm with Caring Professionals. We are New York City-based LIXA, a home care agency, but I'm going to talk about all the stakeholders in this conversation, and at the end, there's going to be somebody who has not really been mentioned. The first set of stakeholders is obviously the Medicaid patients, the consumers, and their families. They need HHAs, PCAs, and personal assistants who will show up and do show up and provide quality continuum of care. The silver tsunami of baby boomers is upon us, and the actuarial numbers are really no secret. The second set of stakeholders is obviously the caregivers. Fewer are performing this dead-end job, it's not insulting, but it's factual, at low rates of pay. And wage improvement is a critical need. And we also need career pathways, and I think what you just mentioned about bringing in the nurses, the nursing students, is so true. I went into a nursing school, because I was a board member a couple of years ago, 2 or 3 semesters. Nobody knew what I was talking about, even the dean. And they weren't really interested. But education and teammanship will make it, across the healthcare sectors, will make a difference. I come out of the workforce world, that was my start in nonprofits. There are many creative pathways and creative models that do exist to bring people up. But I want to touch on something that hasn't been mentioned. We are in the midst of a large labor shift intensified by Corona. And last week's New York Times reported that wages and opportunities for some low-wage workers, such as those in the restaurant industry and those in online retail, are rising since the pandemic. Obviously, people want to go out to eat now and have bought a lot online. Wait staff can move up to managers at restaurants, for example. And they do mention home health care. But in our system and in our industry, workers cannot move up without more training and additional credentials. The third set of stakeholders are the LIXAs and the FIs, the providers. We cannot give the workers the wages they deserve with our shrinking margins. There are now increased regulations and safety precautions for which we were not reimbursed. And there are administrative costs to the work that we do. We are not capitalists soaking up government money and exploiting workers. Years back, we had a 2 to 3% profit margin. That is long gone. The margins are now minuscule. And we are a union shop. We pay the top dollars. We have not had 24-hour shifts in years. And there's one more thing I wanted to mention here, but I forgot it. Historically, even when money did come down from the state for minimum wage increases on the LIXA side and wage parity on the CDPAP side, no measures were put in to ensure that the personnel rates, you know, the unemployment, the workers' comp, the payroll taxes, et cetera, and general administrative costs were included in the rates paid to us providers. The managed care plans decide which providers get increases and how much. Providers are depleted, forced to manage more things on less dollars. Obviously, New York State is the fourth stakeholder group. New York State, and I remember this, was once a trailblazer in allowing moderate income seniors and people with disabilities to access Medicaid. Does New York State still care about this sector? There is now a look-back period of 2.5 years, and there are other barriers to long-term care services. And now we come to the fifth group of stakeholders, the managed care organizations which operate without transparency. They are paid with Medicaid dollars and have a very big stake in the existing system. Managed care organizations normally work on a capitation basis. It's a simple equation, but capitation does not work for long-term care. You can't make money by investing in the health of people who require long-term care. Their care needs increase, and there are no savings to be had. It doesn't work. But the managed care organizations get the increases for home care without accountability for contracts and the rates paid to providers. Take a look at the plan submitted to CMS last week for how to manage the additional FMAP money coming down. The managed care organizations are going to be devising the accountability measures for the money they receive. This is accountability? Why are they stakeholders in the welfare of poor people with disabilities and seniors in New York State? One final point. There are two main differences between these two populations right now. And I know, wait, I wanted to talk about the workforce. The workforce issues in home care are similar to those in the OPWDD world. And I know because I'm a 25-year veteran board member of a medium-sized OPWDD agency in Brooklyn. There are two main differences. Number one, just this final point, which no one mentioned. No new barriers have been erected recently to bar eligible people from services in the world of developmental disabilities. Two, there are no managed care organizations in the LDD universe. I rest my case at 5 minutes exactly. You know what you need to do. You are our champions. Keep on fighting for us.
Okay, thank you. And finally, Jim.
Hi, I just want to echo the thank you to those that hung in there to the end with us. I think it's very important that we do this. My name is Jim Hurley, and I own Home Instead, which is a licensed home care agency here in the Capital District. We employ about 300 caregivers. I'm the chair of the New York chapter of the Home Care Association of America, and I'm a member of the New York State Healthcare Providers and a board member of the Capital Region Workforce Development Board. And I've chopped a whole bunch out of here. There are a number of reports that I used to put this together, and I'll get you those reports by the end of the week. In those reports, there are recommendations and strategies that everyone seemed to agree on. The strategies to improve recruitment of new caregivers, reduce turnover, and ensure that a stable, high-quality workforce will be available to care for older adults with long-term service and support needs. And I'm going to touch on just two of those strategies. One is a public campaign which could help expand the pipeline of potential caregivers by recruiting non-traditional workers to the long-term services field. These workers could include students, displaced workers, and older adults who want or need to work past the age of retirement. We have a good percentage of our workers and our staff who are in their 60s, 70s, or even 80s and find meaningful work and remain productive members of society. Although sometimes there are strict restrictions on what they're able to earn, we have to stop encouraging or incentivizing people not to work. And then home care, healthcare integration. We need to explore a reasonable and sensible expansion of the scope of services that LHCSAs, licensed home care service agencies, and particularly aides, are permitted to provide. Well-trained aides under the supervision of an RN should be able to do more in the home. If we come up with a home health aide can provide care in a home. A certified nurse's aide can provide care in a facility, but those two very similar positions can't work in the other's area. Why? Why not establish a more universal worker to become a direct care professional in nursing homes, assisted living communities, and home and community-based settings? We just need to identify a common set of competencies that this universal aide, regardless of setting, could master and demonstrate. This role should be able to carry their credentials across state boundaries also. That's correct. And that is it.
Wow, well done. Coming in below time. Any questions, anybody? I just want to say thank you for the really important work you're doing to try, and the good ideas. I'm going to, did you submit your testimony in writing? I don't think I got it here, but I'm looking forward to seeing some of these really good suggestions that you have, and investments in things like transportation are critical, and the nurses, you know, rotating students into home care seems like a brilliant idea too. So thanks so much for bringing all this forward. And
Okay, thank you.
for your work. And the last panel. All right.
Not least, but
Not least. So we have Christy Johnston, Matt Hederick, and Veronica Charles. And you guys should win a prize for being here till the bitter end.
Thank you for being here until
Yeah.
the bitter end.
Well, and thanks to everyone who stayed, actually. Here.
Yeah.
So, Christy, you want to kick it off?
Yep. And the mic is on, so that works well. So good afternoon, almost evening, and I just want to thank you for convening a hearing dedicated to such an important and challenging topic, and for your patience in sitting through all of the conversation today. My name is Christy Johnston, and I work for Premier Home Healthcare Services. And my remarks today, which have been cut down and edited,
excuse me 1 second.
Yeah.
Folks, if you could take the speaking outside, please, because we can hear it down here. Thank you so much. That's it. Thank you. Please continue.
And my remarks today reflect those of a number of additional LHCSAs that share similar characteristics. Together, our organizations care for tens of thousands of Medicaid beneficiaries in the 5 boroughs and surrounding counties. And we employ tens of thousands of home health aides who are members of 1199 SCIU. Our organizations invest in training, technology, and career growth for our essential home health workforce to ensure our patients receive the highest quality care. And we endeavor to collaborate regularly with our union partners on issues and initiatives that impact our workforce. It's been a long day, and prior speakers and your questions have covered many of the critical issues, so I will just hit a few points important to reinforce at the end of the day. We are at a critical juncture. We have a crisis going on in home care right now, but we also have an unprecedented funding opportunities for home care. And you all, your colleagues and the executive, ultimately must decide how much of an investment the state will make to address the home care workforce challenges and how accessible the state wants to make home care services to its citizens. New York has always been supportive of home care, sooner and at greater levels than other states, but has not consistently continued to invest in home care. So a couple of the issues. Workforce, there is a growing workforce home care shortage crisis, but it existed before the pandemic. It's even greater now and has spread throughout the state. New York City, which was not touched as much by shortages in prior years, I can say is now in a full-fledged staffing crisis. And as we emerge from the pandemic, thousands of home care workers have left the market and many have still not returned. And I think one piece relative to the issues with that is the lack of staff drives an incredible overtime expense to make sure continuity of care exists, patients are cared for, and as we kind of move people around. During the pandemic, it was critical because we wanted to ensure the care was there and people were able to remain at home. Now that we're moving out of the pandemic, it's because we don't have workers. Infrastructure, the state's home care infrastructure increasingly is unstable. It's a system designed to keep individuals out of congregate care settings, but it's been neglected and is fraying as a result of decades of Medicaid cuts with simultaneously increasing wage and related costs. It will come as no surprise that it's been exacerbated after the pandemic. This sector of the healthcare system received no additional funding support to deal with any of the pandemic-related issues. And I will say, we work in multiple states. Other states did invest. They provided access to grant funding. They increased rates for increases to wages. New York didn't do that. So it's an additional struggle on top of the other challenges. Without question, home care workers are the backbone of this healthcare sector. They are the eyes, ears, and hands in the home, and they contribute significantly to controlling healthcare costs and improving quality of patients' lives. To that end, we are grateful to you and your colleagues in the legislature for leadership in proposing solutions to address these critical issues and working collaboratively. Our group has been supportive of increasing wages and other approaches to increase the amount of pay home care workers can take home through bonuses, recruitment incentives, and fair reimbursement to home care providers. We believe that the best way to accomplish this is by a development of regional base rates, similar to the fair pay for home care bill approach. And I want to emphasize that minimum hourly regional reimbursement rates, it is about wages, it is about benefits, but the cost of delivering an hour of care is more than just that wage and benefit. It's payroll taxes, insurance, paid time off, training time, travel time, overtime, spread of hours, holiday pay. It costs us $1 million plus a year to pay time and a half and double time for holiday pay. That's not reimbursed by MLTCs or the Medicaid program. And those are wages that workers deserve. And that's not even managing the regulatory requirements. QI-VAP funding is critical to our work as well, and it helps target things to our workforce. There are myriad other approaches to improving aspects of the home care workforce recruitment, retention challenges, training flexibility, social determinants of health support for workers, enhanced training, career, and ladders, among other things. I'd love to talk about that endlessly because that's what we want to be focusing on, but it's really about ultimately investing in wages and benefits for this workforce. Fortunately, there's funding opportunity at the federal level, and we look forward to working with you to help secure that for New York.
Great, thank you. Matt?
Good afternoon, Senators. Thank you for waiting for all of us today, and especially for some of us. I came up from Long Island, so it's a 4+ hour ride. So when the meeting cuts off at 5 o'clock, you worry that you made the trip. So I appreciate everybody's time today and getting to work with you. My name is Matthew Hederick. I serve as the administrator of Gerwin Certified Home Health Agency, part of the Gerwin healthcare system based out of Comac, Long Island. In addition to operating both a LICSA and a CHA, we serve as a 460-bed nursing and rehab center that provides long-term care, ventilator care, on-site dialysis, medical and social model daycare. We have an assisted living facility that's across the street. We do memory care. We do the entire care continuum, and soon after the independent building is finished, we will be one of the few CCRCs on Long Island and offering diverse care options for people out on the eastern portion of Suffolk County. So I wanted to come and speak today on behalf of not just the home care agency, but on the whole care continuum and seeing what we're experiencing right now with what is truly a workforce shortage of not enough nurses, not enough aides, not enough therapists, not enough CNAs. It's been very dire straits between COVID, between other employment opportunities out there. So, we're looking forward to working with you in the future on what we can do. There's been a lot of discussion today. Obviously, a lot of the core issues have already been addressed. There are a couple of things that I would like to suggest in terms of efficiencies that are relatively cost neutral. So, for example, home health aides are required to maintain a certain number of in-service hours every year. They have to do at least 12 hours. The agency is responsible for monitoring those in-service hours. So if an aide works for Matt's Home Care and then also works for Senator May Home Care, she's required to take those same in-service hours for both agencies. There should be some sort of efficiency created within the health commerce system or somewhere along the way where those hours can be recorded on an agency basis and then prorated, which will also allow for those caregivers to spend more time in the field versus time in the office maintaining those sorts of criteria that are required. In addition to that, there are training programs that are certified by the Department of Health. There are training programs that are certified by the Department of Education. There should be some look into creating either a universal worker program or how can we allow these trained caregivers to work across different settings, whether it's a CNA in the nursing home, a home health aide that's in the home, a resident care assistant that's at the assisted living, a direct support professional, whatever it may be called, there may be some opportunities in looking at aligning these caregivers and the training and the experience they have in order to be able to service multiple populations, not just for one provider like Gerwin, but for multiple providers out there, and to allow them different opportunities there. In addition to that, one thing I did want to mention that has been a positive also is Gerwin had created a position called the resident care assistant, which was an extra set of hands that we utilized in the nursing home in COVID. This was untrained staff that would be able to at least triage call bells, help with food deliveries, things of that nature, non-clinical hands-on or non-clinical tasks to allow our other caregivers to provide that care. We'd be hopeful in looking at the staffing ratios that something like that would be allowed to be included in that hourly fix or that hourly range of care that's going to be required come January. There's been a lot of horror stories today, but one of the things that I did want to mention is, Gerwin is a CMS-rated 5-star facility. We spare no expense when it comes to employee benefits. We offer wages that are above and beyond any of our competitors that are out there. In addition to that, we already meet all of the staffing requirements that are going to be required of us. We are a quality provider that believes in putting the patient at the center of our care, and then everything else will fall into place. When we get calls from for-profit providers that are inquiring as to what we're doing differently and how we're operating in this environment, that's somebody that should be included at your table in terms of these discussions and moving forward. So with that, all I wanted to say is before the pandemic, people had already preferred to age and receive care in place in familiar surroundings whenever possible. This has only grown truer in the post-pandemic world as many people look to bypass facility-based care completely, and new federal programs such as SNF at Home, Hospital at Home continue to showcase the ability of home and community-based services to deliver higher levels of care in a safe and efficient manner. With the lessons we've learned regarding infection control and the capacity of the overall healthcare system, an investment into home and community-based services is money well spent, as it's been repeatedly demonstrated to be a cost-effective patient care solution at a variety of levels that's not limited by walls or the number of beds. So, thank you.
Thank you. And last, but definitely not least, Veronica.
Thank you so much, Chairwoman May, Chairman Rivera, and Senator Serino, for sticking it out until the end. And I greatly appreciate everyone's thoughtful testimony today, as well as your thoughtful comments and considerations. So I do want to keep my testimony brief. I will be speaking primarily towards private duty nursing, which is a specific type of nursing services that Maxim provides that really focuses on pediatric patients, which are sometimes left out of this equation. So my name is Veronica Charles. I am the Director of Government Affairs at Maxim Healthcare Services. We're a national provider of home health care services, but we do have 7 offices in the state of New York. We care for a little over 1,700 individuals throughout the state. That's, again, primarily offering private duty nursing services as a LICSA, certified home health agency, but we also are a fiscal intermediary in the consumer-directed personal care program. Maxim has been a long-standing advocate for the New York home care workforce, and we appreciate everything we've discussed today, and I agree with so much of what my colleagues have had to say. Private duty nursing is a continuous skilled nursing care provided in the home for medically complex and vulnerable pediatric patients, as well as older adults or individuals that may have had a traumatic brain injury, require a tracheostomy, ventilator care. But these are really individuals that suffer from a disability that they require a nurse around the clock to stay alive. So, unfortunately, many New York children and older adults with these special needs are not receiving enough nursing services in the home or able to access these life-saving services for the reasons you've heard today, primarily stemming from low Medicaid reimbursement rates from Medicaid, as well as the managed care organizations, which hinders comprehensive recruitment and retention strategies, and that has definitely been true throughout the COVID-19 public health emergency. The pandemic has made the delivery of our specific PDN services more difficult for nurses and costly for agencies, as neither our agencies nor our clinicians have received enough financial support from the state or the federal government associated with COVID that nurses in other industries have received. Offering additional funding to support PDN wages will assist home care providers in improving quality while also containing healthcare costs. As we've heard today, it's incredibly costly to keep individuals in the hospital, and it's inappropriate to keep these children in hospitals. The cost of 16 hours of PDN services is approximately 1/3 the cost of a day in the hospital. So obviously, we'd like to work towards avoidable hospital utilizations and help save the state of New York precious Medicaid resources. And while Medicaid rates in the state are lower than necessary to maintain this robust workforce, there's a lack of a PDN rate floor in New York, which makes it possible for MCOs to pay less than Medicaid, forcing clinicians and agencies to cut our costs when we're reimbursed less than what is guaranteed by Medicaid. By establishing a PDN rate floor for MCOs, hopefully the state will be able to provide providers with an opportunity to recruit and retain workforce, and we definitely want the most qualified caregivers for these complex and high acuity children and older adults. Lastly, it's important to note that LHCSAs have a harder time recruiting and retaining nurses for patients who are over the age of 23 due to the wage cliff created by the Medicaid pediatric rate enhancement for medically fragile children. We recognize that this was likely unintentional, but what happens is because of this rate enhancement, when a child turns 23 with a severe disability, the nurse loses roughly 30% of their pay due to the lack of the enhancement that was attributed with that case. In order to protect these patients from losing their lifelong nurses in many circumstances, and in an effort to help support this ongoing workforce shortage, we do ask that the legislature consider extending that enhancement rate for medically fragile children over the age of 23. And lastly, as we look to things that are a little bit different than our skilled workforce, like our unskilled workforce, which I don't like that term, for our personal care assistants, we really ask that we look to looking at these rates as well. That will help personal care assistants across the state, specifically in the consumer-directed program. The CDPAP program has increased access to care for approximately 75,000 New Yorkers statewide, and the importance of this program was obviously further emphasized during the pandemic. Given the work that Maxim and other FIs have put into running a highly successful operation within CDPAP, I would be remiss if I did not voice our concern regarding the ongoing RFO process that many of my colleagues have brought up that have threatened to drastically reduce access to FIs and take away job opportunities from these numerous personal care workers. In order to increase the unskilled workforce in home and community-based services, we ask the legislature work to preserve this program by allowing good faith FIs to continue to operate in this program, with specific attention to FIs that practice areas of excellence and promote easier access to job opportunities. Thank you all so much for your time. We greatly appreciate it, and we look forward to working with you in the future.
Thank you. Any last comments or questions?
Last comment I'll say, the gentleman that came from Long Island, you know, it being the time that it is, there's a couple of great restaurants in the neighborhood, so maybe you want to just stay the night, take off tomorrow morning or early, just as a suggestion, because it's going to be a long drive. But in all seriousness, thank you for everyone for being here, particularly there's obviously some very key, I think it was, what was it, the one, oh yeah, we need to make sure we fund it more adequately, that we provide a more stable revenue source, that we provide a more, that we provide better conditions for these folks who perform an incredibly important job, and which is only going to become even more necessary in the years to come, and that we have an opportunity, as I believe there was a lady just said it very recently, there was an opportunity because of the crisis that we are in. We are in a crisis, we shouldn't waste it, I think it was as she said. I believe, I always said that we have an obligation at times like this to actually really invest, to really think in the long term and not just think, as we said before, penny wise, pound foolish, but really, a couple of great places I'll suggest.
Are we going to dinner?
I'm going someplace, I'm just saying you should too, and don't drive out there too long.
I just want to say thank you to everybody. Everybody that has come before us today really cares about what they do. We are headed towards a crisis, and it has to be addressed. Like I've said many times over through the years, our seniors and our vulnerable populations have kind of been like an afterthought in our staff, and it's something that we really have to work on now. So I really appreciate everybody's testimony today. Thank you.
And let me conclude with the same, just gratitude to you, to everybody who's been here. We talk about this crisis, but that means even more that those of you who are still doing this work are doing it out of love and commitment and passion, and it is that much more important that you keep doing what you're doing and that we find ways to support you in it. So thank you to everybody who has tuned in here, who has been here in person. Thank you to the staff who have been amazing and keeping this running, all of you. And I'm just grateful to all of you and to my colleagues for sticking with it, but also the ones who have been here in the course of the day. So thanks again. The hearing is officially over now. Thanks.